Very good morning. Just. Very good morning. Can you hear me properly? I hope everything is fine. Am I audible? You can hear me. I'm audible. Okay. Very good morning to all of you. 17 days before exam, shivering, done with almost all tests and discussions, just few subjects left. 26, you are having OBG test. You have already started revising, and in 2-3 days, a lot can happen, and we will make it happen. Without wasting any more time, let's begin our revision class today for Ops Gynae. I'm starting with menstrual cycle. I would request you to please keep your notes with you, which I know you already have with you right now. You have your notes with you, and I will start revising the thing, and we will move along with the notes. And I will try my best to move with the notes. I won't open my notes. I will speak looking at you. You keep on looking at notes. Fine? And wherever required in between, I will show you the images. Although I know you have all the images in your notes, whatever are required. Fine. So I'm beginning with menstrual cycle. Listen to me. We have to make it a quick revision of whole Ops Gynae. Again, I'm requesting you, please start looking at your notes as well and just look at me too. I won't open my iPad notes or I won't open my iPad. Wherever required in between, I will just take the image and show it to you once again. Fine. So menstrual cycle begins from hypothalamus. Wherever the MCQs are asked, we will just discuss this is a question, this is a question, this is a question. All are fine. Thank you, thank you, thank you, thank you, thank you. Fine, 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 sir. Go ahead, sir. Go ahead, sir. Looking smart, sir. Thank you, thank you, thank you. I'm always smart. Okay. Chalo ji. Uh, okay. Menstrual cycle begins from hypothalamus. Hypothalamus secretes gonadotropin releasing hormone. Just pick up your notes. GnRH. Fine. Which acts on anterior pituitary, which secretes follicle stimulating hormone, FSH, which is acting on which ovarian cells? This is the question. Which ovarian cells? Ovarian granulosa cells, which secrete estradiol and inhibin B. Which secrete what? Estradiol and inhibin B. What this estradiol is doing? This estradiol, one thing, causes proliferation of endometrial glands. This is why first half of cycle which phase? Proliferative phase. What else it is doing? It is giving positive feedback to LH. So LH starts increasing. LH starts increasing. There are how many actions of LH before ovulation? 3 actions. Action number 1, via LH surge and LH peak, it causes ovulation. LH surge question, MCQ. Meaning of LH surge is sudden rise of LH. Another MCQ. LH surge is attained how much time before ovulation? 24 to 36 hours before ovulation. Best answer, 36 hours. Meaning of LH peak? Minimum amount of LH required for ovulation. Another MCQ. How much LH is required for ovulation? Minimum 75 nanogram per ml. Another MCQ. LH peak is attained how much time before ovulation? 10 to 12 hours. Surge, 24 to 36. Peak is attained 10 to 12 hours. Minimum LH required for ovulation how much? 75. Please remember the units. It is not kilogram, it is not milligram, it is not gram, it is nanogram per ml. And 1 nanogram is 10 to the power minus 9 grams. We know that. Fine. And how much estradiol is required for LH surge? Because estradiol is causing increase in LH. So minimum estradiol required for LH surge is 200 picogram per ml, which should sustain for at least 48 hours. And 1 picogram is 10 to the power minus 12 gram. 1 nanogram 10 to the power minus 9 gram. 1 picogram 10 to the power minus 12 gram. So this is happening ovulation via LH surge and LH peak. This is one action of LH. Second action of LH before ovulation is it is acting on which cells? Theca cells. FSH was acting on which cells? Granulosa cells. LH is acting on which cells? Theca cells, which secrete androgens. And androgens are converted to estrone. Estrone is E1 or E2? E1. And estradiol was E2. Estradiol was secreted by which cells? Ovarian granulosa cells. Fine. And this LH is acting on which cells? Theca cells, which are secreting what? Androgen, which are converted to which form of estrogen? Estrone E1. This process is called aromatization. Maximum aromatization occurs in which tissues? Adipose tissues, fatty tissues. This is why. Which female has more amount of estrogen? Thin female or obese female? Obese female. This is why all estrogen related disorders will be more common in which female? Thin female or obese female? Obese female. So endometriosis more in obese female. Fibroids more in obese female. Endometrial cancer more in obese female. So examiner will trap you with thin, but we know motive female, more estrogen related disorders and complications. Fine, beta. Then what else is happening? LH causes axon, granulosa cells also, little action, which release progesterone, which cause mid-cycle FSH surge. And I will show you here one image which is important and which can be asked in examination. I'll just show you that image where the examiner will point the arrow and will ask you, what is this peak called as? Fine. Now, ovulation occurs. After ovulation, ruptured follicle is called corpus luteum. Maximum activity of corpus luteum is on which day after ovulation? 8th day. So if it is a regular 28-day cycle, it is which day of cycle? Day 22. So maximum progesterone will be on day 8 post-ovulation. If ovulation has occurred, how much should it be? It should be at least 3 nanogram per ml. And when levels of progesterone are at least 3 nanogram per ml, it start giving negative feedback to LH. What LH was doing? LH was supporting corpus luteum. 2 MCQ beta, 2. Non-gravid corpus luteum is supported by LH, while gravid corpus luteum is supported by HCG, that is human chorionic gonadotrophin. Fine. This corpus luteum secretes 3 hormones in non-pregnant female, while 4 hormones in pregnant female. 3 hormones in non-pregnant females are estradiol, progesterone, and inhibin A. And fourth hormone, which is specific to pregnancy, is relaxin. So there are 4 hormones from corpus luteum. Main hormone, predominant hormone from corpus luteum is progesterone. Predominant hormone from corpus luteum is progesterone. And what is the action of progesterone? It holds endometrium. Second action, secretory changes. Secretory changes mean secretion of glycogen and lipids in endometrium, which are stored in tiny numerous vacuoles in liquid form. Third action is vasodilatation. So these are the 3 actions of progesterone. Now what is happening? When there is negative feedback to LH, LH falls and it is not able to support corpus luteum. So corpus luteum start degenerating. And when corpus luteum degenerates, all the hormones secreted by corpus luteum will start declining. Main hormone was progesterone. It was holding endometrium. So when progesterone is falling, will it be able to hold endometrium? No way. And endometrium will start shading off. What else is happening? Because of fall of progesterone, an enzyme is released that is called metalloproteinase, which causes ischemic necrosis of endometrium. And due to fall of progesterone, there is release of a prostaglandin PGF2 alpha, which causes myometrial contraction and endometrial peristalsis. So all these things are causing shading of endometrium. Everything is written word by word in our notes. Now how it is expelled out? It is expelled out by myometrial contractions and endometrial peristalsis. It is converted to blood by the process fibrinolysis. And this blood which is coming out is mainly, of course, due to apoptosis, it is mainly arterial blood. So MCQs asked would be, inhibin A is predominant in which phase? Secretory phase. Inhibin B is predominant in which phase? Proliferative phase. Non-pregnant corpus luteum is supported by LH. Pregnant corpus luteum is supported by HCG. Fine. And how ovulation occurs? Via LH surge and LH peak. What is E1? Estron. What is E2? Estradiol. E3 is estriol and E4 is estetrol. These E3 and E4, they are specific to pregnancy. So which estrogens are specific to pregnancy? E3 and E4. That is estriol and estetrol. What is the main estrogen in a reproductive female? E2, that is estradiol. Overall, most potent estrogen is E2, that is estradiol. How much is the rate of growth of follicle? 2 mm per day. Size of dominant follicle? 14 mm. Follicle ruptures at what size? 20 mm. Fine. Proliferation of endometrial glands occurs under influence of which hormone? Estrogen. Secretory changes are caused by which hormone? Progesterone. Everything is MCQ. All these are chocolate questions. Now, what is Mittelschmerz? Pain during mid-cycle. Metal blue is spotting during mid-cycle. They are physiological phenomena. What is the management? Reassurance. Another thing, third thing is premenstrual syndrome. Premenstrual syndrome approx 5 to days before menses. कब होता है बेटा? Approx 5 to days before menses. Most common cause of premenstrual syndrome? Not known. Idiopathic. If idiopathic is not given in option, low levels of serotonin. What is the drug of choice for premenstrual syndrome? Fluoxetine. Done, done. Drug of choice for premenstrual syndrome is fluoxetine, that is SSRI. Selective serotonin reuptake inhibitor. Then how to calculate day of ovulation? We know this formula. 14 days should be subtracted. Suppose this is a 40-day cycle. So day of ovulation would be 40 minus 14. That is 26. If it is a 50-day cycle, how much is the day of ovulation? 50 minus 14, that is 36. So she will ovulate on day 36. Fine. What are the normal parameters of menstrual cycle? According to WHO, cycle length is 21 to 35, old concept. According to ACOG, that is American College of Gynecology, latest concept 24 to 38 days. How much is the duration of flow? 2 to 7 days. Amount, how much is the amount? 5 to 80 ml per cycle. 5 to 80 ml per cycle. And if there is deviation from this, this will be called abnormal duration or abnormal cycle length or abnormal amount of flow. Now, what abnormalities can occur? Oligomenorrhea. Oligomenorrhea is delayed menses. If she is having menses after 38 days. If 38 is not given in option, after 35 days. Most common cause PCOS. Polymenorrhea, if she is having before 24 days. Most common cause PID. Hypomenorrhea, if the amount is less than 5 ml or duration is less than 2 days. Most common cause of hypomenorrhea, Asherman syndrome. Most common cause of Asherman syndrome, postpartum curettage. Other causes, post-abortal curettage and endometrial TB. Then what is the management of Asherman syndrome? What we do? How to manage Asherman syndrome? Asherman syndrome is managed by hysteroscopic adhesiolysis. I will just show you the image. We break the adhesions in endometrial cavity, followed by insertion of balloon catheter, followed by administration of estrogen and progesterone. I will just show you these two images, one from menstrual cycle and one from Asherman syndrome and its management. This is a potential question, beta. This can be asked in examination. Let's have a look at this image. Let's have a look at this image. Your questions would be, this is LH, luteinizing hormone. So what is this peak? Examiner will point the arrow here and will ask you, which peak is indicated by this arrow? This is the LH peak, top one. We know the maximum levels are of LH. The second peak, it is FSH. This is second peak. This is follicle stimulating hormone, FSH. So both LH and FSH, they are maximum during what time of cycle? mid-cycle. LH is maximum during mid-cycle. FSH is also maximum during mid-cycle. So we solved two MCQs. One MCQ, this top peak is LH peak. The second peak is FSH peak. Then another MCQ beta. When estradiol levels are maximum, estradiol levels are maximum. This is the third peak. This is the third one. Estradiol levels are maximum approximately 24 to 36 hours before ovulation because they coincide with LH surge. LH surge depends on estradiol. And how much estradiol is required for LH surge? It should be at least 200 picogram per ml, which should sustain for at least how many hours, beta? 48 hours. Then the very important, two questions are very important here. They usually ask about LH peak and progesterone. When levels of progesterone are maximum in menstrual cycle, they are maximum on day 22 of cycle. If it is a regular cycle, they may frame this MCQ how many days post ovulation if it is a regular cycle? 8 days post ovulation. So levels of progesterone are maximum on which day of cycle, beta? Speak with me. Just speak out with me. They are maximum on day 22 of cycle. Estradiol is maximum 24 to 36 hours before ovulation. LH and FSH both are maximum on mid-cycle. And this mid-cycle FSH peak, mid-cycle surge is due to what? Progesterone. A small amount of progesterone is released before ovulation. We have discussed everything in detail. Now the second image I want to show you is of Asherman syndrome. Look here, what we are doing and what is this Asherman syndrome. This is Asherman syndrome. This is Asherman syndrome. What is Asherman syndrome? Asherman syndrome is formation of fibrous bands in endometrium. Fine. And most common cause of Asherman syndrome is postpartum curettage. Most common cause of Asherman syndrome is postpartum curettage, beta. And what is the, so three chocolate questions, beta. Most common cause of hypomenorrhea, Asherman syndrome. Most common cause of Asherman syndrome is postpartum curettage. Management of Asherman syndrome, I'll show you the image. Management of Asherman syndrome is hysteroscopic adhesiolysis. Just have a look here. This is the hysteroscope, beta. This is the hysteroscope. This instrument is hysteroscope. I will take an image session along with CCD or chanting session, and in that image session we will discuss all the images of obs-gynae which can be asked in examination. So after this session, today's revision class, there will be a test and discussion session. Then I will take a separate clinical case discussion, CCD session of approximately 2 to 3 hours, where we will, but that CCD session I will take after your test and discussion, so that you are able to revise everything till 26. We are having test on 26. The idea behind it, today is 24, 25th, 26th, you revise obs-gynae properly. There will be fair number of questions from obs-gynae. I am repeating again and again. Revise it properly in these 3 days. Please, please, please be focused on obs-gynae in these 3 days till the test. Give the test properly, then we will have test discussion, then you will have obs-gynae on the tips. Then we will have clinical case discussion and chanting with the rapid fire round, because you will be speaking out there, because you will prepare, you will revise everything in these 3 days. Fine. Now, hysteroscopic adhesiolysis. How adhesiolysis is done? How do we break these adhesins? This is how we break these adhesins. These are the adhesins. Can you see? These are the fibrous bands. These are fibrous bands in endometrium. So management of Asherman syndrome is hysteroscopic adhesiolysis. We cut them. Followed by we insert a balloon catheter, and then for endometrial proliferation, estrogen. And whenever uterus is intact, we have to add progesterone along with it. So progesterone takes care of side effects of estrogen. Fine. It takes care of side effects of estrogen. Fine. So this was about hypomenorrhea. Now after hypomenorrhea, another menstrual disorder is cryptomenorrhea. What is cryptomenorrhea? Cryptomenorrhea is hidden menses. You can see. This is how a normal vagina and vulva, and you can see there is the opening here, vaginal introitus. This is the opening. This is normal opening here. This is normal opening in hymen and through which menstrual blood comes out. If this opening is absent, will anything come out? Look here. If this opening is absent, can anything come out? No way. This is imperforate hymen, as you can see. This is imperforate hymen. There is no perforation, so menstrual blood is not coming out. This is cryptomenorrhea. Cryptomenorrhea is hidden menses, and examiner will ask you what is the most common cause of cryptomenorrhea. Most common cause of cryptomenorrhea is imperforate hymen. It's closed. Imperforate hymen. It's closed. Other causes of cryptomenorrhea are transverse vaginal septum and vaginal atresia. Then what are the steps? What will be your questions? A 20-year-old girl presents with primary amenorrhea, normal secondary sexual characters, and cyclical pain. Cyclical pain means pain at the time of menstrual cycle. Why she is complaining of pain at the time of cycle? Because nothing is coming out from here. This is the reason for this cyclical pain. So primary amenorrhea, normal secondary sexual characters because her ovary is normal, which is secreting normal estrogen. So breasts are normally developed. Fine. But cyclical pain, that gives you a clue that this is the case of imperforate hymen or a transverse vaginal septum or a vaginal atresia. The most common cause of cryptomenorrhea is imperforate hymen. Now, can you see this dense bluish blood? Examiner can give you one more clue. And on per speculum examination, if you do a per speculum examination, you can see a tense bluish bulge. This tense bluish bulge is due to collected blood inside. Now, what is the next step? We do a per rectal examination, PR. And what will be revealed in this per rectal examination? Fullness. And then we immediately jump over to ultrasound. Please go along with your notes. Please go along with your notes. I am trying my level best to speak word by word whatever is written in our notes. Fine. When you do an ultrasound, what will be the ultrasound finding? This collected blood will be seen on ultrasound. First of all, this cervix and vagina will be filled up. First of all, this cervix and vagina will be filled up with this blood. Do you remember? This is the urinary bladder. This is the transabdominal ultrasound. Fluid appear black in ultrasound. This is anterior wall of vagina. This is anterior wall of cervix. This is anterior wall of uterus. This is fundus. This is posterior wall of uterus. This is posterior wall of cervix. And this is posterior wall of vagina. So this is vagina, this is cervix, and this is uterus. And fluid appear black in ultrasound. So you can see the cervix and vagina, they are filled with fluid, that is blood. So this is called hematocolpos. When blood is filled in cervix and vagina, this condition is called hematocolpos because nothing is coming out. So firstly, there will be hematocolpos, and later on this uterus will also be filled with blood. And when uterus is also filled with blood, this condition is called hematometra. So first thing is hematocolpos, which is followed by hematometra beta, which is followed by hematometra. Uterus is also being filled with blood. So this is hematometra. So hematocolpos, which is followed by hematometra. So what is the sequence of ultrasound findings in cryptomenorrhea? Hematocolpos, hematometra, then fallopian tubes, hematosalpinx, and finally it spills in peritoneal cavity, that is hemoperitoneum. So a 20-year-old girl presents with primary amenorrhea, normal secondary sexual characters, and cyclical pain. The fourth clue may be tense bluish bulge. What is the next step? Per speculum examination. What is the next step after PS? Per rectal examination. What is the next step after per rectal examination? Ultrasound. What is the correct sequence of ultrasound findings in cryptomenorrhea? Hematocolpos, hematometra, hematosalpinx, and hemoperitoneum. Now, how to treat this condition? There is obstruction. Very important. Cryptomenorrhea is very important. What is the management for imperforate hymen? Criss-cross incision or diagonal incision over hymen. Look here. If this is like this, what we have to do? We have to give a criss-cross incision here like this. Once we cut it, criss-cross, whatever has been collected inside will come out. So management of cryptomenorrhea is diagonal incision or criss-cross incision over hymen. Diagonal or criss-cross incision over hymen. Fine. This is how we treat this condition. Just a moment. I'll just show you that image of that incident over hymen. So this is a crisscross incident, as you can see. This is how it is given and everything comes out. So management of cryptomenorrhea, management of imperforate hymen is crisscross or diagonal incident over hymen. And if it is a vaginal septum, we take out this septum. This is called septal resection. So most common cause of hypomenorrhea, Asherman syndrome. Most common cause of Asherman syndrome, postpartum curettage. Most common cause of cryptomenorrhea, imperforate hymen. Most common cause of oligomenorrhea. What is the most common cause of oligomenorrhea? What is the most common cause of oligomenorrhea? PCOS. Most common cause of polymenorrhea, PIT. Let's discuss menorrhagia. Menorrhagia is excessive. Menorrhagia is excessive menstruation. Excessive menstruation means excessive bleeding. Excessive bleeding. Excessive bleeding. Excessive bleeding means how much is the range? 5 to 80 ml. Range is 5 to 80 ml. And if this blood loss is more than 80 ml or duration is more than 7 days, this is called menorrhagia. And most common cause of menorrhagia, just look in your notes. Just look in your notes. Most common cause of menorrhagia is uterine fibroid. There is a word called dysmenorrhea. What is dysmenorrhea? Pain at the time of menstruation. Be very careful. Dysmenorrhea is pain at the time of menstruation. Mittelschmerz is mid-cycle pain. Mittelblue is mid-cycle spotting. Management of both Mittelschmerz and Mittelblue is reassurance. Fine. How things happen, we have discussed in detail in our classes. So Mittelschmerz, Mittelschmerz, mid-cycle pain, Mittelblue, mid-cycle spotting, management reassurance. Drug of choice for premenstrual syndrome, fluoxetine. How to calculate day of ovulation? We have to subtract 14 days from cycle length. Inhibin B is predominant in proliferative phase. Inhibin A is predominant in secretory phase. Rate of growth of follicle per day 2 mm. Size of dominant follicle 14 mm. Follicle ruptures at what size? 20 mm. Fine? Clear. Pregnant corpus luteum is supported by HCG. Non-pregnant corpus luteum is supported by LH. Predominant hormone secreted by corpus luteum is progesterone. Whether it is pregnancy or non-pregnant stage, main hormone secreted by corpus luteum is progesterone. Fine, beta? Now, dysmenorrhea, pain at the time of menses. This can be primary dysmenorrhea or secondary dysmenorrhea. Primary without organic pelvic pathology. Secondary with organic pelvic pathology. Only question from this definition, most common cause of secondary dysmenorrhea, endometriosis. Done. Primary dysmenorrhea, most common cause is genetic. Genetically, there is some problem where levels of PGF2 alpha are high. So, drug of choice for primary dysmenorrhea, mefenamic acid. Second MCQ, if primary dysmenorrhea is not relieved by mefenamic acid, what is the next step? OCP, oral combined pill. Why, how? We have discussed everything in detail in our classes. Drug of choice for primary dysmenorrhea, mefenamic acid. If primary dysmenorrhea is not relieved by mefenamic acid, what is the next step? Oral combined pill. Now, if primary dysmenorrhea is not relieved even by oral combined pill, what is the next step? Surgical dilatation of cervix. Surgical dilatation of cervix or presacral nerve ablation. Now, after dysmenorrhea, amenorrhea. What is amenorrhea? Amenorrhea is absence of menses. Amenorrhea is a big topic. Let's discuss metrorrhagia and how male and female develop. That's all in few minutes only. Metrorrhagia is irregular bleeding. Menorrhagia is excessive bleeding. Metrorrhagia is irregular. Irregular anytime it can happen. So your question will be, most common cause of metrorrhagia. Best answer is DUB. Dysfunctional uterine bleeding. If DUB, go along with notes. Just keep on looking at your notes. Just keep on looking at your notes. I am trying to move word by word with your notes only. So most common cause of metrorrhagia is DUB. Dysfunctional uterine bleeding. Definition of DUB, irregular bleeding per vaginum without organic pelvic pathology. Without. Fine. If DUB is not given in option, second most common cause of metrorrhagia would be ulcerated endometrial polyp. What it would be? Ulcerated endometrial polyp. Fine. What is AUB? DUB is irregular bleeding PV without organic pelvic pathology. What is AUB? That is abnormal uterine bleeding, irregular bleeding PV with organic pelvic pathology. So if it is without, it is called DUB. If it is with, it is called AUB. What are the causes of AUB? Palm coin classification. P is polyp, A is adenomyosis, L is leiomyoma, M is malignancy, C is coagulation disorders, O is ovulatory disorders, E is endometrial dysfunction, I is iatrogenic, and N is not yet classified. So causes of AUB, palm coin classification. Most common cause of metrorrhagia is DUP, dysfunctional uterine bleeding. Fine. If examiner asks you what is abnormal uterine bleeding, then irregular bleeding PV with organic pelvic pathology. That's all. Now after metrorrhagia, how a male and female develops quickly. Although I think ma'am has also covered in embryology, but I will take 1 or 2 minutes because two important questions are asked from this development. So testis develops due to presence of what? SRY complex. Second question. SRY complex is situated on short arm of Y chromosome. So testis develops due to presence of SRY complex. So if SRY complex is present, which gonad will develop? Testis. Testis has two types of cells, Sertoli cells and Leydig cells. Sertoli cells secrete Mullerian inhibiting factor. The Mullerian inhibiting factor, Mullerian ducts are suppressed. So another question arises, if Mullerian ducts are suppressed, what are the remnants of Mullerian ducts in males? Appendix of testis and hydatid of Morgagni. Leydig cells secrete testosterone. Embryological question. What develops embryologically due to testosterone? Wolffian duct. Second question. What develops from Wolffian duct? Male internal genital organ. That is epididymis, vas deferens, seminal vesicle and ejaculatory duct. Testosterone. So male internal genital organs develop due to by what? Wolffian duct. Wolffian duct develops under influence of testosterone. Testosterone is secreted by Leydig cell. Why Mullerian duct is suppressed? Due to Mullerian inhibiting factor which is secreted by Sertoli cell. If Mullerian duct is suppressed, examiner gets a chance to frame another MCQ. What are the remnants of Mullerian duct in males? Appendix of testis and hydatid of Morgagni. Fine. This testosterone is converted to dihydrotestosterone by 5-alpha reductase. And this dihydrotestosterone is responsible for formation of male external genitalia. Male external genitalia. So male external genitalia develop by what? Presence of dihydrotestosterone. Male internal genitalia develop by Wolffian duct. And Wolffian duct develops under influence of testosterone. Fine beta? Done, 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 done. If SRY complex is absent, which gonad will develop? Ovary. No Sertoli cell, no Leydig cell. No Sertoli cell, so no Mullerian inhibiting factor, so Mullerian duct develops. And what develops by Mullerian duct? Uterus, cervix, fallopian tube, and upper 2/3 of vagina. So female internal genital organs develop by Mullerian duct. No Leydig cell, no testosterone, so no dihydrotestosterone. If dihydrotestosterone is absent, which external genitalia will develop? Female. Very, very important MCQ. Female external genitalia develop due to absence of what? Dihydrotestosterone. And examiner will trap you with testosterone. Similarly, male external genitalia develop due to presence of what? Dihydrotestosterone. Wolffian duct develops by testosterone. Male internal genital organs develop by Wolffian duct. Male external genital organs develop due to presence of dihydrotestosterone. Female external genital organs develop due to absence of dihydrotestosterone. Done, 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 done. Now, what is happening here in females? Epiphoron, periphoron, and Gartner's duct. Why they are developing? Why they are developing these? Because of suppression of Wolffian duct. Because there is no testosterone. Wolffian duct develops due to testosterone. So if there is no testosterone in females, Wolffian duct is suppressed. What are the remnants of Wolffian duct? From upper part of Wolffian duct, that is from cranial part of Wolffian duct, epiphoron develop. From lower part of Wolffian duct, that is from caudal part of Wolffian duct, peripheron develop. And from middle part of Wolffian duct, Gartner's duct develops. Keep on moving along with notes. Now, amenorrhea. Amenorrhea definition is absence of menses. Amenorrhea can be primary amenorrhea, it can be secondary amenorrhea. Primary amenorrhea, she never menstruated. Secondary amenorrhea, she was normally menstruating before, but now she is not menstruating. So primary, she never menstruated. Secondary, she was normally menstruating before. So definition of primary amenorrhea is absence of menses by which age? 13 years, 13 saal. But what you have to see at 13 years? Secondary sexual characters. How, why, we discussed everything in detail in our classes. Definition of primary amenorrhea, absence of menses by 13 years of age. And if at 13 years secondary sexual characters are developed, we will wait till 15 years. Chocolate question, definition of primary amenorrhea. Secondary amenorrhea, absence of menses for 90 days in a previously normally menstruating female, and maximum span for waiting is 6 months. So this is secondary amenorrhea. Now, what are the causes? Other systemic causes of amenorrhea. There can be severe anemia, HIV, severe chronic renal disease, hyperprolactinemia, thyroid disorder, and a physiological cause. What are the physiological causes of amenorrhea? Physiological, pregnancy and lactation. What is the cause of amenorrhea in pregnancy? HCG. HCG is supporting corpus luteum beta. So corpus luteum keeps on secreting progesterone, which keeps on holding. And we have discussed everything. This is not the time for that. Just remember, pregnant corpus luteum. In pregnancy, what is the cause of amenorrhea? HCG, which is supporting corpus luteum. Lactation. Why amenorrhea occurs in lactation? Why amenorrhea occurs in lactation? Prolactin gives negative feedback to GnRH. Gives negative feedback to GnRH and finally to FSH. So this is the cause of lactational amenorrhea. Now, pathological causes of amenorrhea. Primary amenorrhea. At endometrial level, two causes. Mullerian agenesis and testicular feminization syndrome. Mullerian agenesis, Mullerian duct not developed. So what is not developed? Uterus, cervix, fallopian tube, and upper two-thirds of vagina. They are not developed, they are absent. So what is going to happen? How there can be menses? Nothing is present. This is the cause of primary amenorrhea. Now your MCQ zone in Mullerian agenesis. Whether secondary sexual characters will develop or not, they will develop. Because ovary is normal. Ovary don't develop from Mullerian duct. Ovary develops from genital ridge. Ma'am has covered in embryology. Ovary develops from genital ridge. So ovary is normal in Mullerian agenesis. This is the reason secondary sexual characters are normal. A 22-year-old girl presents with primary amenorrhea and normal secondary sexual characters. What is most likely? Mullerian agenesis. If in this question a third line is added with cyclical pain, then it would be cryptomenorrhea. Fine, beta? Cryptomenorrhea if cyclical pain is added. If cyclical pain is not added, the answer is Mullerian agenesis. Now, what should be the management? Management is do a vaginoplasty just before marriage so that she can have a normal sexual life. So, management is vaginoplasty just before marriage. Now, if she wants to conceive, she wants a baby, bacha chahiye. Yes, what is the management? If a girl with Mullerian agenesis wants to conceive, in vitro fertilization, IVF, we will take out her because her ovary is normal. We will take out that oocyte from her and we will make fertilization outside IVF. Now, another MCQ. In Mullerian agenesis, IVF has to be done with her own oocytes or with donor oocytes. Her own oocytes because her ovary is normal. IVF with donor oocyte is required beta when her ovary is not working. If it is a case of premature ovarian failure, MCQ zone, trap beta, trap. IVF with donor oocytes will be required when her ovary is not working. So IVF with donor oocytes where we have written in our notes to treat premature ovarian failure. If a lady wants to conceive with premature ovarian failure, then IVF would be done with which oocytes beta? Donor oocyte. In Mullerian agenesis, very important MCQ zone. IVF has to be done with her own oocyte. Dun, 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 dun. Another MCQ beta. If Mullerian agenesis is associated with renal anomaly and spinal anomaly, What is this condition called as? This is called as Rokitansky-Kuster-Meyer-Haber syndrome, popularly known as RKMH syndrome. So, beta, why we have to remember this? Examiner will give us an MCQ. Which of the following are causes of primary amenorrhea except? So, instead of writing the word Mullerian agenesis, examiner may write the word Rokitansky-Kuster-Meyer-Haber syndrome or RKMH syndrome. Fine, beta. So, Mullerian agenesis term. In this spinal defects, they are mostly at the level of cervical spine. Renal defects, kidney may be absent or a horseshoe kidney. Testicular feminization syndrome, second problem at endometrial level. Testicular feminization syndrome is also called androgen insensitivity syndrome. Popularly, beta examiner may write TFS or AIS. What is this problem? Testicular feminization syndrome. Testis is normal. So this is male. This is not female. We are talking about XY. This person has testis. Testis is secreting testosterone. Where is the problem? Problem is at the level of receptor. Receptors of testosterone are not recognizing testosterone as testosterone. So testosterone is not able to function. Testosterone is not able to function. So what is happening in this? What is happening in this? Testosterone is not able to function. So Wolffian duct is not developing. So male internal genital organs are absent. If testosterone is not functional, dihydrotestosterone is not available. So external genitalia will be female. Female external genitalia. This is why we are discussing it here. Male internal genital organs absent and external genitalia are feminine. Now, what is the management protocol here? One thing is, because she is a female, even at the time of puberty, what is going to happen? This testosterone, whatever testosterone is present, because testis is secreting testosterone, will be converted to estrogen. So, which secondary sexual characters will develop finally, even at the time of puberty? Female. So, management protocol, let this individual lead a feminine life. So, do a vaginoplasty at the time of marriage, do a vaginoplasty. And then this testis has to be removed because in TFS, testis is undescended. It is undescended, so it should be removed. MCQ here. This testis should be removed at what time? This orchidectomy should be done at what time? It should be done after puberty. Because till puberty we want testosterone from this testis. Because this testosterone is converted to estrogen, which is giving secondary sexual character. So, an important MCQ zone here is this orchidectomy in TFS should be done at what time? It should be done after puberty. One thing. What then after removing testis, some hormone should be given to maintain the femininity. So we give her estrogen. Important MCQ zone here, beta. Should we add progesterone or can we give only estrogen? We can give only estrogen because there is no uterus. Fine. Now, two very important MCQs here. Levels of testosterone in TFS, they are low or normal or high. They are high because there is no negative feedback. One thing. Second is this, what is the best clinical method to differentiate Mullerian agenesis and TFS? What is happening in TFS? Testosterone is not functioning. In females also, for development of axillary and pubic hair, androgens are responsible. So in TFS, there are absent axillary and pubic hairs. Very important MCQ. A 21-year-old girl presents with primary amenorrhea, normal secondary sexual character. If examiner finish it, stop it here, answer is Mullerian agenesis. Primary amenorrhea, normal secondary sexual character, cyclical pain, cryptomenorrhea. 20-year girl, primary amenorrhea, normal secondary sexual character, absent axillary and pubic hairs. Answer is TFS, testicular feminization syndrome. So best clinical method to differentiate Mullerian agenesis and TFS is absent axillary and pubic hairs in TFS. If the question is best method to differentiate Mullerian agenesis and TFS, then answer would be karyotyping. This TFS is male pseudohermaphroditism. Another important question. Most common cause of male pseudohermaphroditism is TFS. What is pseudohermaphroditism? You know that. Gonad is of one sex and secondary sexual characters are of other sex. That is, karyotype is XY, but this is a female secondary sexual character. So this is called male pseudo hermaphroditism because originally this is a male XY. Another important MCQ of patho and medicine, most common cause of female pseudohermaphroditism, that is congenital adrenal hyperplasia. Pathomedicine topic, congenital adrenal hyperplasia. Here we have to discuss because this is a very important chocolate question. Most common cause of female pseudohermaphroditism is congenital adrenal hyperplasia, while most common cause of male pseudohermaphroditism is testicular feminization syndrome. Now, after this endometrial level, ovarian level. What is the problem at ovarian level? Most common problem is gonadal dysgenesis. And most common variety of gonadal dysgenesis is Turner syndrome. Here also students get very much confused. Gonadal dysgenesis, if given in option, that would be the best answer. If gonadal dysgenesis is not given, then second best answer would be Turner, because Turner is most common variety of gonadal dysgenesis. Turner syndrome, one X chromosome absent. So what is happening? For normal development of ovary, two X chromosome required. Only one X chromosome, so ovaries don't develop. It's streaky ovary. So very less estrogen, minimal estrogen. So secondary sexual characters are absent. Uterus also don't develop properly because of lack of estrogen. Very much hypoplastic uterus, that's the cause of amenorrhea. And this estrogen is responsible for maturation of long bones also. So height is also reduced. There is a long list, but we are concerned with our gynae. So secondary sexual characters are absent, height is reduced, and markedly hypoplastic uterus. What is the management for Turner? We have to give estrogen. But we know the thumb rule. When uterus is intact inside, we add progesterone along with estrogen. So management would be estrogen and progesterone. What else can be given? To increase the height, growth hormone can be added. One thing. Second problem at ovarian level is pure gonadal dysgenesis. I am going word by word with your notes only, trying to do that. So it will save a lot of time and you are scrolling the pages of your notes. Pure gonadal dysgenesis. Pure gonadal dysgenesis, no chromosome is absent. It is a pure condition. But one X chromosome is not functioning properly. So estrogen is less, but not to that extent as it is reduced in Turner. So final outcome is hypoplastic uterus, absent secondary sexual characters, but height is normal. This is the only difference and MCQ zone between Turner syndrome and pure gonadal dysgenesis. Turner syndrome, absent secondary sexual characters, markedly hypoplastic uterus and reduced height. Pure gonadal dysgenesis, absent secondary sexual characters, markedly hypoplastic uterus but normal height. Treatment same, estrogen and progesterone. No need of growth hormone in pure gonadal dysgenesis because height is normal. Third condition at ovarian level beta is Swyer syndrome. Swyer syndrome is again XY. TFS was also XY. Swyer syndrome is also XY. We are talking about male. What is the problem? What is the difference in TFS and Swyer? TFS testis was normal. So there was testosterone was available, but the problem was at the level of receptor. In Swyer syndrome, testis itself is dysgenetic. Dysgenetic testis, so dysgenetic Sertoli cell, dysgenetic Leydig cell. No Sertoli cell, no Mullerian inhibiting factor, Mullerian duct develops, so uterus develops. So uterus is present in this XY, in this male, that is Swyer syndrome, because Sertoli cells are not functioning. Leydig cell, no testosterone. No testosterone, so no Wolffian duct, no male internal genital organ. No testosterone, so no dihydrotestosterone. So which external genitalia will develop? Female external genitalia will develop. What should be the management protocol? Management protocol here is do a vaginoplasty, then do a orchidectomy. Because why we were doing orchidectomy in TFS, why we are doing orchidectomy in Swyer? Because in TFS testes are undescended. In Swyer testes are dysgenetic. Both these conditions have risk to develop malignancy later on in life. Two important MCQ. Most common malignancy to develop, most common tumor to develop, whether it is undescended testis in TFS or whether it is dysgenetic testis in Swyer, it is gonadoblastoma. And most common malignancy to develop, if examiner asks most common tumor to develop, in Sware or in undescended testis in TFS, gonadoblastoma. If examiner use the word malignancy, most common malignancy to develop, then answer would be seminoma. Don't commit any mistake, beta. Most common tumor to develop, gonadoblastoma. Most common malignancy to develop, seminoma. Fine, beta. Now, what is the treatment? In TFS, we were doing orchidectomy after puberty because we wanted testosterone. In Sware syndrome, we are doing orchidectomy as soon as condition is diagnosed because there is no point in waiting till puberty because this testis is dysgenetic. It is not giving us anything which could be of any use. So orchidectomy is done as soon as condition is diagnosed in Sware syndrome, while orchidectomy is done after puberty in TFS. Then after orchidectomy, we have to give estrogen only or estrogen plus progesterone. In TFS, we were giving only estrogen because there was no uterus. In Sware syndrome, we have to give estrogen along with progesterone because uterus is intact. Fine, beta. So this is about these three things, and most common of these is Turner syndrome. Then pituitary level, what is the problem? Pituitary adenoma. And what is the most common to cause primary amenorrhea? Craniopharyngioma. Now, pituitary tumor, why it causes amenorrhea? Because it secretes prolactin, and prolactin gives negative feedback to GnRI. Now, we have discussed everything, all this pathophysiology in detail in our classes. Let's summarize the things. Let's make it a revision class. Fine. So, this is how it is causing primary amenorrhea. Now, next question would be, if a 22-year-old girl presents with primary amenorrhea and examiner will give you some clue that will favor pituitary tumor. So we should know what else can be associated. Galactorrhea. Because of excessive prolactin, galactorrhea. What else? Pituitary tumor, headache. Pituitary anatomical location compressing optic chiasma, so diminished vision. Or because of compression of optic chiasma, most common visual manifestation would be bitemporal hemianopia. So primary amenorrhea with galactorrhea, what is most likely? Pituitary adenoma. That is craniopharyngioma. Primary amenorrhea with headache, what is most likely? Craniopharyngioma. Primary amenorrhea with diminished vision, what is most likely? Craniopharyngioma. Primary amenorrhea with bitemporal hemianopia, what is most likely? Pituitary adenoma. Fine. Diagnosis, MRI. Treatment, cabergoline. If no response, surgery. Hypothalamic level. One syndrome you have to remember, Kelemen syndrome. Kelemen syndrome. Kelemen syndrome, we know because of defective migration of olfactory neurons, so it is associated with anosmia. No smell. She is unable to smell. Management by pulsatile GnRH. So your MCQs would be, if patient presents with primary amenorrhea with absent axillary pubic hairs, TFS. Primary amenorrhea with galactorrhea, pituitary tumor. Primary amenorrhea with anosmia, Kelemen syndrome. Management of Kelemen syndrome, pulsatile GnRH. Management of pituitary adenoma, cabergoline. If no response with cabergoline, then we will go for surgery. Primary amenorrhea with absent axillary and pubic hairs, TFS. Primary amenorrhea with bilateral inguinal hernia. Again, answer is TFS. Bilateral inguinal hernia, beta, due to undescended testes. They mimic hernia. It is not true hernia. So, primary amenorrhea with bilateral inguinal hernia, what is most likely? TFS. Levels of testosterone in TFS is high. It is high. Fine, beta. Inhibin B is predominant in proliferative phase. Inhibin A is predominant in secretory phase. Minimum, speak out with me. Just speak out with me. Minimum estradiol required for LH 200 picogram per ml, which should sustain for how much time? 48 hours. Minimum LH required for ovulation, 75 nanogram per ml. Pregnant corpus luteum supported by SCG. Non-pregnant corpus luteum supported by LH. Predominant hormone secreted by corpus luteum, progesterone. Size of dominant follicle. Speak out in your room. Size of dominant follicle, 14 mm. So follicle ruptures at what size? 20 mm. Follicle ruptures at what size? 20 mm. Day of ovulation in a 60-day cycle, 60. You have to subtract 14. So answer here would be 46. So you have to subtract 15. Drug of choice for primary dysmenorrhea. Speak out. Drug of choice for primary dysmenorrhea, mefenamic acid. Drug of choice for premenstrual syndrome, fluoxetine. What is the drug of choice for premenstrual syndrome? Fluoxetine. So this was about this part. Now, second most common cause of primary amenorrhea, answer is gonadal dysgenesis. If gonadal dysgenesis word is not written, then answer would be Turner syndrome. After this, secondary amenorrhea. Secondary amenorrhea, endometrial level, most common cause, endometrial TB or Asherman syndrome. Ovarian level, most common cause, polycystic ovarian syndrome. Pituitary level, pituitary tumor, that is pituitary adenoma, and Sheehan syndrome. What is Sheehan syndrome? Postpartum necrosis of anterior pituitary. Why of anterior? We have discussed everything in detail. Postpartum necrosis of anterior pituitary due to excessive postpartum hemorrhage. Management of Sheehan, replacement of all the hormones secreted by pituitary. Important MCQ zone in Sheehan. Earliest feature of Sheehan syndrome, failure of lactation. If all the hormones are reduced in Sheehan syndrome, what can be associated features? Due to reduced ACTH, reduced androgens, axillary and pubic hairs start disappearing. TSH reduced, cold intolerance, hypertension. MSH reduced, vitiligo-like white patches. So if axillary and pubic hairs they start diminishing later on in life, what is most likely? Sheehan syndrome. If axillary and pubic hairs are absent since birth, what is most likely? Testicular feminization syndrome. Primary amenorrhea with bilateral inguinal hernia, what is most likely? Testicular feminization syndrome. Fine, beta. Now, a very important question with Sheehan. Earliest feature of Sheehan syndrome is failure of lactation. Earliest feature of Sheehan syndrome, very, very important question, beta, is failure of lactation. Most common cause of primary amenorrhea, gonadal dysgenesis. If gonadal dysgenesis is not written, I'm expecting these questions in exam. If gonadal dysgenesis is not written, then answer would be Turner syndrome. Fine, beta. Now, at hypothalamic level, stress and excessive weight reduction. Why amenorrhea occurs due to excessive weight reduction due to reduced leptin? Just read in your notes. We have written clearly, we made a box and in that box we wrote leptin is required for stimulation of hypothalamus. And if she is doing excessive gymming at all, I don't want to go in any jokes right now. We have to complete everything till 4 o'clock. Fine. So, due to excessive fat reduction, amenorrhea would occur. So if it is due to excessive gymming, we would advise her to gain some weight. And if it is due to stress, stress affects hypothalamus. We will advise her some meditation and lifestyle modification. Now we have discussed systemic causes of secondary amenorrhea. We have discussed physiological causes of amenorrhea, that is pregnancy and lactation. Now MCQ Jones for secondary amenorrhea. First question, most common cause of secondary amenorrhea. Answer is pregnancy. Most common pathological cause of secondary amenorrhea, polycystic ovarian syndrome. Third question, most common pathological cause of secondary amenorrhea in developing countries. Answer is endometrial TB or Asherman syndrome. Now, diagnostic protocol of primary amenorrhea and secondary amenorrhea. Diagnostic protocol of primary. First possibility, a 22-year-old girl presents with primary amenorrhea, normal breast development or normal secondary sexual characters. What is the next step? Next step is ultrasound. In ultrasound, what we have to see, whether uterus is present or absent. If uterus is present, cryptomenorrhea. If uterus is absent, either Mullerian agenesis or testicular feminization syndrome. Now, we know how to clinically differentiate Mullerian agenesis and TFS, absent axillary pubic hairs in TFS, but the best is karyotype. 22-year-old girl presents with primary amenorrhea and absent secondary sexual characters. How to differentiate? Only by karyotyping. If secondary sexual characters are absent, ultrasound will be of no use. Karyotyping, because it can be Turner syndrome, it can be pure gonadal dysgenesis, it can be Swyer syndrome, it can be Kalaman syndrome. So what is required? Karyotyping. So best differentiation in the causes of primary amenorrhea is by karyotyping. Read the question very carefully. Best differentiation, best differential diagnosis for the causes of primary amenorrhea is by karyotyping. Second question. Listen very, very carefully and read at notes very carefully. Second question. A 21-year-old girl presents with primary amenorrhea, normal breast development. What is the next step? Next step is ultrasound. Fine. These two questions very, 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 very important. And best differential diagnosis of causes of primary amenorrhea is by karyotyping. Now come to secondary amenorrhea. Diagnostic protocol. A patient presents with secondary amenorrhea. What is the next step? First question, urine pregnancy test. Because most common cause of secondary amenorrhea is pregnancy. Second question, a patient presents with secondary amenorrhea and negative urinary pregnancy test. What is the next step? Answer is TSH and prolactin. Third question, beta. A patient presents with secondary amenorrhea. Her urine pregnancy test is negative. Her TSH and prolactin are within normal limits. What is the next step? Next step is progesterone challenge test. Fourth question. If progesterone challenge test is positive, what is most likely? An ovulation. And what is the most common cause of an ovulation? It is polycystic ovarian syndrome. Fifth question, beta. A patient presents with secondary amenorrhea and her progesterone challenge test is negative. What is the next step? If her progesterone challenge test is negative, next step is combined estrogen and progesterone challenge test. How and why we have discussed everything in detail. Estrogen and progesterone challenge test. If estrogen and progesterone challenge test is negative, what is most likely? Asherman syndrome. If estrogen and progesterone challenge test is positive, what is the next step? Next step is estimation of FSH. If FSH levels are high, what is likely? Premature ovarian failure. If FSH levels are low, hypothalamic or pituitary cause. So if FSH levels are low, what is the next step? MRI. In MRI, if MRI is normal, hypothalamic cause. If MRI shows pathology, it is a pituitary cause. If FSH levels are low, apart from MRI, or if MRI is not given in option, second thing you will search for is injection GnRH. If after giving injection GnRH, her FSH increase, where is the problem? Hypothalamus. So this is how we differentially diagnose various causes of primary amenorrhea and secondary amenorrhea. Then few words about puberty, although sir in pediatrics have covered it. So what we have to remember here, sir has told you the sequence and everything. What is the age range of puberty? Age range of puberty, you know. What is the age range of puberty? 8 to 12, and the mean is 10.5 years. What is precocious puberty? If secondary sexual characters develop before 8 years. Most common cause, idiopathic. Management is continuous GnRH. Precocious menarche, if menses begin before 10 years, because the age range for menses is 10 to 15. Age range for puberty is 8 to 12. Age range for menses is 10 to 15. So precocious menarche if menses begin before 10 years. Most common cause, idiopathic. Management is continuous GnRH. Delayed puberty if secondary sexual characters don't develop even till 13 years. Most common cause, it is idiopathic constitutional delay, and management is by pulsatile GnRH. Management is by pulsatile GnRH. Now few words about actions of estrogen and progesterone. Estrogen-progesterone action on vagina. In vagina, there are three types of cells. Superficial cells, which are also called cornified cells or eosinophilic cells. Intermediate cells, basal and parabasal cells. Look at that chart. Superficial cells are abundant under influence of which hormone? Estrogen. Intermediate cells are abundant under influence of which hormone? Progesterone. Basal and parabasal cells are abundant when there is no hormonal predominance. To calculate maturation index, these cells are written like this. Superficial cells towards right side, intermediate cells in between, and basal and parabasal cells towards left side. So what is maturation index? It is ratio of these three types of cells per 100 cells counted. Fine. Your MCQs would be, after ovulation, maturation index shifts from right to left, because superficial cells were written towards right side and intermediate cells are written in between. So what is happening? Number of intermediate cells is increasing after ovulation. So very important question, beta. After ovulation, maturation index shifts from right to left. Now basic statistics. Before basic statistics, what is the meaning of word cornification index or eosinophilic index? It is percentage of cornified cells or eosinophilic cells or superficial cells. Your MCQ would be cornification index is maximum in which phase? Proliferative phase or secretory phase? Proliferative phase, because cornified cells, they are maximum in which phase? Proliferative phase, because they develop under influence of which hormone? Estrogen. Fine. So cornification index is maximum in estrogenic phase, that is first phase, that is proliferative phase. Now statistics. In proliferative phase, maturation index is 0, 40, 60. Secretory phase 0, 70, 30. Pregnancy 0, 95, 5. And before puberty, it is 100, 0, 0. So in vagina, what we see? Maturation index. Actions of estrogen, they increase which cell? Superficial cell. Action of progesterone, they increase which cell? Intermediate cell. And before puberty, when there is no hormonal predominance, which cells are in abundance? Basal and parabasal cell. So now on cervix. Action of estrogen on cervical mucus. Cervical mucus is thin, watery, profuse, alkaline, elastic. It can be stretched up to 10 centimeter and it doesn't break. If it doesn't break, this phenomena is called spin-Barrett phenomena. What is microscopic finding? If you put this mucus on slide, allow it to dry and look under microscope, we see furning. Important question, beta. So furning is seen in which phase? Proliferative phase. And this furning is due to what? Sodium and chloride crystals. Very important MCQ, beta. Furning in cervical mucus is due to everything is written word by word in our notes. Everything is there in front of you on your page. Furning is due to what? Sodium and chloride. Furning is seen in which phase? Proliferative phase. Spin-Barrett phenomena is seen in which phase? Proliferative phase. Now, under influence of progesterone, that is in secretory phase, cervical mucus becomes thick, scanty, non-elastic. If you try to stretch it, it breaks. If it breaks, this phenomena is called Tech phenomena. In proliferative phase, it doesn't break. So that phenomena is called spin-Barrett phenomena. In secretory phase, it breaks. This phenomena is called Tech phenomena. Microscopic finding in secretory phase, no furning, no furning. Furning disappear. So if furning is absent, it is indicating that ovulation has occurred. So these are the actions on cervical mucus. Then actions on myometrium. Estrogen increases number of myometrial cells. Estrogen increases myometrial contractility. Progesterone is uterine relaxant. It reduces myometrial contractility, but it helps estrogen in increasing number of myometrial cells. So these are the actions. Now, few MCQs. Everything is in front of you. Why it happens, we have discussed in detail. Just do revision. What are the questions which can be asked here from this page? Ultrasound finding of proliferative endometrium. Triple layered or trilaminar or 3-layered endometrium. Ultrasound finding of secretory endometrium. I will show you. Ultrasound, let me tell you, then I will show you. Ultrasound finding of secretory endometrium is hyperechoic. Histological feature of proliferative endometrium, short tubular gland. Histological feature of secretory endometrium. There can be 2 questions, 3 questions better. Earliest histological feature of secretory endometrium, vacuolation. Histological feature of early secretory endometrium, vacuolation. Third MCQ beta. Histological feature of late secretory endometrium, cork screw glands or saw-tooth glands. These vacuoles become tortuous. Let me show you. Let me show you these endometrium. Look here, beta. This is the ultrasound appearance of proliferative endometrium. This is the ultrasound appearance of proliferative endometrium. Look here. 3-layered beta. How many layers beta? 3. 1, 2, and 3. These are the 3 layers beta. So ultrasound feature of proliferative endometrium is 3-layered or triple layered or trilaminar endometrium. Fine beta. Next question beta. Next question. Ultrasound feature of secretory endometrium. Ultrasound feature of secretory endometrium. Look beta, look here, look here. This is a hyperechoic endometrium. Hyperechoic. White beta, white. Radiologist sir told you what is the meaning of word hyperechoic beta? Whitish towards white. Ultrasound terminology. What is the meaning if it is towards blackish beta? Hypoechoic. If it is absolute black, what we call it? Anechoic. So this is hyperechoic. It is due to acoustic enhancement. We discussed in detail. Just remember this now. Just remember this. Ultrasound appearance of secretory endometrium is hyperechoic. This is proliferative endometrium. If examiner asks you to identify, this image is given, proliferative endometrium, 3 lines clearly seen beta, distinctly seen. This is ultrasound appearance of secretory endometrium. Now I will show you histological feature. Histological feature of proliferative endometrium. Can you see these? This is proliferative endometrium, a short tubular gland, short tubular gland. Look here. This is short tubular gland, short tubular. This is a short tubular gland. This is a short tubular gland. These are glands, beta, short tubular gland. So this histological feature is of proliferative endometrium, short tubular gland. So this short tubular gland, this proliferation occurs under influence of which hormone, beta? Estrogen. Now I will show you histological feature of early secretory endometrium. Look, beta, look here. This is histological feature of early secretory endometrium. Can you see what are these, beta? These are vacuoles. These are vacuoles. Histological feature of early secretory endometrium, vacuolation. Second MCQ, earliest histological feature of secretory endometrium, vacuolation. Earliest histological feature of secretory endometrium, vacuolation. Answer to 2-2 question, beta, 2-2. Now third question, histological feature of late secretory endometrium. Histological feature of late secretory endometrium, beta, these vacuoles become heavy and tortuous. This is called corkscrew glands or saw-tooth glands. What is this called, beta? Corkscrew gland or saw-tooth gland. Fine. Just quickly speak out in your room. Spin barket is seen in proliferative phase or secretory phase. Spin barket doesn't break, proliferative phase. Tech phenomena, secretory phase. Furning is present in proliferative phase. Furning is absent in secretory phase. Furning is due to sodium and chloride crystal. Furning is due to sodium and chloride crystal. Maturation index in pregnancy. Speak out. Speak out. Speak out in your room. Maturation index in pregnancy 0.95.5. 0.95.5. Maturation index in first half. Proliferative phase. Maturation index in proliferative phase. Tell me. 0.40.60. Maturation index in secretory phase 0.70.30. Maturation index before puberty 100.00. What is precocious puberty? If secondary sexual characters develop before, come on, speak out. If secondary sexual characters develop before 8 years. Precocious menarche. If menses begin before 10 years. Most common cause of both precocious puberty, both precocious menarche, chocolate question, idiopathic. Management of both precocious puberty, precocious menarche with GnRH. Continuous GnRH. Delayed puberty if secondary sexual characters don't develop even till MCQ. Age, remember age, 13 years. Management is pulsatile GnRH. Management is pulsatile GnRH. Best clinical method to differentiate Mullerian agenesis and TFS. Speak out! Best clinical method to differentiate Mullerian agenesis and TFS. Absent axillary and pubic hairs in. Absent axillary and pubic hairs in. TFS. Most common cause of male pseudohermaphroditism. TFS. Most common cause of female pseudohermaphroditism. Congenital adrenal hyperplasia. Most common cause of secondary amenorrhea. Most common cause of secondary amenorrhea. Pregnancy. Most common cause of primary amenorrhea. Gonadal dysgenesis. If gonadal dysgenesis is not given in option, answer would be Turner syndrome. Minimum LH required for ovulation. Come on! Come on! Minimum LH required for ovulation 75 nanogram per ml. Pregnant corpus luteum is supported by, come on, HCG. Non-pregnant corpus luteum is supported by LH. What is the day of ovulation in a 40-day cycle? 40 minus 14. Drug of choice for primary dysmenorrhea, mefenamic acid. Drug of choice for premenstrual syndrome, fluoxetine. Fluoxetine. Most common cause of menorrhagia. Most common cause of menorrhagia, uterine fibroid. Most common cause of metrorrhagia. Come on! Most common cause of metrorrhagia, DUP. DUB is without or with? Without. AUB is with. Primary dysmenorrhea without or with? Without. Secondary dysmenorrhia with. Most common cause of secondary dysmenorrhea is endometriosis. Most common cause of secondary dysmenorrhea is endometriosis. So we have done actions of estrogen and progesterone as well. Now congenital malformations of uterus. I will tell you and will show you few images also. Fine. We will take our first break at 12 o'clock. Fine? At 12 o'clock, so after 30 minutes. Come on, come on. Congenital malformations of uterus. I will show you the image. First, let me tell you, then I will show you the images. Okay. Congenital malformations of uterus. Uterine malformations. Open the notes, open the notes. Congenital malformations of uterus. The first one, embryology part, ma'am has also covered. First malformation, uterine didelphys. Uterine didelphys is also called double uterus. It is also, I will show you the images later on, quickly. Just look at your notes. If Mullerian ducts don't fuse at all, if Mullerian ducts don't fuse at all, what is the outcome? Double uterus or uterine didelphys. Second MCQ. If Mullerian ducts fuse partially, what is the outcome? Bicornuate uterus. Bicornuate uterus is also called heart-shaped uterus. It is of two types, bicornis unicollis, bicornis bicollis. Which one is more common? Bicornis unicollis is more common. Third MCQ. If Mullerian ducts fuse, but their inner walls don't disappear, what is the outcome? Septate uterus. Fourth MCQ. If Mullerian ducts fuse, but their inner walls disappear partially, what is the outcome? Subseptate uterus. Next question. In subseptate uterus, septum is present in which part of uterus? Upper part of uterus. Next question. If only one Mullerian duct develops, what is the outcome? Unicornuate uterus. Next question, which is unrelated to Mullerian pathology. If dome of uterus doesn't develop, what is this called? Arcuate uterus. Next question. Two vagina are seen in which congenital malformation? Uterine didelphys. Next question. Unicornuate uterus is associated with how many fallopian tube, or single fallopian tube is seen in which congenital malformation of uterus? Unicornuate uterus. Let's have a quick look at these images. Quick look at these images. Yes, come on. Let me show you the didelphys first. See. This is the answer to which MCQ? What is this? Ultrasound, MRI, laparoscopy, hysteroscopy, or HSG? HSG, hysterosalpingography. Can you see this is the X-ray film? This is the X-ray film, and what is this? Barium. We have instilled a radio opaque dye. So can you see how many uterus? One uterus, second uterus. How many vagina? Two. One vagina, two vagina. And the best way to identify that this is uterine didelphys, this is by one Leach-Wilkinson cannula, this is by second Leach-Wilkinson cannula. Leach-Wilkinson cannula. And we are instilling radio opaque dye through which instrument? Leach-Wilkinson cannula. In image session, that image session of obsgyne will be for 1 hour only, that I will merge with either CCD or chanting session, where I will show you all the potential images which can be asked in exam. Here what images I am showing, this is just to demonstrate. Just to demonstrate. In that image session, which will be with clinical case discussion and chanting, of obsgyne, I have especially planned after test and discussion, so that you revise obsgyne properly, you appear for the test, you give the test, and then we can talk with eye contact, and because you are perfectly prepared. Again telling you, fair number of questions from obsgyne, second paper, you will see. So please utilize these 3 days. Utilize these 3 days. Don't just think what is going to happen in next 17 days. Don't just think what is going to happen in next 17 days. That's the big problem. Many students, daily I am receiving many messages. सर याद नहीं हो रहा, not able to remember, not able to memorize, what's happening? सारा दिन पढ़ते हैं, whole day we are studying, and in the evening suddenly we start feeling low. I have at least 500 to 600 messages in my mobile. The problem is I am not able to answer everyone. Because the mobile is flooded. But still I try. Maybe after 2 days, maybe after 3 days. Commonly, I am telling you, the common message for this problem is, don't think what is going to happen in next 17 days. Just think what can happen in next 24 hours. This message I prepared today morning only. After going through all the messages, don't just think now what will happen in next 17 days, what will happen on 12th of December. For just don't think. Just think what can happen in next 24 hours. make the target of 24 hours only. Fine. Now, so this was about uterine didelphys. This is uterine didelphys or double uterus. So how many vagina beta here? Two vagina. And how will you identify it? With two Leach-Wilkinson cannula. Next one is when Mullerian ducts fuse partially, the outcome is bicornuate uterus. What is the outcome beta? Outcome is bicornuate uterus. That's the bicornuate uterus beta. Fused lower down, but upper part is not fused. This is bicornuate uterus. Which one is most common in bicornuate? Bicornis unicollis. Fine. Then I will show you the next one, the septate one. This is septate. This is septate beta. There is a filling defect in the septum. This is a septate uterus. This is septate and this was bicornuate. I will show you unicornuate now. This is unicornuate beta. Can you see? This is the unicornuate uterus. Only one side. Everything is absent here. So 50% of uterus because single. So if one Mullerian duct develops, outcome is unicornuate uterus. How many fallopian tubes are associated with unicornuate uterus? One fallopian tube. Two vagina are seen in which congenital malformation of uterus? Uterine didelphys or double uterus. Heart-shaped uterus is which one? Bicornuate uterus. Now few potential MCQs here beta. Few potential MCQs. What are these MCQs? Few potential MCQs related to this. What is the most common complication of congenital malformations of uterus? What is the most common complication of congenital malformation of uterus? Abortion. Second question beta. What is the indication of repair of congenital malformation of uterus? History of recurrent abortion or habitual abortion. Recurrent or habitual means how many abortion? 3 or more than 3 abortion. Best method to diagnose congenital malformation of abortion? Combination of laparoscopy and hysteroscopy. If it is not given in option, then MRI. Next question beta. Most commonly used diagnostic method for congenital malformation of uterus is ultrasound. If she is married, transvaginal ultrasound. 4D, 5D, they are better. Fine. So most common is ultrasound. Best is a combination of laparoscopy and hysteroscopy. If combination of laparoscopy and hysteroscopy is not given, second best answer would be MRI. Fine beta. So this is about diagnosis. Management, indication of management, history of recurrent abortion. Congenital malformation with worst reproductive outcome, septate uterus. Second one is unicornuate. Congenital malformation with best reproductive outcome, arcuate uterus. Second best is bicornuate. Now what is the treatment? If it is septate uterus, hysteroscopic removal of septum. If it is uterine didelphys or bicornuate uterus, metroplasty. So what is the name of repair of bicornuate or uterine didelphys? Metroplasty. Initially, metroplasty was started by whom? Strassman via abdominal route. But now, a neat PG question, which metroplasty is best? Abdominal or hysteroscopic? Hysteroscopic. Less invasive beta, very simple to understand. So which metroplasty is best? Hysteroscopic. Metroplasty is done to repair what? Bicornuate uterus and uterine didelphys. What is the management of septate uterus? Hysteroscopic removal of septum. Congenital malformation with worst reproductive outcome, septate uterus. Second one is unicornuate. Congenital malformation with best reproductive outcome, arcuate uterus. Second best is bicornuate uterus. Very important question beta. Best diagnostic method for congenital malformation is a combination of laparoscopy and hysteroscopy. Laparoscopy alone, no. Hysteroscopy alone, no. How and why we discussed in detail in our classes. Fine. So after congenital malformation of uterus, PCOS, polycystic ovarian syndrome. Open your notes, just keep on moving with notes. Polycystic ovarian syndrome, PCOS, it is also called Steen-Leventhal syndrome. How PCOS starts? Quickly, pathophysiology, quickly. Insulin resistance, insulin not able to control plasma sugar, plasma glucose elevated. Altered body function, liver function altered. Sex hormone binding globulin synthesis reduced, it is impaired. So free androgens are increased. They are converted to what? Estrogen. Estrogen gives negative feedback to FSH, positive feedback to LH. Because of less FSH, follicles remain small. Because of excessive LH, excessive action on theca cell, which are secreting excessive androgens and which are converted to estrogen by aromatization. So this is a vicious cycle which is ultimately producing more and more androgens and estrogen and less FSH. This is why follicles remain small. And LH acts on thecal cell. So there occur theca cell hyperplasia. This is why follicles are displaced towards periphery. This is why these follicles are displaced towards periphery. And we know what is this appearance called as. Look here. This is the reason these follicles are displaced towards periphery. These follicles are displaced towards periphery. This is called a string of pearl sign, a string of pearl sign or necklace sign. Look here. These are small follicles. छोटे laddu, small laddu. Fine, beta. The reasons for smaller follicles is reduced FSH, beta. And what is the reason why they have been displaced peripherally? Because of this theca cell hyperplasia, which is giving it classical necklace sign or string of pearl sign. So this is the feature of polycystic ovarian syndrome. Fine. So this is the pathophysiology of PCOS. Now what will be the symptoms here? Symptoms in PCOS would be insulin resistance. What is happening? Tendency towards obesity. Androgens. Because of that, acne, hirsutism, androgenic alopecia. Then they are converted to estrogen, which is giving negative feedback to FSH. Follicles are small. So what is happening? Menstrual disorder, oligomenorrhea and amenorrhea. And because of this, anovulation, follicles are small, they are not rupturing. And LH is also continuously elevated. There is no LH surge in PCOS. So no ovulation. If she is married, infertility. So these are the symptoms. Long-term complications, diabetes mellitus, cardiac or cerebral stroke, due to excessive estrogen, endometrial cancer, breast cancer, ovarian cancer. What are other complications? Metabolic X syndrome, sleep apnea syndrome, non-alcoholic steatohepatitis. Diagnostic criteria, Rotterdam criteria. Move with the notes. Diagnostic criteria, Rotterdam criteria. How many points? 3. How many have to be positive? 2. First is menstrual dysfunction, oligo or amenorrhea. Second is clinical evidence or biochemical evidence of hyperandrogenemia. Third one is ultrasound appearance. What ultrasound appearance are included in Rotterdam criteria? Size of follicles between 2 to 9 mm. Number of follicles should be at least 12. Ovarian volume should be at least 10 cc. Which ultrasound criteria is not a part of Rotterdam criteria? Necklace sign. Please be very, very careful. This necklace sign is not included in Rotterdam criteria. Why, beta? Why this necklace sign is not included in Rotterdam criteria? It may take years. PCOS is a slow process. It takes much time for the whole pathophysiology to set in. So this necklace sign or a string of pearl sign is not included in Rotterdam criteria. What are included? Size of follicles 2 to 9 mm. Number of follicles should be at least 12. Ovarian volume should be at least 10 cc. So out of these 3, 2 have to be positive in Rotterdam criteria. Another point in ultrasound finding, these ultrasound findings should be present in. They should be present in both ovaries or in one ovary is also sufficient. So these ultrasound findings, even if they are present in one ovary and other ovary is absolutely normal, it is still diagnostic of polycystic ovarian syndrome. Fine. So this was about Rotterdam criteria. Now what are the changes in biochemistry? Very frequently asked question, which of the following are increased in PCO except, or which of the following are decreased in PCO except? So insulin resistance, so insulin increasing, glucose not controlled, so glucose increasing, sex hormone binding globulin decreasing, so free androgens increasing, so estrogen increasing, so FSH decreasing, so LH increasing, so progesterone decreasing. In few patients, prolactin increasing. Why and how we have discussed in detail in our classes. E2 E1 ratio normal 2 is to 1. In PCOS 1 is to 2 or 1 is to 3. Normal FSH-LH ratio 2 is to 1. In PCOS 1 is to 2 or 1 is to 3. Fine. Now, this PCOS is a slow process. If all these things like acne, hirsutism, or other androgenic feature, if they are developing suddenly, then answer will not be PCOS. Like a 22-year-old girl presents with sudden onset of amenorrhea, hirsutism. What is most likely? Answer is not PCOS. Then answer is androgen secreting ovarian tumor. Normal androgen levels up to 70 nanogram per ml. In PCOS, they range between 70 to 150 nanogram per ml. But if it is androgen secreting ovarian tumor, androgen levels are more than 200 nanogram per ml. Fine, beta. So this is how if it is given sudden onset. Or features may be more virilizing like clitoromegaly, atrophy of breast, hoarseness of voice, altered masculine body contour. If these kind of features are also written in this question, answer will not be PCOS, very, very important MCQ zone. Then answer would be androgen secreting ovarian tumor. Now, what is the management of PCOS? Management of PCOS, first is lifestyle modification. Lifestyle modification. If there is no response for 3 months, then we start treatment for insulin resistance because diseases start from insulin resistance. Drug of choice for insulin resistance, metformin. If hirsutism is present, then drug of choice for androgenic feature, oral combined pill. If OCP is not given in option, is spironolactone. Then, if menstrual dysfunction is present, oligomenorrhea or amenorrhea, the best answer is OCP for 3 cycles. But before OCP, we give a progesterone withdrawal bleeding. But drug of choice for androgenic features in PCOS, OCP. Drug of choice for menstrual dysfunction in PCOS, OCP. Infertility. If she is a married female, drug of choice for infertility due to PCOS, answer is letrozole. Very important MCQ zone beta. Drug of choice for infertility due to PCOS, letrozole. Second line, HMG and laparoscopic ovarian drilling. Third line, pulsatile GnRH. Side effect of all these ovulation inducing drugs, hyperstimulation syndrome and multifetal pregnancy. This is maximum with HMG, second maximum with clomiphene, and lastly by pulsatile GnRH. So this was all about PCOS, polycystic ovarian syndrome. Then vaginitis. Vaginitis, just open that chart. Trichomonal vaginitis caused by Trichomonas vaginalis. Trichomonas vaginalis. It is a flagellated protozoa. Symptom, important MCQ zone in trichomonal vaginitis. Nature of discharge, greenish yellow or greenish white vaginal discharge plus itching plus dysuria. Sign, tiny numerous ulcers on vagina. So 3 MCQs beta. This is called strawberry vagina. I will show you the image. This is called strawberry vagina. I will show you the image after we discuss vaginitis. Just after 5-10 minutes, I will show you the images. Strawberry vagina, it is called angry looking vagina. It is called colpitis macularis. So angry looking vagina is seen in trichomonal vaginitis. Strawberry vagina is seen in trichomonal vaginitis. Colpitis macularis, another name for this vagina, is seen in trichomonal vaginitis. Investigation of choice is saline microscopy. What will be seen? Flagellated protozoa. Gold standard, you have to remember the name of culture media. Culture media for trichomonal vaginitis is diamond media. Treatment, 2 grams single dose of metronidazole. Pregnancy, first trimester, no treatment. Second and third trimester, 250 milligram TDS for 7 days. Male partner, treated because it is transmitted sexually. Dun, 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 dun. Candidal vaginitis, caused by Candida albicans. Discharge due to fermentation, curdy white or cottage cheese like discharge, plus intense itching beta. See your notes, see your more notes, what is written in your note. Intense itching. So we get a MCQ because of intense itching. Maximum itching is seen in which vaginitis? Candidal vaginitis, plus dysuria, frequency of micturition. So nature of discharge in trichomonal vaginitis, greenish yellow or greenish white. Nature of discharge in candidal vaginitis, curdy white or cottage cheese discharge, plus intense, see your notes, intense itching. Maximum itching is seen in which vaginitis? Candidal vaginitis. Then dysuria in both. Fine. Investigation of choice, saline microscopy, hyphae or pseudo-hyphae. This is little microbiology. Fine. Gold standard is culture on which media? Seborrheic. You have to remember the name of culture media. Gold standard for trichomonal vaginitis, diamond media. Gold standard for candidal vaginitis, seborrheic media. Treatment, fluconazole, 150 milligram single dose. What is recurrent candidal vaginitis? Recurrent vulvocandidiasis. If there is episodes of four or more than four episodes in a year, this is called recurrent vulvovaginal candidiasis. Now, in pregnancy, second, third trimester, we don't give fluconazole. Fluconazole is hepatotoxic. Already liver function is deranged in pregnancy due to cholestasis. Just remember clotrimazole or miconazole local ointment. Now, predisposing factors for candidal vaginitis. It is most common in diabetes. Diabetes is a predisposing factor. OCP use is a predisposing factor. Pregnancy is a predisposing factor. Prolonged use of steroids or antibiotics is a predisposing factor. So how many questions we did? Most common vaginitis in pregnancy, candidal vaginitis. Most common vaginitis in diabetes, candidal vaginitis. Most common vaginitis in OCP user, candidal vaginitis. Most common vaginitis in HIV positive female, candidal vaginitis. Most common HIV after prolonged use of steroid, candidal vaginitis. Most common vaginitis after prolonged use of antibiotic, candidal vaginitis. Greenish white discharge is seen in trichomonal vaginitis. Curdy white discharge is seen in candidal vaginitis. Culture media for trichomonal vaginitis, Diamond media. Culture media for candidal vaginitis, Seborrheics media. How much LH is required for ovulation? Minimum 75 nanogram is required for ovulation. Name of the criteria to diagnose PCOS. Name of the criteria to diagnose PCOS. Rotterdam criteria. Drug of choice for infertility due to PCOS. Come on, speak out. Drug of choice for infertility due to PCOS, letrozole. Drug of choice for hirsutism in PCOS. Drug of choice for hirsutism in PCOS, OCP. Drug of choice for menstrual dysfunction in PCOS, OCP. If Mullerian ducts don't fuse at all, what is the outcome? What is the outcome? Uterine didelphys. Single fallopian tube is associated with which congenital malformation? Come on, speak out. Unique cornuate uterus. Two vagina are seen in which congenital malformation? Uterine didelphys. Best method to diagnose congenital malformation of uterus, combination of laparoscopy and hysteroscopy. If it is not given in option, MRI. Most common method to diagnose congenital malformation of uterus, ultrasound. Which one? If she is married, transvaginal. 5D, best one. Next to 5D, 4D. Next to 4D, 3D. And next to 3D, 2D ultrasound. What is the indication of management of congenital malformation of uterus? If there is history of what? Recurrent abortion. Recurrent or habitual abortion. What is the recurrent or habitual abortion? If there is history of abortion for at least 3 or more than 3 times. For 3 or more than 3 times. Spin market phenomena is seen in proliferative phase. Tech phenomena is seen in secretory phase. Furning in cervical mucus under microscopy is absent in secretory phase. It is present in proliferative phase. Furning is due to what? Sodium and chloride crystals. Furning is due to what? Sodium and chloride crystals. Even E2 ratio in PCOS. Even E2 PCOS 2:1. E2 even PCOS 1:2. LHFSH PCOS 2:1. FSH LH PCOS 1:2. FSH LH PCOS 1:2. Fine, beta. Histological feature of proliferative endometrium, short tubular gland. Histological feature of early secretory endometrium, vacuolation. Histological feature of late secretory endometrium, corkscrew glands, which are also called sawtooth gland. Earliest histological feature of secretory endometrium, vacuolation. Earliest histological feature of secretory endometrium is vacuolation. Fine, beta. So this was about candidal vaginitis and this was about trichomonal vaginitis. The third one is chlamydial vaginitis. Chlamydial vaginitis is caused by Chlamydia trachomatis. It is caused by Chlamydia trachomatis. One second. Chlamydia trachomatis. It is mostly asymptomatic because it is inside the cell. Now, how to diagnose it? Investigation of choice, nucleic acid amplification test, PCR. But gold standard, although it is difficult, gold standard is McCoy or HeLa cell culture. Management is azithromycin plus contact tracing. If azithromycin is not given in option, doxycycline. Trichomonal vaginitis, male partner treated. Candidal vaginitis, male partner treated if symptomatic. Chlamydial vaginitis, treatment of male partner even we are searching for male partner. So azithromycin plus contact tracing. Then the fourth one is bacterial vaginosis. What is bacterial vaginosis? It is not itis, it is cyst, that is alteration of vaginal flora. What is normal habitant of vagina? Come on, speak out. What is normal habitant of vagina? It is Doderlin bacilli or Lactobacillus acidophilus, which converts glycogen to lactic acid. So thereby making pH of vagina acidic. Acidic pH is a good pH which prevents entry of other microorganisms from outside. Fine beta? Now, what is happening if by chance number of Doderlin bacilli reduce? If number of Doderlin bacilli reduce, other microorganisms will start entering, and the most common one to enter inside is Gardnerella vaginum. This is why bacterial vaginosis is also called Gardnerella vaginosis. It is also called Gardnerella vaginosis. Fine beta. What is the diagnostic criteria for this? M cell criteria. How many points? 4 points. How many have to be positive? 3. 4 points. pH is more than 4.5. Nature of discharge is thin, dirty, grayish white. Then two more, whiff test and clue cells. Whiff test, if you add 10% QH to the discharge, we get fishy odor due to formation of amino metabolites. That's whiff test. Fourth one is clue cell. How we get clue cells? If we add sodium chloride to the discharge, Gardnerella start adhering on the surface of vaginal cell. This gives us a clue. So what are the MCQs here? Diagnostic criteria for bacterial vaginosis, M cell criteria. Most pathognomonic in M cell criteria, number of clue cells. Clue cells should be more than 20%. How do we get clue cells? By addition of sodium chloride. How do we get positive if test? By addition of 10% potassium hydroxide. Gold standard for bacterial vaginosis is Nugent score. If it is more than 7, it is diagnostic of bacterial vaginosis. Management of bacterial vaginosis, metronidazole. Trichomonal vaginosis, metronidazole. Trichomonal vaginosis, it was 2 gram single dose. The best one was 2 gram single dose. If that was not given in option, we could choose 500 milligram TDS for 7 days. That we are doing for bacterial vaginosis, 500 milligram TDS for 7 days. Pregnancy, it's same like trichomonal vaginitis. First trimester, no treatment. Second and third, 250 milligram TDS for 7 days, metronidazole. So trichomonal and bacterial vaginosis pregnancy treatment is same. Otherwise, the difference is in dose only. Trichomonal vaginitis, 2 gram single dose. Bacterial vaginosis, 500 milligram TDS for 7 days. Bacterial vaginosis, treatment of male partner not required. Itching is absent. TLC ESR remain normal. These three are very important MCQ. Maximum itching is seen in which vaginitis? Candidal vaginitis. Itching is absent in which one? Bacterial vaginosis. Itching is absent in bacterial vaginosis. Fine. TLC ESR remain normal in bacterial vaginosis. Treatment of male partner not required in bacterial vaginosis. Trichomonal vaginitis, treatment of male partner done. Candidal vaginitis, treatment of male partner is done only if male is symptomatic. Chlamydial vaginitis, we are even searching for the male partner to treat. Bacterial vaginosis, treatment of male partner is not at all required. Fine beta. So this is how we will not commit any mistake in solving any question here. Here we will take a 15 minutes break. 15 minutes break. Lunch break we will take around 2 to 2:30. 30 minutes lunch break we will take 2 to 2:30. Here we are taking, this is 11:50, a 15 minutes break. So we will resume at 12:05. We are back at 12:05. Welcome back. Let me show you a few images of vaginitis. This is trichomonal vaginitis. This one is trichomonal vaginitis. You can see trichomonal vaginitis we can easily identify by these tiny numerous ulcerations on vagina. This is called strawberry vagina or angry looking vagina or colpitis macularis. Then after this trichomonal vaginitis, candidal vaginitis. Candidal vaginitis we will identify with curdy white discharge. The nature of discharge is curdy white, as you can see here in this image. This is trichomonal vaginitis. Nature of discharge is greenish white or greenish yellow discharge, while due to candida you can see it is like curdy white or cottage cheese like. So curdy white or cottage cheese like is candidal vaginitis, greenish yellow, greenish white is trichomonal vaginitis. What is this appearance? Due to tiny numerous ulcers on vagina, this is a strawberry vagina or angry looking vagina. Then bacterial vaginosis, it is thin grayish white discharge. Thin, it is thin. The discharge is thin. It is not thick. Thin grayish white discharge. You can see these bubbles in this thin discharge. And one more pic, this is indicating presence of clue cells. This is indicating presence of clue cell. So clue cells are seen in bacterial vaginosis. It is the most pathognomonic criteria in M-cell criteria. In M-cell criteria, there are 4 points. And how many have to be positive? 3 have to be positive. Gold standard for bacterial vaginosis is Nugent score. If it is more than 7, it is diagnostic of 7 or more than 7, diagnostic of bacterial vaginosis. Then, after this, we are starting with PID. Pelvic inflammatory disease, PID. Open PID. Open your notes. PID. PID. PID is inflammation of upper genital organs like uterus, fallopian tube, and ovary. So what will be asked in PID? It is inflammation of upper genital organ. That's the definition. What is the most common microorganism? Chlamydia. Most common microorganism responsible for acute PID is gonorrhea. Most common microorganism in PID due to IUCD, it is actinomyces. So 3 questions. Most common microorganism responsible for PID is chlamydia. Most common microorganism responsible for acute inflammation, gonorrhea. And in IUCD users, actinomyces. Now how PID occurs? Most common route is ascending or descending? Ascending. Intercourse is the most common route. So ascending infection along with sperms. Which microorganisms enter inside along with sperms? Chlamydia and gonorrhea. So it is ascending infection along with intercourse, along with sperm. So most common cause of PID is intercourse. So most common risk factor for PID will be intercourse with multiple partners. Intercourse with multiple partners. Fine. What are other risk factors for PID? Apart from intercourse with multiple partners. Instrumentation, if there is any history of instrumentation that may be contaminated. Douching, that is wash, cleaning. And if the fluid is contaminated, PID is common in IUCD users also. So they are all risk factors for PID. What are protective factors for PID? Use of barrier contraceptives, oral combined pills, they are protective. Important MCQ is most common route and what are the most common microorganisms. Then PID most common symptom is lower abdominal pain. Other symptoms would be fever, malaise. Now, how to diagnose PID? What are the criteria to diagnose PID? Minimum criteria, additional criteria, and definitive criteria. Minimum criteria 3 tenderness: cervical, uterine, and adnexal tenderness. Additional criteria: temperature more than 101.6 degree Fahrenheit. Demonstration of laboratory demonstration of Neisseria gonorrhoeae or chlamydia, increased WBC, increased CRP. They are additional criteria for PID. Fever, of course, we have written increased DSR. Definitive criteria, if you are doing endometrial biopsy, that could be diagnostic. If you are doing ultrasound, then there can be tubo-ovarian mass. If you are doing laparoscopy, that is the gold standard. Gold standard among all is laparoscopy. What is most conclusive evidence in laparoscopy? If you can see trickling of pus via fimbrial ends of fallopian tube, that is gold standard for diagnosis of PID. So this is how we have diagnosed. Symptoms okay, signs done, diagnostic criteria done, microorganisms done, risk factor done, protective factor done. Then what is the correct sequence? Ascending infection. So first of all, what will happen? Endometritis, then salpingitis, then ophoritis, tubo-ovarian mass, tubo-ovarian abscess, then pyosalping. We have written clearly in our notes. We have drawn a line beneath pyosalping. Why? The acute PID finishes at pyosalping. Then what we have written in our notes below pyosalping? Hydrosalping. Hydrosalping is a feature of chronic PID, not of acute PID. Now, this is the correct sequence of events in PID. Now, how do we manage PID? How do we treat PID? Treatment of PID, best is you are doing laparoscopy. You can see pus there. Trickling of pus is the most conclusive evidence. Take out this pus, do the culture and sensitivity. So best management of PID is culture sensitivity of pus and choose the most appropriate antibiotic. If culture sensitivity not given in option, then and if we have to choose on our own to solve two MCQs, we will see what examiner has written, OPD patient or IPD patient. If it is an OPD patient, injection ceftriaxone, intramuscular 250 milligram single dose. So ceftriaxone takes care of gonorrhea. Then doxycycline, which takes care of chlamydia, 100 milligram BD for 14 days. Then metronidazole, 500 milligram TDS for 7 days. Metronidazole takes care of anaerobic infection. Doxycycline takes care of candidal infection. And ceftriaxone, 250 milligram intramuscular single shot, takes care of gonorrhea. So that is for OPD patient. For IPD patient, examiner may not use the word IPD, may use she is having fever with chills and rigor. So that is intravenous clindamycin along with gentamicin. But if examiner has given you an option, culture sensitivity, best answer would be culture sensitivity. Then what can happen? After giving these drugs, pus will be resolved, fever will disappear. But pus has caused formation of fibrous band. These fibrous bands block fallopian tube. Now we have two questions. Complication of PID if tube is partially blocked, ectopic pregnancy. Complication of PID if tube is completely blocked, infertility. Due to fibrous bands, another question. Pain in right hypochondrium in PID patient due to fibrous bands reaching up to liver capsule. What is this called? Fitz-Hugh-Curtis syndrome. So Fitz-Hugh-Curtis syndrome is pain in right hypochondrium in a patient of PID because of formation of perihepatic adhesion. Done, 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 done. Then other investigation like ultrasound finding in PID. So if you are doing an ultrasound in PID, so if you see fallopian tube in transverse section, I will show you the images. If you see fallopian tube in transverse section, what are the signs? Bead on string sign and cogwheel sign. Bead on string sign and cogwheel sign, they are seen in transverse section of fallopian tube by ultrasound. If you are visualizing fallopian tube in longitudinal section, two findings. Hydrosalpinx and waist sign. Hydrosalpinx and waist sign. These are ultrasound signs, we'll just see them. Then if you are doing a laparoscopy, the fibrous bands are present in peritoneal cavity. So these fibrous bands appear as thin violin string-like adhesion. Thin violin string-like adhesion. So laparoscopic finding in chronic PID, thin violin string-like bands. Ultrasound finding in chronic PID, transverse section, bead on string sign, cogwheel sign. Longitudinal section, hydrosalpinx and waist sign. Complication of PID if tube is partially blocked, ectopic pregnancy. If you completely blocked, infertility. Let me show you the images. Look here. If you are visualizing tube in longitudinal section, this is waist sign. This is waist sign. Waist sign. Tube has narrowed down, so it looks like waist. Waist is thin, narrow, slim. So this is waist sign. Another one in longitudinal section, this is hydrosalpinx. This is hydrosalpinx. Can you see this hydrosalpinx? This tube is elongated, linear, filled with watery, serous fluid. This is hydrosalpinx. Transverse section beta. Two findings beta, no? Bead on string sign and cogwheel sign. This is bead on string sign beta. Can you see these beads, these fibrous bands when they start developing? This is called bead on string sign. And when they become big, like spokes of a wheel, that is called cogwheel sign. Let me show you a cogwheel sign. This is cogwheel sign. Can you see like a spoke of a wheel? This fibrous band has become bigger one. A spoke of a wheel. Cogwheel sign. Now I will show you laparoscopy finding in chronic PID. Thin violin string-like adhesion. Please see. Can you see the thin violin string-like adhesion? So this is laparoscopic finding of chronic PID. And what is Fitz-Curtis syndrome? Pain in right hypochondrium in which patient? PID patient, due to perihepatic adhesion. This was about PID. Now genital TB. Genital TB is ascending infection or descending infection? Genital TB is descending. While infection by chlamydia and gonorrhea, it is ascending. Mycobacterium tuberculosis, tubercular infection is descending infection. It is descending infection. Now descending. So where from descend? Questions start. Most common primary site for genital TB, pulmonary TB. Second most one is lymph node. Second MCQ. What is the most common route of spread from here? Hematogenous spread. This is why it is almost invariably bilateral. Another question, beta. It is descending. No intercourse is required. So which PID can occur in a virgin female? Tubercular. Which can occur in a virgin female? Tubercular. The next question, beta. A 20-year-old girl presents with bilateral tubo-ovarian masses. What is most likely? 20-year-old girl presents with bilateral tubo-ovarian masses. What is most likely? Tubercular infection. Because it is almost invariably bilateral. So now what happens? Most common primary site lung. Second is lymph node. Most common route of spread is hematogenous. Keep your notes in front of you. Everything is written there word by word. Hematogenous. Then first part of genital tract involved is fallopian tube. Which part of fallopian tube is involved first? Ampulla. Everything is a question, beta. Every line is MCQ. Ampulla. And from ampulla, in 80% cases, it reaches to endometrium. 20% to ovary. And in endometrium, what it causes? Look at your notes, look at your notes, look at your page. We have drawn, it causes formation of fibrous bands, Asherman syndrome. And because of Asherman syndrome, what may develop? Hypomenorrhea and amenorrhea. Hypomenorrhea and amenorrhea. And because of these fibrous bands, because first site involved is fallopian tube, tube is blocked, which causes infertility. So you get two questions, very important questions regarding symptoms of genital TB. Most common presentation of genital TB is asymptomatic. Most common presentation of genital TB is asymptomatic. Second MCQ beta. Most common menstrual symptom. Most common menstrual symptom of genital TB is hypomenorrhea. Most common menstrual symptom of genital TB is hypomenorrhea. Most common presentation of genital TB is infertility. Clear? Then how to diagnose this genital TB? Endometrial biopsy. Best day to do biopsy, day 22. If missed, 1 day before menses. If missed, PCR of menstrual blood within first 12 hours. We send the sample for 3 findings. One is histopathology, one is culture on Lowenstein-Johnson media, and the third one is PCR. If diagnosis is confirmed, next MCQ beta. Treatment of genital TB is for how many months? 6 months. Next MCQ beta. Neat PG question. First 2 months which drug? Next 4 months which drug? First 2 months 4 drug. Rifampicin, isoniazid, ethambutol and pyrazinamide. INI-CET question beta. In next 4 months which drug is skipped? pyrazinamide is skipped. Complications are same. If tube is partially blocked, ectopic pregnancy. If tube is completely blocked, infertility. Fine, beta. So this is genital TB. Now after genital TB, endometriosis. What is endometriosis? Endometriosis is presence of endometrium outside uterus. Fine. In endometriosis, most accepted theory, Sampson's theory of retrograde menstruation or reflux of endometrium. Other theories, Mayer and Ivanov, coelomic metaplasia theory, Halban theory of metastasis. Metastasis to liver, lungs or brain. Important MCQ here, endometriosis has not yet been seen in which tissue, which organ is spleen. Fine, beta. Now, most accepted is Sampson's theory. Now, risk factors, high estrogen is responsible. So, high estrogen is present in nulliparity, obesity, early menarche, late menopause, high socio-economic class. Which gene mutation is responsible here? KRAS gene mutation is responsible, and it is more deposited over scar area. Fine. Now, how she will complain? Most common symptom is dysmenorrhea, secondary dysmenorrhea. Two other important symptoms, dyspareunia and infertility. So this triad is classical for endometriosis. Triad of dysmenorrhea, dyspareunia and infertility. Now, how will she present to you? She will say, Doctor Sahab, I am having dysmenorrhea, pain at the time of menses for last so many months. Now, firstly, whenever a patient presents to us with a gynecological complaint, we do a PV. When we are doing PV, what are the PV findings? MCQ zone. PV findings in endometriosis. Fixed retroverted uterus. How and why? Everything we discussed in detail in our classes. Fixed retroverted uterus. And which field, beta? Cobblestone field. Fine. This is the PV finding. Then we will do an ultrasound. In ultrasound, there may be an ovarian cyst. I will show you the image. How an ovarian cyst look like in endometriosis? This is MCQ beta. What is the name of appearance? Overlap with radiology, ground glass appearance. Endometriotic cyst appear in ultrasound, ground glass appearance. Fine beta, this is ultrasound done. Then investigation of choice for endometriosis is laparoscopy. In laparoscopy, what are seen? This cyst appear chocolate cyst. So ultrasound appearance of endometriotic cyst is ground glass appearance. I will just show you. Laparoscopic appearance I will just show you of endometriotic cyst is chocolate cyst. What else is seen in laparoscopy? These endometriotic deposits. Early lesions are tiny petechiae-like. Later lesions are gunshot or powder bun-like. And then we see adhesions also. Final diagnosis gold standard is histopathology of these things. Okay. So how to manage this condition? How to deal with ovarian cyst? If size is less than, this is MCQ. Management of ovarian cyst, if size is less than 3 centimeter, cyst aspiration. Another MCQ beta, if size is 3 or more than 3 centimeter, cystectomy. How to deal with these lesions, bluish black, petechiae-like or gunshot or powder bun? Burn them, so they will be damaged forever. What we are doing? Fulguration of endometriotic spots or cauterization of endometriotic spots. Adhesions, break them, adhesive lysis. Then you will discharge her. On discharge ticket, you will write some medicine and examiner will start framing question. The best drug to treat endometriosis, continuous GnRH, first MCQ. Most common drug to treat endometriosis, progesterone. Other drugs to treat endometriosis, other why and how we are using all this, we have discussed in detail in our classes. Best drug to treat endometriosis, continuous GnRH. Most commonly used drug to treat endometriosis is progesterone. Other drugs now, gastrinone danazole, MCQ zone with gastrinone danazole. Side effect, hirsutism, so should not be used before 35 years. Letrozole, aromatase inhibitor, and OCP also. This is the medical management of endometriosis. Now let me show you the images. Although I will take an image session along with CCD or chanting. This is the ultrasound appearance, beta. This is the ultrasound appearance of endometriotic cyst. This is the ultrasound appearance of endometriotic cyst. This is called ground glass appearance. Why it is called ground glass? We have discussed in our classes. This is medium level internal score discussed in our classes. Just remember what now? 17 days before exam, ground glass appearance. Ultrasound appearance of endometriotic cyst is ground glass appearance. Dun, 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 dun. Now, laparoscopic appearance of endometriotic cyst. This is chocolate cyst, beta. Don't confuse. Examiner can put this question like this also. So, chocolate cyst in endometriosis is a laparoscopy finding or an ultrasound finding? It is a laparoscopy finding. While ground glass appearance is an ultrasound finding, it is an ultrasound finding of endometriotic cyst. Both are endometriotic cyst, beta. Upper one, ultrasound finding, ground glass appearance. Lower one is laparoscopic finding, chocolate cyst. Then, these are endometriotic deposits. This is how they are deposited inside. This is how they are deposited inside. And because of these deposits in endometrial cavity, what happens? These deposits may fall in various structures like urinary bladder, various ligaments, etc. So there can be tear of ligament. And if there is tear of ligament, this is called Allen-Masters syndrome. I will show you Allen-Masters syndrome. Allen-Masters syndrome if a ligament is torn, as you can see here. Because of the weight of these deposits, if the ligaments are torn, if this ligament is torn off, this is the defect in ligament. Because of weight of these deposits, this is called Allen-Masters syndrome, beta. So Allen-Masters syndrome is seen in endometriosis, while Fitz-Curtis syndrome is seen in chronic PID. Fine. Most common organ involved in endometriosis is ovary, because what is next to fallopian tube? Ovary. Most common organ involved in endometriosis is ovary. This is why, beta, these two questions are important. Ultrasound appearance of endometriotic cyst, it is ground glass appearance. Ground glass appearance. While laparoscopic appearance of endometriotic cyst, this is chocolate cyst. This is chocolate cyst. This chocolate cyst is a true cyst lined by pseudoxanthoma cells. And what is the reason for this color? Hemosiderin red and original serous. We discussed in detail in our class. Here, just remember, this is chocolate cyst, laparoscopic finding, endometriotic cyst. This is ground glass appearance, ultrasound finding, endometriotic cyst. Allen-Masters syndrome seen in endometriosis. Fitz-Curtis syndrome seen in chronic PID. Fine. Most common organ involved in endometriosis, ovary. Second most common is pouch of Douglas, because finally everything will settle in pouch of Douglas. After this, let's come to adenomyosis. Just look at your notes. Your notes are just in front of you. Adenomyosis is presence of endometrium in myometrium. It is more common in multipara. More common in multipara. Most common symptom is menorrhagia. Second most common is dysmenorrhea. Now, what will be the PV finding in adenomyosis? Symmetrically enlarged uterus 1, and it is tender. This tender uterus is called which sign? Hellben sign. And just now we studied Hellben theory. Hellben theory is for endometriosis, to explain endometriosis, metastatic theory. And what is Hellben sign, beta? Hellben sign, tender uterus if you are doing PV, because everything inflammation is in myometrium. So uterus is that we discussed in our class. Hellben sign is seen in endometriosis, and adenomyosis. Hellben sign is seen in adenomyosis, while Hellben theory is to explain endometriosis. Okay. This was PV finding here. Symmetrically enlarged or asymmetrically enlarged uterus? Symmetrically enlarged uterus and Hellben sign. Then ultrasound finding, there are three findings. One is salt and pepper appearance. I will just show you. Salt and pepper appearance. Second is Venetian blind appearance. Third one is myometrial cyst. They are ultrasound finding. Investigation of choice for adenomyosis, MRI. Junctional zone thickness is more than 12 mm. Gold standard for adenomyosis is hysteroscopic curettage from endomyometrial junction. And management is total abdominal hysterectomy. Let me show you the image. Let me show you the images. This is salt and pepper appearance. This is salt and pepper appearance. Salt and pepper means salt and pepper, black and white, black and white. They are due to endometriotic deposits here. Salt and pepper appearance in adenomyosis. Second one is Venetian blind appearance. We discussed in our classes why it appears as Venetian blind. We discussed in detail in our classes. So this is Venetian blind appearance as we see on our windows. Then the third one is myometrial cyst. Details we have discussed, why and how, everything we have discussed in our class. This is myometrial cyst. Fine. So these are ultrasound features of adenomyosis. After adenomyosis, uterine fibroid. Open uterine fibroid, beta. Open fibroids. Uterine fibroid. Fibroid is also called myoma. It is a laddu. It starts originating at which place? Myometrium, because that's the muscle. So fibroids originate in which part of uterus? Myometrium. They are called intramural or interstitial. If they protrude in endometrium, submucous. If they protrude outside uterus, subserous. So two questions, beta. To start with, fibroids are intramural, which are also called interstitial. Second MCQ, beta, most common type of fibroid, intramural. Maximum is intramural, 75. 15 is submucous and 10 is subserous. Everything we wrote in our notes, which are just in front of you right now. So fibroids we divide in uterine fibroids and extrauterine fibroids. Uterine, intramural or interstitial, submucous and subserous. Intramural, interstitial 75, submucous 15 and subserous 10. Then extrauterine 2, broad ligament fibroids and cervical fibroid. Cervical fibroids 2, anterior wall cervical and posterior wall cervical. Anterior wall cervical, this is the MCQ. Symptom of anterior wall cervical fibroid, your pages, your notes are right in front of you right now. Anterior wall cervical fibroid, increased frequency of micturition. Posterior wall cervical fibroid, retention of urine. Broad ligament fibroid, true broad ligament fibroid and pseudo broad ligament fibroid. True broad ligament fibroid originate in broad ligament. So it is lateral to ureter. In our notes, we have written ureter is medial to true broad ligament fibroid. So don't confuse, beta. Examiner may put it other way around as well. So true broad ligament fibroid is lateral to ureter. What we have written in our notes, ureter is medial to true broad ligament fibroid. Fine. Pseudo broad ligament fibroid originates from uterus and encroach towards broad ligament. So ureter is lateral to pseudo broad ligament fibroid, while pseudo broad ligament fibroid is medial to ureter. Fine. Most common uterine or extrauterine? Uterine. In uterine, most common is intramural or interstitial. As far as extrauterine are concerned, which one is more common? Cervical or broad ligament? Cervical is more common. Fine. So this was about classification of fibroid. Now, what is the feature, gross appearance of fibroid? They are whorled in nature. They have a pseudocapsule. Vesicles run in pseudocapsule, that is, vascularity is peripheral. They have a rubbery consistency. They are pinkish white in color. This is about gross appearance of fibroids. Now, what are the risk factors? Again, due to high estrogen, so nulliparity, obesity, high socioeconomic class, early menarche, and late menopause. Gene mutation in endometriosis was KRAS. Gene mutation in fibroids is translocation between chromosome 12 and 14. Gene mutation in PCOS CYP21. Gene mutation in PCOS CYP21. Gene mutation in endometriosis KRAS. Gene mutation in fibroid, translocation between chromosome 12 and 14. This genetics is involved here in fibroid. So risk factors for fibroid and endometriosis are almost same. What is protective for endometriosis and fibroid? Physical exercise is protective both for endometriosis and fibroid. Why and how we have discussed in detail. Physical exercise is protective, smoking is protective both for endometriosis and fibroid. Fine, physical exercise is smoking, and oral combined pills are protective for endometriosis but not for fibroid because OCP contain both estrogen and progesterone, and progesterone helps estrogen in myometrial hyperplasia. We discussed everything in detail in our classes. Right now, what you have to remember, protective factors for endometriosis, physical exercise, smoking, and OCP. Protective factor for fibroid, physical exercise, and smoking. Gene mutation in PCOS CYP21. gene mutation in endometriosis, whereas genetics involved in fibroids is translocation between chromosome 12 and 14. Fine, beta. So this was about gross appearance of fibroid, risk factors of fibroid, genetics involved in fibroid. So endometriosis, polycystic ovarian syndrome, and fibroids, they have a tendency to run in families. Now, fibroids, as far as symptoms are concerned, symptoms of fibroid will depend on its location. The most common fibroid is intramural or interstitial, and most common symptom of intramural or interstitial is menorrhagia. So, if examiner frames you this question, what is the most common symptom of fibroid? Answer will be menorrhagia. Second MCQ, what is the most common presentation of fibroid? Answer would be is most common presentation of fibroid is symptomatic. Read the question very carefully. Most common presentation of fibroid is symptomatic. Most common symptom of fibroid, then answer is menorrhagia. Most common presentation of genital TB, infertility because of fibrous bands in fallopian tube. Most common presentation of genital TB, infertility. Most common menstrual symptom of genital TB, hypomenorrhea. If not in option, then amenorrhea. Similarly here, most common presentation of fibroid is symptomatic. Most common symptom of fibroid, menorrhagia, because most common fibroid is intramural and most common symptom of intramural fibroid is menorrhagia. Fine, done. Then next MCQ. Symptoms specific to submucous fibroid, infertility, abortion, and menorrhagia. Symptoms specific, menorrhagia is not specific to submucous. Menorrhagia occurs with submucous. Two symptoms are specific to submucous, infertility and abortion. Menorrhagia occurs with intramural as well. Subserous pressure symptoms. Pressure symptoms. Wherever it is present, it will cause like this: anterior wall cervical fibroid, increased frequency of micturition; posterior wall cervical fibroid, retention of urine. Fine. And if they are on lateral wall of cervix, then they may compress veins and lymphatics, like hemorrhoids and edema will develop if they are on lateral wall of cervix. The lateral wall of cervix, neat PG question. Lymphatics and veins are compressed, so edema will develop. Fine. And hemorrhoids may develop. After that, pedunculated fibroid. If a subserous fibroid has a pedicle, that is called pedunculated fibroid. What is a wandering fibroid? If pedicle of pedunculated fibroid is broken, then it is freely moving in abdominal cavity. Everything is written in our notes word, which are just in front of you right now. So wandering fibroid is a pedunculated fibroid whose pedicle is broken. That is called wandering fibroid. Fine. Now, after these things, what are the investigations done for fibroid? Three questions as far as investigations are concerned. Investigation of choice for fibroid, ultrasound. Investigation of choice for follow-up of fibroid, ultrasound. Gold standard to diagnose fibroid, MRI. So three questions. Gold standard is MRI. Investigation of choice is ultrasound. Investigation of choice for follow-up, ultrasound. As far as complications are concerned, most common complication, hyaline degeneration. Important chocolate question. Least common complication, malignancy. How much is the incidence of malignancy? 0.5%. What are the indicators of malignancy? Because this is something dangerous. There will be sudden increase in size of fibroid. Fibroid will cause pain and change in consistency of fibroid. Other degenerations, cystic degeneration, fatty or myxomatous degeneration, calcareous degeneration. One question from calcareous degeneration. If calcium carbonate is deposited in fibroid, it is called womb stone. This is the question, beta. What is this called? Womb stone, deposition of calcium carbonate in fibroid. Then there can be atrophy of fibroid after menopause and red degeneration. Red degeneration, important topic, beta. Questions asked would be red degeneration. What is red degeneration? Pinkish white fibroid becomes red. Most common time of red degeneration, second half of pregnancy. Most common time is second half of pregnancy. Then, what is the management of red degeneration? Management is conservative. This is our question. Management of red degeneration of fibroid is conservative. That is, if she is having pain, analgesic, fever, antipyretic, vomiting, antiemetic. What examiner want to know? No surgery should be done. No myomectomy should be done. The treatment remain conservative. Then management of fibroid. To solve a question related to management of fibroid, we have to see size of fibroid. Thumb rule is if size of fibroid is less than 10 centimeter, if she is asymptomatic, we have to see for the symptoms. The thumb rule to solve the question related to treatment of fibroid is symptom. If she came to you with a pain in abdomen and the cause of pain was gallbladder stone, and incidentally when you saw uterus you found a fibroid, she says she doesn't have a problem, so it doesn't require any treatment. So it will depend on symptom. If she is asymptomatic, only follow up is required. The best method for follow up of fibroid is by ultrasound. No management, no active intervention required. No active intervention required if she is asymptomatic and size of fibroid is less than 10 centimeter. If size of fibroid is 10 or more than 10 centimeter, even if she is asymptomatic, then we tell her, kuch to kara lo, kuch to kara lo. Something should be done. So thumb rule to solve MCQ, 17 days before examination without any descriptive talk. If size of fibroid, if she is asymptomatic and size is less than 10 centimeter, observation, follow. If she is symptomatic or size is 10 or more than 10 centimeter, then treatment is done, management. Now question arises, this was the talk, when to treat. Now how to treat? Primary method of treatment is surgery. Fibroids need surgery. Now which surgery? Now it will depend on parity. If she is nulliparous, she wants future childbearing, then we can't take out the uterus, myomectomy. If she is multiparous, she doesn't want to conceive later on, hysterectomy. So this is the thumb rule. Nulliparous myomectomy, multiparous hysterectomy. Another MCQ beta. She doesn't want surgery. Primary method of treatment in fibroid is surgery, but she doesn't want surgery. She is unwilling for surgery or there may be some contraindication for surgery. Then if she is multiparous, we can go for uterine artery embolization with polyvinyl alcohol and ether, or MRI guided focused ultrasound therapy. If she is nulliparous, we give her drugs. What drugs can be given? Because she is not willing for myomectomy. Drugs which may be given are continuous GnRH1. Then we will not give progesterone here. Why and how we have discussed. We will give mifepristone and ulipristal. Danazol, gastrinone, same thing. Side effect hirsutism, so should not be used before 35 years of age. Most common symptom with fibroid is menorrhagia. So to control local menorrhagia, to control local bleeding, this is the MCQ beta. Which drug has to be given? We have written in our notes, tranexamic acid. Tranexamic acid. What support should be given? Because she is becoming anemic very soon, iron. So supportive therapy with iron. So this was about the management of uterine fibroid. I will show you a few images related to fibroid and a FIGO classification also. So submucous fibroid, this is type 0, 1, 2. Type 0 is 100% inside endometrial cavity. Type 1 is 50% or more than 50% inside endometrium. Type 2 is less than 50% inside endometrium. And there are type 4 and 5. They are in myometrium, intramural. Then 6, 7, they are subserous, and then 8 is extrauterine or broad ligament. I'll show you a few images which are required here for understanding. Look here, few things which we need to understand as far as fibroids are concerned. This is red degeneration. This pinkish white fibroid has become red. So this is red degeneration of fibroid. In obsgyne, the images which are asked I have shown you. Not much images are asked like dermatology and radiology, but this was the FIGO classification of fibroid. 0, 1, 2. 0 is completely inside endometrial cavity. 1 is 50% or more than 50% inside. 2 is less than 50% inside. Your MCQ will finish between 0, 1 and 2 only. If by chance examiner gives you an ultrasound image and want to identify which type of fibroid it is, then we should know it. I'll show you. Look here. If this ultrasound image is given to you and examiner asks you which type of fibroid is this, and it is marked by this. So this is urinary bladder. This is a transabdominal ultrasound. This is anterior wall of cervix. This is anterior wall of uterus. This is fundus. This is posterior wall of uterus, and this is posterior wall of cervix. So this is cervix and this is uterus, and this is endometrium, and this is our laddu here. This is the laddu. This one, can you make out? This is our laddu. This is hypoechoic. So which type of fibroid is this? This is intramural fibroid, which is also called interstitial fibroid, which is inside myometrium. So intramural or interstitial fibroid. I'll show you other varieties. This is a subserous fibroid. Can you see? This is protruding out of serosa. This is anterior wall of cervix. This is a transvaginal ultrasound, anterior wall of uterus. This is posterior wall of uterus. This is posterior wall of cervix. And this is endometrium in the center. This is cervical canal, which is continuing as endometrium. And this is our laddu here. This is our laddu. So which type of laddu is this, beta? This is a subserous fibroid. Fine. Because these two, they are used in surgery. This is Boni's myoma screw. This is Boni's myoma screw. It is used to hold the fibroid. It is used to hold the fibroid when we are doing myomectomy. It is Boni's myoma screw. Another one is Boni's myoma clamp. This is Boni's myoma clamp. This is Boni's myoma clamp. It is used to release the blood supply intermittently. Otherwise, there will be necrosis, no? So we release the blood supply during surgery. This is Boni's myoma clamp, and this is Boni's myoma screw. Fine. So these were the images which were required for fibroid. I don't think anything else will be asked. This another image. One thing. This is fatty degeneration of fibroid. Can you make out? This is a fibroid with fatty degeneration. Yellowish fatty. Yeah, this yellow is fat. So this is a fatty degeneration in fibroid. While this is red degeneration in fibroid. This is cystic degeneration. This is cystic degeneration in fibroid. Cyst is developing in the center. This is cystic degeneration of fibroid. This is uterine artery embolization. This is how we do uterine artery embolization with polyvinyl alcohol and ether. This is the treatment of fibroid in multiparous when she is unwilling for surgery. MRI guided focused ultrasound wave therapy. This one I just want to show you Wombstone, deposition of calcium carbonate. This is Wombstone. This is Wombstone. When calcium carbonate is deposited in fibroid, this is the X-ray picture. Why X-ray has been taken? Because calcifications will be picked up better in X-ray. So this is a Wombstone beta. Can you see this laddu? And in this laddu, calcium carbonate is deposited. This is calcareous degeneration in fibroid. What is this? Calcareous degeneration in fibroid. And calcareous degeneration in fibroid is called Wombstone. Fine. So, after fibroids, uterine prolapse. So, we have discussed two prolapse, uterine prolapse and vaginal wall prolapse. So, let's begin with uterine prolapse first. Uterine prolapse. First question will be related to risk factor. So, most important risk factor for uterine prolapse is mismanaged which stage of labor? Second stage of labor. That's the most important risk factor for uterine prolapse. Other risk factors, multiparity, menopause, increased abdominal pressure like COPD, ascites, or marked obesity. Fine, so prolapse will be more in that. The most important risk factor for uterine prolapse is mismanaged which stage of labor? Second stage of labor. This was about risk factor. Then classification of prolapse. Old classification, Shaw's classification. Everything is in our notes. Look at the pages. Shaw's classification is stage 1, prolapsing part is in vagina. Second stage, prolapsing part at vaginal introitus. Third stage, prolapsing part outside vaginal introitus. Fourth stage, whole uterus outside. That is called precedentia. That was old staging. Latest staging, reference point is hymen. If lower edge or leading edge of prolapsing part is more than 1 centimeter above hymen, is stage 1. Within 1 centimeter above to 1 centimeter below hymen is stage 2. More than 1 centimeter below hymen is stage 3. And stage 4 is stage 3 plus complete vaginal eversion. That is a stage. Then what are her symptoms? She will say, Doctor Saab, something is coming out, feeling of insecurity in vagina, and ulcers will develop on prolapsing part. These ulcers are due to venous congestion. So how to manage with these ulcers? We pack these ulcers with glycerin and acryflavin, and then we deposit the prolapsing part inside. Glycerin is a hygroscopic and acryflavin is an antiseptic. So we pack with glycerin and acryflavin. That's the local management of ulcer. Very important MCQ here, beta. Ulcers in prolapsing part are due to venous congestion. Ulcers in prolapsing part are due to venous congestion, and examiner is ready to trap you here with friction. Fine, so they are due to venous congestion. So this was about symptoms of prolapse. Now, how to manage prolapse? What is the management of prolapse? Management of, regarding supports, they were discussed in anatomy, but I will repeat two questions which are very important. Most important support to uterus is by levator ani or pelvic diaphragm. Second MCQ beta, most important ligamentous support to uterus. It is by cardinal ligament, which is also called McEnroe ligament, cardinal ligament, which are also called McEnroe ligament or transverse cervical ligament. So read the question very carefully, beta. Most important support to uterus is by levator ani or pelvic diaphragm. Most important ligamentous support to uterus is by transverse cervical ligament or cardinal ligament or McEnroe ligament. Fine, beta? Okay, so this was about support. Now, management. To solve a MCQ related to management of prolapse, we have to look for parity. If she doesn't want future childbearing multiparous, we will do Ward-Mayo vaginal hysterectomy. If she wants future childbearing, she is nulliparous. Then abdominal sling operation. Abdominal sling operation is also called cervicopexy. Cervicopexy, which material is used? Marceline tape. If it is attached to rectus sheath, Purandre abdominal sling operation. Rectus sheath is anterior, so Purandre abdominal sling operation is an anterior sling. It is a dynamic sling, beta. Healthy है ना? Dynamic sling. So it provides less support and less complication. If you are attaching it to sacral promontory bone, beta, fixed. It is a fixed sling, a static sling. It is a posterior sling, sacral promontory is posterior. It provides more support but has more complications also. हड्डी घिसती है ना, bone घिसती है. Fine. So Purandre abdominal sling operation, anterior sling, dynamic sling, provides less support, less complication. Shirodkar abdominal sling operation, posterior sling, static sling, provide more support but has more complication. What are complications of Shirodkar on left side? Obstruction of sigmoid colon, compression of ureter, injury to genitofemoral nerve. This is why ideally what we do, Shirodkar on right side, because we want more support from Shirodkar also. So Shirodkar on right side and Purandre on left side. And this combined operation is called Virkud abdominal sling operation. Why I took your 1.5 minutes? Your MCQ in 90% case will finish at if she is nulliparous abdominal sling operation, which is also called cervicopexy, beta, pexy. Fine. But examiner may frame which pexy, Purandre or Shirodkar or Virkud. So out of these three, which one is best? Virkud's abdominal sling operation. Second MCQ, if she is multiparous, Ward-Mayo vaginal hysterectomy. Third MCQ, she is multiparous but unwilling for surgery. Maybe because she is around 40, 38, 37. Fothergill's operation. Another name of Fothergill's operation, Manchester. You have to remember name of operation only. Fothergill's operation or Manchester operation. Another MCQ beta. There is a Shirodkar modification of Fothergill. Difference between Fothergill and Shirodkar modification of Fothergill is in Fothergill cervical amputation is done, while in Shirodkar modification cervical amputation is not done. Another MCQ. If her age is around 60 or 60 plus, what is done? Leaf fold colpoclysis and Daniel stitching. Another MCQ. What is the treatment of vault prolapse? Vault prolapse. 2. Via abdominal route, sacral colpopexy. Via vaginal route, sacrospinous fixation. And if you have to choose between these two, sacral colpopexy is the best to treat vault prolapse. Then treatment of prolapse in pregnancy is by ring pessary. Another question, beta. What are other indications of ring pessary apart from this? Apart from pregnancy, so ring pessary are used to treat prolapse in puerperium and ring pessary are used to treat prolapse in young girls who are unwilling for surgery or in whom there are some contraindications for surgery. Now, there's a word called prevention of prolapse. So, prevention of prolapse is by which exercise? Kegel exercise. Prevention of prolapse is by Kegel exercise. So, this was about uterine prolapse. Then we wrote a vaginal wall prolapse. What is the cause of vaginal wall prolapse? Endopelvic fascia defect. Cause of uterine prolapse? Mismanaged second stage of labor. Cause of vaginal wall prolapse? Endopelvic fascia defect. Now, types of vaginal wall prolapse: cystocele, urethrocoele, enterocele, rectocele, and lex perineum. What is cystocele? Prolapse of upper 2/3 of anterior wall of vagina along with urinary bladder, cystocele. Urethrocoele, prolapse of lower 1/3 of anterior wall of vagina along with urethra. Enterocele, prolapse of upper 1/3 of posterior wall of vagina along with pouch of Douglas. Rectocele, prolapse of middle 1/3 of posterior wall of vagina along with rectum. Lex perineum, isolated prolapse of lower 1/3 of posterior vaginal wall. Everything is in front of you in your notes, word by word. Fine. So these are the types of prolapse. Out of these, which one is most common? Cystocele. So most common vaginal wall prolapse is cystocele. Overall most common type of prolapse is also cystocele. Fine. Now, what is the management? Management for cystocele and urethrocoele, anterior colporaphy. Here, beta, don't confuse. Raphy. Raphy means repair. So, management for cystocele and urethrocoele is anterior colporaphy. While this is for vaginal wall prolapse. Management of uterine prolapse in nulliparous was cervicopexy, beta. Don't confuse. That was cervicopexy. And this is raphy. Clear, beta? Now, management of rectocele and lex perineum, posterior colpoperineoraphy. Which one? Posterior colpoperineoraphy. And management of enterocele, Moskowitz repair. Fine. So this is how we manage it. Overall, most common prolapse is cystocele. Most common risk factor for uterine prolapse, mismanaged which stage of labor? Second stage of labor. And most common cause of vaginal wall prolapse is endopelvic fascia defect. Now, fistula. After prolapse, fistula. We discussed 3 urinary fistula: uretrovaginal, vesicovaginal, and urethrovaginal. In fistulas, you should know what is the cause, what are the symptoms, what is the screening test, what is the definitive test, what is the management, what is the timing of management. Okay, so most common fistula is vesicovaginal fistula. Most common prolapse was cystocele. Most common fistula is vesico. This is 1 o'clock. 1 o'clock. Kabhi gaini nahi hua. This is 1 o'clock. Okay, don't worry. We'll finish. Okay. Most common fistula is vesicovaginal fistula. Okay. So what are the symptoms? Vesicovaginal fistula, your MCQ will be here. Vesicovaginal fistula symptoms are continuous dribbling of urine through vagina and no normal micturition. Uretrovaginal fistula, continuous dribbling of urine through vagina with normal micturition. Urethrovaginal fistula, dribbling of urine only at the time of micturition. These are symptoms. Most common fistula is vesicovaginal. Now causes. Cause of vesicovaginal fistula. Most common cause of vesicovaginal fistula in developing country, obstructed labor. Developed country, simple hysterectomy. We have written this word by word. Now, what is the screening test? Methylene blue 3-swab test. So methylene blue 3-swab test, what is filled in bladder? Methylene blue. And we put 3 cotton balls. Now what is the interpretation? If topmost swab is wet but not blue, it is uretrovaginal. If middle one and lowermost they are blue and wet, vesicovaginal. If only lowermost is stained, this is urethrovaginal. Definitive test for vesicovaginal and urethrovaginal cystoscopy. For uretrovaginal, IV indigo carmine and IVP. Fine. Now, vesicovaginal fistula, what are the management part? Pre-op, operative and post-op management. Most important aspect in pre-op management, urine culture sensitivity. Operation, you have to remember 2 names, Chesser-Mayer and Let's Go Repair. Post-op management, very important question. Most important aspect in post-op management of vesicovaginal fistula is continuous catheterization of urinary bladder for 2 weeks. Rule of 2. In front of you in your notes. Continuous catheterization of urinary bladder for 2 weeks. What else? No per speculum per vaginal examination or intercourse for 2 months. No pregnancy is allowed for 2 years. And if she becomes pregnant, baby will be taken out by which cesarean section? This is MCQ. Classical cesarean section. Now timing of repair. If it is diagnosed within 24 hours, immediate repair. If diagnosed after 24 hours, repair after 6 weeks. Why and how of everything we have discussed in detail in our classes. Then uretrovaginal fistula, very rare. Most common fistula, vesicovaginal. Rare one is uretrovaginal. How it happens? Due to fall on a penetrating object. Management is repair. Uretrovaginal fistula, important MCQ here. Most common cause of uretrovaginal is which hysterectomy? Vardyne. While in vesicovaginal fistula, most common cause of vesicovaginal in developed country is simple hysterectomy. While most common cause of uretrovaginal fistula is Vardyne hysterectomy. Now, management of repair, you have to remember name. Vesicovaginal, Chasser-Mayer and Let's Go. Uretrovaginal, Boari flap repair. And here repair is done immediately. Fine. Then one word is menuria. Meaning of menuria, hematuria at the time of menses. 2 causes. One is endometriosis of bladder and second is a fistula. Which fistula? Utrovesical or vesicouterine. Management accordingly. Endometriosis treated, fistula repaired. No specific name. Rectovaginal fistula between rectum and vagina. Most common cause, complete perineal tear. And cause of complete perineal tear is 4-degree perineal tear. And cause of complete perineal tear is occipito-posterior position. Everything is in front of you word by word in your notes. Fine. Occipito-posterior position. How will she present? Passage of feces through vagina. Management, initial colostomy followed by repair after 3 months. That is the management for rectovaginal fistula. Then infertility. Infertility, we'll take a lunch break, I think, at देखते हैं जितनी देर तक बोलता हूँ. Till what time I can speak? Maybe at 1:30. 1:30 से पहले तो नहीं लेंगे. Either at 1:30, any time between 1:30 and 2, we'll take a lunch break for 30 minutes. Fine. Infertility. Infertility definition is failure to conceive. Failure to conceive even after 1 year of unprotected intercourse. Unprotected and regular. That's the difference. And sterility is permanent damage. It is irreversible due to permanent damage to sperm or ovum, gametes. That is sterility. So sterility is irreversible, infertility is reversible. Now infertility can be primary infertility or secondary infertility. Primary infertility, she never conceived before. Secondary infertility, she conceived before but now having difficulty. Okay. This is the definition of infertility, sterility and primary and secondary. Then infertility causes. Female factors 45%, male factors 35%, and combined factors 10%, unexplained 10%. So females are little more responsible. In females, ovarian factors 45%, tubal factors 35%, uterine and cervical factors 10%, unexplained 10%. So overall most common is ovarian factor. And what you want from ovary? Oocyte. So anovulation. So we get many MCQs here. Most common cause of infertility, anovulation. Most easily diagnosed cause of infertility, anovulation. Most easily treatable cause of infertility, anovulation. So overall, most reversible form, 4-4 MCQ beta, 4-4 MCQ. Most reversible form of infertility is due to anovulation. Fine, this is done. And now the question arises: what is the cause of this ovarian factor, ovarian dysfunction? The most common here is HPO axis dysfunction, responsible in 85%. HPO axis dysfunction, and this dysfunction mostly is due to what? PCOS and hyperprolactinemia, mostly PCOS. There may be HPO axis failure also, and there may be premature ovarian failure also. Everything is in front of you, in front of your notes, word by word. Fine, I am not speaking anything anonymous or ridiculous. I am just following your notes only and trying my best not to speak anything beyond your notes. Otherwise, you will start looking at me and staring at me what I am speaking. So you can understand how, in a balanced way, I am taking this revision class. I am just following your notes word by word. Fine. So HPO axis dysfunction is the most common cause. And of this, polycystic ovarian syndrome is the most common. Fine. How to diagnose anovulation? Diagnosis of anovulation, 3 MCQs beta. Best method to diagnose anovulation, serum progesterone estimation done on day 22. It should be at least 3 nanogram per ml. Second MCQ. Most commonly used method to diagnose anovulation, answer is serial ultrasound. Second MCQ. The serial ultrasound is started on which day? It is started on day 10. Third MCQ here. What is the evidence of ovulation? Ruptured follicle plus free fluid in pouch of Douglas. Okay. So best is serum progesterone estimation done on day 22. Most common is serial ultrasound, not ultrasound beta, serial ultrasound. And this is started on which day? Day 10. Fine. Other investigations which can be done to diagnose anovulation, in vagina maturation index. After ovulation, it should shift from, speak out in your room, right to left. Then cervix mucus. After ovulation, if you examine cervical mucus on day 22, maturation index on day 22, it should be 0,70-30. Cervical mucus study on day 22, it should be thick, it should break, and there should be no furning. Endometrial biopsy, if you do on day 22, it should show vacuolation. It should not show short tubular glands. Fine. But 2 MCQs best is serum progesterone. Most common is serial ultrasound. That is to diagnose anovulation. What is the predictor of ovulation? How to predict? Prediction is done with LH kits. Prediction is done with LH kits. So read the MCQ very carefully. How to diagnose and how to predict. Predictor of ovulation is by LH kits. Fine. So how to manage if you have diagnosed anovulation? Management. So management of anovulation, if it is due to PCOS, then letrozole, otherwise clomiphene citrate. Otherwise clomiphene citrate. So we can give letrozole or clomiphene citrate if it is due to PCOS, letrozole. Otherwise clomiphene citrate. We can give HMG, human menopausal gonadotrophin. We can give pulsatile GnRH. And if hyperprolactinemia is there, then bromocriptine is there. If bromocriptine is given, if prolactin levels are high, what is the management for hyperprolactinemia? Bromocriptine. Fine. Then, after this anovulation, tubal problem, tubal block. What can happen in tube? Tubal block. Most common cause of tubal block is PID. Other causes, endometriosis. Other problem in tube, Carter-Jenner syndrome, ciliary dysfunction, you know. Now the question arises, how to diagnose tubal block? There are 3 ways. Laparoscopic chromoperturbation, sonosalpingography and hysterosalpingography. Next question, what is the best? Laparoscopic chromoperturbation. Next question, what is the best day to perform? Whether it is a laparoscopic chromoperturbation or a sonosalpingography or a hysterosalpingography, best day is day 10. So best method is laparoscopic chromoperturbation. Best day is day 10. Now, tubes can be blocked at proximal ends, in middle part or in distal part. So most common cause of bilateral proximal tubal block is physiological spasm. This question, most common pathological cause of bilateral cornual block or proximal block, genital TB. If pathological void is not written, answer will be physiological spasm. If pathological void is written, answer would be genital TB. Proximal block हो जाएगा. Okay, so if you see a proximal tubal block, it could be due to physiological spasm. What should be next step? So hysteroscopic guided tubal cannulation. We try to pass a cannula. And if we are able to pass the cannula, then we confirm the procedure with laparoscopy that tubes are khul gaya, they are patent now. Fine. And if it is pathological cornual block, in vitro fertilization, IVF. If it is distal block, for mild distal block, we can try to repair fimbria because that is at fimbrial block. Fimbrioplasty, that is theoretical. Finally, we have to do IVF. If it is a mid-part block, mid-segmental block, that could be due to we have performed a tubal ligation and that ligature has slipped now. So then we have to do recanalization. Overall, for our exam, in 80% case, examiner will finish the question as a chocolate question. And chocolate question would be best management of tubal block overall is in vitro fertilization, beta, IVF. Best management of tubal block, IVF. Done, done. But if examiner dissect the question, most common cause of bilateral proximal block, physiological spasm. Second question, most common pathological cause of bilateral proximal block, genital TB. Most common cause of bilateral mid-segmental block, history of tubectomy. But now something unfortunate might have happened to her and she want to conceive again. Then what we have to do? Recanalization. Okay. So best management of tubal block, done in vitro fertilization. Then uterine and cervical factors. Uterine factors there can be uterine fibroid, there can be septate uterus that we have discussed. Cervical factors, anti-sperm antibodies may be present in cervix. What they do, they reject sperm. Now the question arises. Anti-sperm antibodies, they are not seen by naked eye, they are not seen by ultrasound. So the question is, how to diagnose anti-sperm antibodies in cervix? Name of the test, postcoital test, which is also called Sims test, which is also called Hunner's test. Now next question is, when to perform this postcoital test or Sims test or Hunner's test? Day 10 to 12. Day 10 to 12. Answer is day 10 to 12. How many slides are prepared? 2 slides. When do you call her? 2 hours after intercourse. When do you call her? 2 hours after intercourse. Fine. 2 slides are prepared. Abnormal movement of sperms will be seen in which slide? Which is prepared from cervical canal. So if you have diagnosed anti-sperm antibodies, what is the management? Intrauterine insemination, popularly known as IUI. Another problem in cervix can be poor cervical mucus. That is detected by insular scoring system. Insular. Normal score is 10 to 12. Normal score is 10 to 12. So insular score detects status of cervical mucus. So in cervix there can be 2 problems. One is poor cervical mucus. Second is presence of anti-sperm antibodies in cervix. And how to treat whether it is a case of poor cervical mucus or anti-sperm antibodies in cervix, it is done by intrauterine insemination. Now another question arises. What are other indications of IUI apart from this immunological problem? Other indications of IUI. When do you want to do intrauterine insemination? Impotence, vaginismus, epispedia, hypospedia, retrograde ejaculation, or in cases of mild oligospermia. Another question, beta. In intrauterine insemination, washed semen is used or unwashed semen is used? Washed semen is used. Another question, beta. What is the best method for semen washing? Density gradient method. Swim up is another technique, swim down is another technique, but the best method is density gradient method. Another question, beta. In IUI, insemination is done at which place in uterus? Insemination is done near tubal ostia, where the tubes are opening, so that it can be directly picked up by fallopian tube. So washed semen, 0.5 ml, loaded in IUI cannula, inseminated near tubal ostia. Best method for semen washing is density gradient method. Which method, beta? Density gradient method. And we have discussed other indications of IUI also. Now, male factor. Male factor, seminogram. What is WHO normal seminogram? Amount of semen, it should be at least 1.5 ml. Sperm count, it should be at least 15 million per ml. Normal morphological forms, they should be at least 4%. Progressively motile forms should be at least, everything is in front of you in your notes. Progressively motile forms should be at least 32%. Total motile forms should be at least 40%. Viable sperms should be at least 58%. Leukocyte count should be less than 1 million per ml. If anything is deranged, then this is called abnormality. Let's just start with. First one, a semen amount should be at least 1.5 ml. If amount of semen is less than 1.5 ml, it is called hypospermia. What is it called? Hypospermia. If it is more than 5.5, although it's not a, upper one is not WHO cutoff, but in our language, if amount of semen is more than 5.5 ml, we call it hyperspermia. Semen amount less than 1.5 ml, hypospermia. More than 5.5 ml, hyperspermia. Morphologically, sperm count less than 15 million per ml, oligospermia. 10 to 15, mild oligo. 5 to 10, moderate oligo. Less than 5, severe oligo. Morphologically normal sperms, if less than 4%, teratospermia. Progressive motility, if less than 32%, asthenospermia. Viable sperms, if less than 58%, necrozoospermia. Leukocyte count, if less than more than 1 million per ml, leukocytospermia. And you know the sperm structure. If sperm cap is absent, acrosomal cap is absent, and it is a round-headed sperm, it is called globozoospermia. Now, problems in male can be divided in three categories: pre-testicular problem, testicular problem, and post-testicular problem. And these three can be differentiated by estimation of FSH, LH, and testosterone. Pre-testicular means hypothalamic or pituitary problem. So FSH, LH, testosterone, all three will be less. Testicular problem, if testis is damaged, testosterone will be less, but FSH and LH will be high. Post-testicular, hypothalamus, pituitary, testis normal, but there is an obstruction in vas deferens. So FSH, LH, and testosterone, all three will be normal. This is how we can differentiate. Then we discuss three questions. A male presents with azoospermia and normal FSH, LH, and testosterone. What is the next step? Next step is TESA, testicular sperm aspiration. Best management is MISA, microscopic, microsurgical, epididymal sperm aspiration. So next step is TESA, best management is MISA. Next question, beta. If a male presents with azoospermia and failed MISA, what is the next step? TDI, therapeutic donor insemination. TDI, which is also called IUID, IUI with donor. How to treat asthenospermia if sperms are not motile? If sperms are not motile. See, if you are doing in vitro fertilization, I will show you few images of infertility. If you are doing in vitro fertilization, what is important? Sperm should be motile. You drop the sperm, then sperm reach oocyte on its own. If sperm can't move, how to treat asthenospermia? The best is with ICSI, intracytoplasmic sperm injection. I will show you. ICSI is we are directly injecting sperm into the cytoplasm of the oocyte. So, what are the indications of ICSI? One is asthenospermia, second one is obstructive azoospermia, third one is severe oligospermia. So, for mild oligospermia, IUI, we discussed in other indications of IUI, mild oligospermia, that is 10 to 15. Moderate oligospermia, we do IVF. Severe oligospermia, we do ICSI. Let me show you few images related to infertility. Look here. Relevant images I want to show you. One is this image may be given in exam by chance, although not likely. What we are doing oocyte aspiration. This is the needle. This needle is going inside the follicle, and we are doing oocyte aspiration for IVF or for ICSI.
oocyte aspiration. Then how IVF is done? I will show you that katori petri dish. We put this in after aspiration. After this aspiration, we aspirated oocyte from follicle, and then we put it in this petri dish, and then we drop sperm. So which property of sperm is essential for IVF? Motility is required. Then we put it in incubator, and on day 5 when blastocyst is formed, embryo transfer is done. So embryo transfer in IVF is done on day 5. Previously we were doing on day 3. Day 5 blastocyst is formed, so results are better. Now, I will show you an image of ICSI, intracytoplasmic sperm injection. This is how we do ICSI beta. Intracytoplasmic sperm injection, we are directly injecting sperm directly into the cytoplasm of oocyte. Now I will show you an image of IUI also. You should know how IUI is done. This is how we do IUI beta. This is how we do. You see, this is the IUI cannula or called IUI catheter. And with this IUI cannula or IUI catheter, we are inseminating near tubal ostia. So they can directly be picked up inside fallopian tube. This was about infertility. Now, after infertility, menopause. What is the definition of menopause? Definition of menopause. This is single liner chocolate question. Absence of menses for at least 1 year. Absence of menses for 1 year, stoppage of menses for 1 year. In which age group? Menopausal age. Now the next question is, how much is the menopausal age? If examiner asks you menopausal age is, answer is 51 years. If examiner writes menopausal age in India, then it would be 47. Menopausal age, nothing is written, 51. Menopausal age in India or developing countries, 47. This is age. So what is happening at menopause? Ovarian function is reducing. So ovarian function is reducing, so ovary is not secreting adequate estrogen. So estrogen is decreasing. Estrogen is decreasing, progesterone is decreasing. So what is increasing? Because estrogen is decreasing, FSH is increasing. Because progesterone is decreasing, LH is increasing. So in a menopausal female, estrogen and progesterone are less and FSH and LH are high. Important chocolate question. This is why HMG infection, human menopausal gonadotrophin, what is the best source for preparation of HMG injection? Urine of menopausal female. Urine of menopausal female. Okay. Now, what is happening due to this? Endometrial proliferation will not occur, uterine size, myometrial hyperplasia, actions of estrogen, progesterone. So, uterus will become small after menopause, endometrium will become thin. Another chocolate question. How much is the cutoff thickness of endometrium after menopause? So, according to American College of Gynecology, upper limit is 4 millimeter. But according to International Federation of Obstetricians and Gynecologists, which is called FIGO, it is 5. You remember FIGO 5, FIGO 5. So according to FIGO, after menopause, maximum acceptable thickness of endometrium is up to 5 mm. And according to American College of Gynecology, maximum up to 4 mm. It's very important chocolate question. Fine, this has happened. But some symptoms also appear due to decreased estrogen. First question, most common symptom of menopause, most characteristic symptom of menopause, earliest symptom of menopause. Answer to 3 MCQ. Most common symptom of menopause, most characteristic symptom of menopause, earliest symptom of menopause is hot flushes. What is this? Hot flushes. Drug of choice for hot flushes, Tibolon. Drug of choice for osteoporosis, bisphosphonate. I will add one line, important pharmacology question also. Drug of choice for any type of osteoporosis beta, not only postmenopausal osteoporosis. Drug of choice for any type of osteoporosis is bisphosphonate. What else will happen? Vaginal dryness, itching, which is called senile vaginitis. Management is local estrogen cream. Decreased libido, androgens. Sagging or wrinkling of skin, estrogens. There is more risk of heart disease. But we don't give this hormone replacement therapy for heart disease, we refer it to cardiologist. Whatever we are giving, this is called hormone replacement therapy beta, because estrogen is less, we are replacing estrogen. And the thumb rule is, if Uterus is intact, we add progesterone along with estrogen. If hysterectomy has been done, only estrogen can be given. We know this very well. Very important MCQ. What is the absolute contraindication of hormone replacement therapy? Answer is history of thrombosis. And if there is history of thrombosis, DVT, how it is given? By transdermal estrogen patch. By transdermal estrogen patch. Now, few chocolate questions. What is premature menopause? If menopause occurs before 40 years of age. Most common cause? Genetics. Most common cause is genetics. And if a female with premature menopause wants to conceive, in vitro fertilization with donor oocyte. What is the best method of ovarian activity assessment? It is by anti-Mullerian hormone, AMH. Other methods, serum FSH, but it has to be done only on day 3. Ultrasound, we count the number of follicles. But the best method is by anti-Mullerian hormone because it can be done on any day. So this was about menopause. After menopause, endometrial and cervical cancer. I think we will finish endometrial and cervical cancer in 15-20 minutes and then we will take a break. And then we will begin with, after break, we will begin with placenta. Endometrial cancer. Endometrial cancer means endometrium is markedly thick, which is due to estrogen. So risk factor is high estrogen. So what are the risk factors for endometrial cancer? Risk factors for endometrial cancer, high estrogen will be more in nulliparity, obesity, early menarche, late menopause. Here take care. Examiner traps you with late menarche and early menopause. So it is nulliparity, obesity, early menarche, late menopause, and high socio-economic class. Which one? High socio-economic class. So they are risk factors for endometrial. Other ones are genetics is involved. Genetics is involved in endometrial cancer. What genetics is involved? It depends on type 1 and type 2. For type 1, P10 and KRAS gene mutation. For type 2, P53 gene mutation. Family history is responsible. Corpus cancer syndrome is a combination of diabetes, obesity, hypertension, and endometrial cancer that we have written separately. If there is history of treatment with tamoxifen, tamoxifen is estrogen agonist on endometrium and estrogen antagonist on breast. This is why tamoxifen is given to treat breast cancer. It can treat breast cancer but can cause which cancer? Endometrial cancer. If there is history of infertility and we have used various drugs which can later on cause endometrial cancer, history of polycystic ovarian syndrome, and if there is atypical endometrial hyperplasia, there are risk factors for. What are the protective factors for endometrial cancer? Physical exercise, smoking, and oral combined pill. How and why we have discussed in much detail in our classes. So this is endometrial cancer. Now, most common symptom of endometrial cancer, irregular bleeding PV. Most specific symptom of endometrial cancer, postmenopausal bleeding. So if a patient presents to you with postmenopausal bleeding, what is the first step? Ultrasound. Of course, if she is married, TBS. If endometrial thickness is more than 4 mm, I told you 4 and 5, but we will first follow ACOG. If 4 is not given and 5 is given, then we will choose 5. If 4 and 5 both are given, my take is 4. So if endometrial thickness is more than 4 mm, what we will do? Screening test for endometrial cancer, endometrial aspiration biopsy. Then if it is inconclusive, what is the definitive test? Definitive test for localized lesion, hysteroscopic biopsy. Definitive test for diffuse lesion, fractional curettage. In fractional curettage, we take 7 samples. Fine. Then we have taken and we have sent it to pathologist and pathologist will send the report. If it is a cancer, pathologist will write adenocarcinoma because the lining in endometrium is columnar. If it is not a frank cancer, pathologist will only write endometrial hyperplasia. So in endometrial hyperplasia, beta, there can be 4 types of MCQ. MCQ number 1, simple hyperplasia without atypical cells. How much is the risk of progression to frank malignancy later on? 1%. Second MCQ, complex hyperplasia without atypical cells. How much is the risk of progression to frank malignancy later on in life? 3%. Simple hyperplasia with atypical cells, 8%. Complex hyperplasia with atypical cells, 30%. So these are 4 MCQs. Out of these 4, I find the most potential is 4th one. And examiner may put this MCQ like maximum risk of conversion to frank malignancy later on in life if it is which type of hyperplasia? Complex hyperplasia with presence of atypical cells. Fine. How to manage endometrial hyperplasia? If atypical cells are absent, progesterone is enough, medroxyprogesterone acetate. If atypical cells are present, then surgery. In surgery, there will be two questions. If her age is less than 45, TAH, only TAH, total abdominal hysterectomy. 45 or more than 45, TAH plus BSO. How and why? We have discussed in detail in our classes. TAH plus BSO. Fine. Now, if it is a frank cancer, this can be two types. Most common histopathological variety is type 1 endometrial cancer or endometrioid adenocarcinoma. Rare but more dangerous is type 2, type 2 or non-endometrioid adenocarcinoma. In type 2 or non-endometrioid, most vulnerable is clear cell carcinoma. Second most vulnerable is papillary serous carcinoma. Fine, beta. So most common histopathological variety is type 1 or endometrioid. Rare but more dangerous is type 2 or non-endometrioid. Fine. Type 1 is estrogen dependent. So it is more common in white females and obese females. Gene mutation responsible is P10 and KRAS. Type 2 non-estrogen dependent, so not related to white and obese female. Gene mutation responsible in type 2 is P53. P53. Fine. Now staging in endometrial cancer is surgical. Most common route of spread is direct spread. Most common site of recurrence is vagina. Stage 1 of endometrial cancer 1A, confined to endometrium or less than 50% of myometrium. 1B, either 50% or more than 50% of myometrium has been infiltrated. Stage 2, cervix is involved. Stage 3A, serosa adnexa peritoneum. Stage 3B, vagina. Stage 3C1, pelvic lymph nodes. Stage 3C2, para-aortic lymph node. 4A, regional metastasis, either to urinary bladder or rectum. 4B, inguinal lymphadenopathy. 4B is distant metastasis. 4B is distant metastasis. MCQs will be, if inguinal lymphadenopathy is seen in endometrial cancer, what is the stage? 4B. Don't confuse beta. Pelvic lymph nodes 3C1. Para-aortic lymph nodes 3C2. Inguinal lymphadenopathy 4B. Second question beta. If ascites develops with endometrial cancer, what is the stage? 3A, when peritoneum is involved. A very important MCQ has been asked 500 or more than 500 times. If vagina is involved in endometrial cancer, what is the stage? 3B. I think they are asking this question because most common site of recurrence in endometrial cancer is vagina. Now, treatment of endometrial cancer. Treatment depends on staging and grading. You know the meaning of grading. This is pathology. Well differentiated, moderately differentiated, poorly differentiated. If it is stage 1A, grade 1, 2. 1A, grade 1, 2. What we are doing? Total abdominal hysterectomy and bilateral salpingo-oophorectomy. Pelvic lymph node dissection is done if size is 2 cm or more than 2 cm. If size is less than 2 cm, no pelvic lymph node dissection is done. No post-op therapy is required in 1A grade 1 and 2. Then 1A grade 3 and 1B, TAH plus BSO, pelvic and para-aortic lymph node dissection followed by radiotherapy. So post-op radiotherapy is required. Then stage 2 hysterectomy change, Vardheim hysterectomy, rest everything is same. Pelvic para-aortic lymph node dissection followed by radiotherapy. Stage 3 and 4 again surgery change, debulking surgery, rest everything same. Pelvic and para-aortic lymph node dissection followed by chemoradiation. Instead of radiotherapy, chemoradiation. And which chemotherapeutic drug is used as a radiosensitizer? It is cisplatin. So this is the treatment of endometrial cancer. Then cervical cancer. Cervical cancer, most common cause of cervical cancer, HPV 16. It affects ectocervix. So cause which one? Squamous cell carcinoma. Most specific for cervical cancer is HPV 18, which affects endocervix. So cause which one? Adenocarcinoma. So most common cause of cervical cancer, HPV 16. Most specific for cervical cancer is HPV 18. What is the cofactor? Cofactor is HIV. Other risk factors for cervical cancer, it is more common in multipara because pregnancy is the risk factor. Multipara, pregnancy, anemia, smoking, use of OCP, multiple sexual partners because HPV is transmitted sexually. low socioeconomic class, poor hygiene, because infections are more common in these. Fine. So cervical cancer is more common in multipara. Endometrial cancer is more common in nullipara. Okay. Most common site of cervical cancer, transformation zone or squamocolumnar junction. Because normally metaplasia occurs and the site is squamocolumnar junction. Columnar cells of endocervix convert to squamous cells of ectocervix, and the place at which it happens is called squamocolumnar junction or transformation zone. So most common site of cervical cancer is squamocolumnar junction or transformation zone. Very important chocolate question. Now, if abnormal cells are formed instead of formation of normal cells, this is called dysplasia. And if this dysplasia is involving only epithelium, this is called cervical intraepithelial neoplasia, CIN. Now we have written everything in front of your notes. In front of you, it is in notes. CIN1, less than one third of epithelium is involved. CIN2, one third or more than one third, but less than two third of epithelium is involved. CIN3, two third or more than two third, but less than whole thickness. Carcinoma in situ, whole thickness is involved. And invasive cancer when basement membrane is broken. Basement membrane is intact till carcinoma in situ. If basement membrane is broken and cancer spreads out of basement membrane, this is called invasive cancer. Fine. Bethesda gave new classification. Bethesda said CIN1 as LSIL, CIN2, 3 and carcinoma in situ as HSIL. What is LSIL? Low grade squamous intraepithelial lesion. HSIL, high grade squamous intraepithelial lesion. This is Bethesda's new classification. And invasive cancer as invasive cancer. Now, what is the most common age range? CIN 1 to 3, they usually happen between 20 to 29 years. Carcinoma in situ 30 to 35 years. Invasive cancer 35 to 39 and 55 to 60 years. Bimodal incidence. So what is the screening test? The best one is Pap smear. In rural area, Willi and Via. Willi visual inspection with leukocidine, Via visual inspection with acetic acid. You know, with acetic acid, abnormal area become white, and with leugol iodine, normal areas become brown due to glycogen. But best is Pap smear, which was invented by George Papanicolaou. How many slides prepared? 3 slides. It is started at which age? 21 years. 21 years to 29 years, done every 3 years. 30 years to 65 years. What is best? Co-testing. What is co-test? Combination of Pap smear and HPV DNA, which is done at an interval of 5 years. But if she is living in those areas where facilities for co-test is not available, Pap smear is done, which is done every 3 years. We can stop screening at 65 years of age if last 10-year reports were normal. But if they were abnormal, we continue screening till what age? 75 years. Another MCQ here, beta. If she is HIV positive, because HIV is a cofactor, if she is HIV positive, then annual screening is done. This is the Pap smear screening protocol. Viral proteins which are required for attachment to epithelium, they are L1 to L2. L1 to L2. Fine. This is the most important out of everything. Now, Pap smear has been done. She will come with Pap smear report. If Pap smear report is normal, we will reassure her and will call for routine screening. Second MCQ. If Pap smear report shows infection, what is the next step? Treat infection and repeat Pap smear after 2 to 4 months. Mean is 3 months. Which infections can be diagnosed by Pap smear? Trichomonas can be diagnosed, HPV can be diagnosed, herpes can be diagnosed, candida can be diagnosed, Gardnerella can be diagnosed. Which infection cannot be diagnosed? Chlamydia and gonorrhea. This is important MCQ. Chlamydia and gonorrhea cannot be diagnosed by Pap smear. Third MCQ. If Pap smear is unsatisfactory, what is the next step? Repeat Pap smear after 2 to 4 months. Mean is 3. Fourth MCQ. If Pap smear show atypical squamous cells of unknown significance, then we will see the age. Up to 24 years of age, we will repeat Pap smear. If abnormal, we will do colposcopy. If she is above 24 years of age, we will do a co-testing. If this is abnormal, colposcopy. Another possibility, if Pap smear shows atypical glandular cells, we do endocervical curettage, endometrial biopsy, and colposcopy. Everything is written in notes, why and how we have discussed in detail. Then, if Pap smear shows LSIL, low-grade squamous intraepithelial lesion, and a lesion is visible, what is the next step? Punch biopsy. I will show you these images of biopsy. What is the next step? Punch biopsy. If Pap smear shows LSIL and nothing is visible, colposcopic guided biopsy. We paint acetic acid before and take biopsy from white area. Third MCQ. She presents with LSIL and nothing is visible even by colposcopy. What is the next step? Conization. Now another MCQ. Instead of LSIL, if she is presenting with HSIL and lesion is visible, we have to add endocervical curettage. Punch biopsy plus endocervical curettage. Fine. HSIL, nothing is visible. Colposcopic biopsy plus endocervical curettage. Nothing is visible even by colposcopy, conization plus endocervical curettage. So this is the diagnosis and protocol for cervical cancer. Most common route of spread of cervical cancer, lymphatic. Endometrial cancer, direct spread. Here lymphatic. So questions are, what is the sentinel lymph node? Paracervical. If not given in option, ureter. Second question, most common lymph node involved in cervical cancer, obturator. Then staging protocol, it is clinical. Staging of cervical cancer, how is it done? Stage 1 says how much this cancer has come out of epithelium. 1A1, 0 to 3 mm. 0 to 3, it should be less than 3 mm. 1A2, 3 to 4 mm. 1B1, more than 4 mm but less than 2 cm. 1B2, 2 or more than 2 cm but less than 4 cm. 1B3, 4 or more than 4 cm. Then stage 2A, upper 2/3 of vagina is involved. 2A is further subdivided in 2A1 and 2A2. 2A1 less than 4 cm, 2A2 4 or more than 4 cm. 2B, along with upper 2/3 of vagina, there is extension to parametrium. 3A, lower 1/3 of vagina. 2A, upper 2/3 of vagina. 3A, lower 1/3 of vagina. 3B, lower 1/3 of vagina and extension to pelvic wall. 3C1, pelvic lymph nodes involved. 3C2, para-aortic lymph nodes involved. 3C1, C2 same as endometrial cancer. 4A, B same as endometrial cancer. 4A, regional metastasis, anteriorly to urinary bladder or posteriorly to rectum. 4B, distant metastasis. Same questions if inguinal lymph nodes are involved in cervical cancer, 4B. If inguinal lymph nodes are involved in endometrial cancer, 4B. If there is hydronephrosis in cervical cancer, what is the earliest stage? 3B. Due to extension to pelvic wall, ureters are compressed. Then, what is the most common complication or most common cause of death in cervical cancer? Renal failure. Second most common one is excessive hemorrhage. Now, management of cervical cancer. If it is CIN1, then observe for 2 years. If it doesn't regress, cryotherapy. CIN2 and 3, leave. Loop electro, I will show you these images. Loop electrosurgical excision procedure or large loop excision of transformation zone. This is an OPD procedure, can be finished in 2 minutes and up to 10 millimeter of depth can be destroyed. For CIN extending to lateral fornix, we do laser. We have written everything. Fine. For recurrent CIN, we can do hysterectomy. Then is carcinoma in situ and stage 1A1 in young nulliparous, conization. Multiparous, total abdominal hysterectomy. In all the surgeries, whatever I am telling you, pelvic lymph node dissection will be done along with it. Fine. 1A2. If she is nulliparous, radical trachelectomy. Trachelectomy means removing the cervix, then stitching uterus and vagina together. If she is multiparous, then we do Vardyne hysterectomy. 1B1. Again, the thumb rule for surgery in cervical cancer is, if size is less than 2 cm, we can do radical trachelectomy, that is removing the cervix and stitching uterus and vagina together so she can have future childbearing. If size is less than 4 cm, then surgery can be done. Any surgery in cervical cancer can be done if size is less than 4 cm. and radical trachelectomy surgery, where we can save uterus, can be done only if size is less than 2 centimeter. So 1B1 is less than 2 centimeter. So 1B1 again, if she is nulliparous, radical trachelectomy can be done. In adult, radical hysterectomy will be done. 1B2, radical trachelectomy cannot be done because size is 2 or more than 2 centimeter. B2 is 2 or more than 2 centimeter. For surgery for B2 is radical trachelectomy. 1B3, 4 or more than 4 centimeter. 1B3, no surgery can be done. Only chemoradiation can be done. 2A1, A1 is less than 4 centimeter. 2A1 surgery can be done, radical hysterectomy. 2A2 onwards, only chemoradiation. Chemotherapeutic drug which is acting as radiosensitizer here also is cisplatin. So this is the management protocol for cervical cancer. Fine. Vaccination has been discussed in PSM. This is 1:45. We are taking a 30 minutes break and we will resume at 2:15. We will be back at 2:15. Before that, let me show you the images. Required images which are required in cancer cervix. I will show you related to Pap smear, how it is done. This is Pap smear kit. First of all, we will see the Pap smear kit. This is old conventional Pap smear kit, beta. This is old conventional Pap smear kit. This is IRS spatula. You know that. This is IRS spatula. This is endocervical brush. This is endocervical brush. So IRS spatula, we take it from squamocolumnar junction by rotating 360 degree. Endocervical brush, this is introduced in cervical canal, rotated 360 degree, and from this swab, we take from posterior fornix and we put these on 3 slides. And fixative for Pap smear is 95% ethyl alcohol. We are talking about old conventional Pap smear. Fixative is 95% ethyl alcohol. But new, the latest one, but the expensive one, it is liquid based cytology and it is liquid methanol. What is this, beta? This is liquid methanol. Now we do liquid based cytology, but it is expensive. And in this we use this brush. In this we use this brush. This is the brush. This is cyto brush, beta. How we do? By this brush only, we take it from squamocolumnar junction or from endocervix, and then we dip this brush in this liquid bottle. In this liquid bottle, and in this liquid bottle, how we do? We dip this brush and we cut it here. So it drops there. It drops there. This is called cyto brush. What is this called? Cyto brush. So liquid based cytology, it is liquid methanol. If you have to choose between 95% ethyl alcohol and liquid methanol, it is liquid methanol. This is LEAP electrodes, beta. These are loop electrosurgical excision procedure electrodes. These are LEAP electrodes. I will show you colposcope also. Hysteroscope you have seen. In image session separately, in 20-30 minutes, I will show you all the images. This is how we are doing this LEAP. This is how we are doing this LEAP. This is the procedure. And this is how we do conization. This is how we do conization. Conization, we take a cone-shaped piece. And this cone should involve squamocolumnar junction, endocervix and ectocervix. All 3 areas. Cone-shaped piece is cut. That's called conization. This is cryocautery, although not required. This is how we do cauterization, cold cauterization, damaging it. This is colposcope. This is colposcope, beta. This is colposcope. Can you see this is the camera here and this is how everything is displayed over monitor. This is colposcopy. Punch biopsy, beta. I want to show you punch biopsy. If lesion is visible, what we are doing, beta? We are doing punch biopsy. This is punch biopsy first. If some lesion is visible, we can take out biopsy directly from here. This is called punch biopsy. If it is not visible, colposcopic biopsy. And so if something is not visible even by colposcope, then conization is done. This is how conization is done. This is how we cut the cone shape piece. So this is the ultrasound image for cervical cancer. Ultrasound image of cervical cancer. This is the mass here. This is the mass. And if we switch on the color Doppler mode, of course, due to neovascularization, whenever there is any malignancy, neovascularization develops. You know this pathology. You can see multiple blood vessels. This is due to neovascularization. Neovascularization. If you do ultrasound in cervical cancer and if you switch on the color Doppler mode, this is how you see multiple vessels there. Fine. So this was enough for cervical cancer. This is 150 now. We are taking a 30 minutes break, 30 minutes lunch break, and we will be back at 2:20. 2:20. And before going, I just want to tell you only one thing. You are thinking about what is going to happen in next 17 days. I'm not able to talk much today because I have to do a revision session. Do a revision session. But tomorrow I have a YouTube live session at 6 p.m. There, along with 25 important questions, I will be discussing how to manage, how to go ahead to score maximally on 12th December exam. There I will discuss few things, but not today. Fine. But here I just want to tell you one thing. Don't think about what is going to happen in next 17 days. Just think what can happen in next 24 hours. And when a lot can happen over a cup of coffee, I just thought today morning, when a lot can happen over a cup of coffee, what can't happen in next 24 hours? Make it happen. Revise, revise, revise. जान डाल दो. क्वेश्चन ही क्वेश्चन आ रहे हैं. Many questions. Revise properly. चलो जी. See you at 2:20. 30 minutes break. Properly revise whole of Skyne till your test. Properly. Welcome back. We are starting with placenta now. Open your notes. Placenta. Yes, placenta. Placenta is formed by two components, fetal component and maternal component. So fetal component is chorion frondosum. I will show you images of placenta, related images. Fetal component is chorion frondosum. Maternal component is decidua basilis. So which one is major component? Fetal component. Fourth, fifth portion of placenta formed by chorion frondosum. That is fetal component. So what is attached on fetal component of placenta? Umbilical cord. And maternal component of placenta, it has cotyledons. Cotyledons. Well, let me show you, make an orientation of placenta and umbilical cord. This is the placenta. This is placenta. This is on posterior wall. This is the placenta on posterior wall. This is fetus here, and this is the umbilical cord. So this is how they are attached. So we are talking about two component of placenta. One is the fetal component. This fetal component of placenta, this is shiny gray in color, while this is maternal component of placenta, which is dull red in color. Fine. So what is attached on fetal component of placenta? Very simple to understand. What is attached here? Umbilical cord. Umbilical cord is attached here. While what are present on maternal component? Cotyledons. These cotyledons are functional units of placenta. This is the fetal surface of placenta. This is fetal surface. So what is attached on fetal surface of placenta? Umbilical cord. This is umbilical cord. This is fetal side. Shiny gray. You can see this is shiny gray in color. Let me show you maternal side of placenta, which is dull red in color. This is maternal surface of placenta, which is dull red in color. Maternal surface is dull red. And you can see these are multiple lobules, cotyledons. These cotyledons are functional units of placenta. So important chocolate question is, what is the functional unit of placenta? Functional unit of placenta are cotyledons, and maternal surface of placenta is dull red in color, while fetal surface of placenta is shiny gray in color. And what is attached on this fetal surface? Umbilical cord is attached. So major contributor to placenta is this fetal surface, which form 4/5 component of placenta. So placenta is formed by chorion frondosum, that is fetal component, this one, and decidua basilis, which is maternal component, this one. Cotyledons are present on maternal component of placenta. Now, few statistics about placenta. How much is the weight of term placenta? Weight of term placenta is 500 grams. It is 500 grams. Placenta, how much is the circumference? 15 centimeter. It is disc shaped, so we call it discoid. It shades off after delivery, we call it deciduate. We call it hemochorial because it is in contact with maternal blood on either side. So discoid, deciduate, and hemochorial. And weight of term placenta is 500 grams. So normal location of placenta, normal site of attachment. Let me show you another image. Normal attachment of placenta, its lower edge should be at least 2 centimeter away from internal os. This is normally located placenta. Look here. This is the normal location of placenta, and this is the MCQ here. When you start calling this placenta as low, this is the level of internal os, and this is the lower edge of placenta. This lower edge of placenta is finishing here. So what we are talking about, that this distance should be at least 2 centimeter. Fine. And if this lower edge of placenta is within 2 centimeter from internal os, then we call it a low-lying placenta. And after the age of viability, low-lying placenta is called placenta previa. So the minimum distance should be 2 centimeter. Otherwise, it will be called a low-lying placenta. Fine. Various hormones are secreted by placenta like HCG, HPL, PEP-A, HCT, estrogen, progesterone, cholesterol. We have written those hormones. Fine. Now, umbilical cord. Umbilical cord. What is the shape of umbilical cord? It is. It has folds. These folds are called folds of Hoboken. These folds are called folds of Hoboken. Folds of Hoboken. Let me show you. Umbilical cord loops. Loops of umbilical cord. They are called folds of Hoboken. These are the loops of cord. In ultrasound also you can see this. This is umbilical cord. It has loops. Can you see? Loops of umbilical cord. These are loops of umbilical cord. These are folds or loops of umbilical cord. These are called folds of Hoboken. Folds of Hoboken. Few statistics, connective tissue of umbilical cord is called Wharton's jelly. It develops from connecting stalk. Length of umbilical cord is 30 to 100 centimeter. Mean length is 55 centimeter. If it is less than 30 centimeter in length, short cord. More than 100 centimeter in length, long cord. Fine. Now let's understand few abnormalities. Let me keep the images open. Few abnormalities of placenta and umbilical cord. Accessory lobe. There are three types of accessory lobe. I will show you the images later on. Let me finish with it. Otherwise, it will take more time. Three types of accessory lobe. One abnormality is accessory lobe. Now, normally there is only one lobe. If there are two lobes, means there is one accessory lobe apart from main lobe. This is called abnormal accessory lobe. So there are three types of accessory lobe. One is succenturiate placenta. Second is placenta spuria. Third is placenta bilobata or bipartite or placenta duplex. So succenturiate placenta is smaller accessory lobe and it is connected with blood vessel by main lobe. Placenta spuria is smaller accessory lobe but there is no connection with main lobe. Placenta bilobata or bipartite or duplex, two equal sized lobes connected with blood vessels. And most common complication here is postpartum hemorrhage. Why? Because living ligature of uterus will not happen. I'll show you later on. Then extracorporeal placenta, circumvallate and circummarginate. In extracorporeal placenta, both circumvallate and marginate, everything is in front of you in your notes. Fetal surface is smaller. So what is the shape of placenta? It is C-shaped. Fetal surface is smaller. Difference between circummarginate and vallate is a valve-like area is present at maternal and fetal junction. This is circumvallate, valve vallate. And maternal surface is continuing smoothly with fetal surface, that is circummarginate. Complication of both circumvallate and marginate is IUGR and abruptio placentae. Living ligature of uterus is present in which layer of myometrium? Important anatomy question. Middle layer of myometrium. Very important. We have drawn the image, living ligature of uterus. It is present in middle layer of myometrium. Then there is a battledore placenta, also called battledore insertion of umbilical cord. Normally, umbilical cord is inserted at central part of placenta. I'll show you once again. But if umbilical cord is inserted at placental margin, this is battledore insertion. If umbilical cord is not at all attached on placenta, it is inserted away from placenta and then reaching placenta. This is filamentous insertion. Let me show you, then we'll move ahead. Look here, succenturiate lobe. This is the succenturiate lobe. This is the main placenta. This is the main one. And this is the accessory lobe. This is accessory lobe, succenturiate lobe. And these two lobes, they are connected with blood vessels. They are connected with blood vessels. This is succenturiate lobe. If they are not connected with blood vessel, this is called placenta spuria. And if these two lobes are of equal size and connected with blood vessel, this is placenta bipartite or placenta bilobata. And what is the living ligature of uterus? Living ligature of uterus, I will show you once again. This is living ligature of uterus. This is living ligature of uterus. See, blood vessels run in middle layer of myometrium, which are eight-shaped. Outer one are longitudinal, inner one are circular fibers, and middle layer of myometrium, it is in crisscross fashion, that is eight-shaped. So our MCQ is living ligature of uterus is present in which layer? Middle layer of myometrium. Fine. Then, other placentas. What is this? This is What is this? This is circumvallate. Circumvallate. As you can see, fetal surface is small. This is the fetal surface, a fetal surface. This is smaller. While the other one, this is maternal surface, you can see. This is bigger. Maternal surface is covering fetal surface. So fetal surface is small. And you can see a valve-like thickening. This valve-like thickening, this is that thickening at the junction of maternal and fetal surface. So this is a circumvallate placenta. If this valve-like thickening is absent, then we will call it circummarginate. Complication of both circumvallate and circummarginate are IUGR and abruptio placentae. Then, another abnormality here is, this is a fenestrated placenta, fenestrated. When there is a hole in the center of placenta, this is called fenestrated placenta. Membranous placenta, not very important for us, membrane-shaped placenta. And we saw cotyledons, they are functional units of placenta. Another image of cotyledons, this is maternal surface of placenta and fetal. You can compare here, maternal surface has cotyledons. These are cotyledons, lobules. It is dull red in color, while fetal surface is shiny gray. And you can see what is attached on fetal surface. Umbilical cord is attached on which surface of placenta? Of course, fetal surface. It is connecting placenta with fetus. So these were abnormalities. And if it is a short umbilical cord, then filamentous insertion and battledore. Let's complete with that. This is another image of succenturiate lobe. As you can see, this is succenturiate lobe. This is the accessory lobe. And these two lobes are connected with blood vessels. This is succenturiate. A smaller accessory lobe. Filamentous insertion of placenta, this one. Filamentous insertion of placenta, as you can see, this umbilical cord is not inserted on placenta. It is inserted away from placenta, that is on amnion and chorion, and then vessels are reaching placenta. This is filamentous insertion. What can be the drawback, complication of filamentous insertion of placenta? Vasa previa. If fetal blood vessels are within 2 centimeters from internal, vasa previa. What can happen? There can be fetal bleeding. So how to, your MCQ is, first is, what is filamentous insertion of cord if umbilical cord is inserted away from placenta? What can be complication of filamentous insertion of cord? Vasa previa. What can be the risk due to vasa previa? There can be bleeding per vaginum, which could be of fetal in origin. Then there are 2 MCQs for diagnosis. What is the diagnosis for vasa previa? Color Doppler ultrasound. Then blood which is coming out of vagina is fetal in origin. So how to differentiate whether it is maternal in origin or fetal in origin? For differentiation, which test is done? Singus alkali denaturation test is done, which is also called AP test. Which test? Singus alkali denaturation test, which is also called AP test. So be very, very careful. There are 2 MCQs. Best diagnosis of vasa previa is by color Doppler ultrasound. See your notes, we have clearly written. Best diagnosis of vasa previa is by color Doppler ultrasound. How to differentiate maternal and fetal blood is by Singus alkali denaturation test, which is also called AP test. Very important test, very important. Which reagent is used here? 10% KOH. 10% QH. Instead of potassium hydroxide, sodium hydroxide can also be used, 1% anyway. What is the principle of this test? Fetal hemoglobin is resistant to alkali. Fetal hemoglobin is resistant to alkali. So, blood which is coming out of vagina, if we add 10% QH to that blood, if that blood is fetal in origin, it will not be denatured because it is resistant to alkali. And if it is maternal in origin, it will be denatured. Its color will change. So principle of this test is fetal hemoglobin is resistant to alkali. Which reagent is used? This is also important. Fine. How to treat cases of vasa previa? If you have diagnosed that this is vasa previa, management is done by cesarean section. Management is by cesarean section. Fine. So after placenta and umbilical cord, amniotic fluid. What is amniotic fluid? Amniotic fluid is present between fetus and placenta. Let me just make you an orientation. It is present between fetus and placenta. So how is it present? Just see this image. So this is the fluid. Although this is not normal fluid, this is yellow colored fluid, this is something different. But this is the fluid which is present between fetus and placenta. This is present between fetus and placenta. So this is amniotic fluid. What is the role of this fluid which is present between fetus and placenta? This fluid acts as a shock absorber. Shock absorber. Fine. But there is no nutritive value. What is your MCQ here? This amniotic fluid gives no nutrition. It acts only as a shock absorber. If we do an ultrasound, how does it look like? You can see. This is how this fluid looks like. This is again amniotic fluid inside. This is placenta and this is fetus. So this fluid is present between fetus and placenta. It is acting as a shock absorber mainly. Fine. Now, just look at your notes. Just look at your notes. Few statistics about amniotic fluid. What is the source of amniotic fluid? In early pregnancy up to 7 weeks, ultrafiltrate or diffusion from maternal plasma. Then 7 to 20 weeks, it is mainly diffusion from fetal skin. After 20 weeks, major source of fetal amniotic fluid is fetal urine. So if examiner asks you two questions, overall major contributor to amniotic fluid, fetal urine. Beyond 20 weeks, major contributor to amniotic fluid is fetal urine. Fine. Composition, because it is urine, 99% is water, 1% are solids, sodium, potassium chloride, urea, uric acid, creatine, whatever is excreted by kidney. That is present in amniotic fluid. Then pH is alkaline 7.2 to 7.4 up to 7.5 alkaline pH. Specific gravity 1.008 to 1.010. Osmolality is 250 milliosmol per liter. Turnover rate is 500 cc per hour. It is completely replaced in approximately 3 hours. So these are statistics about amniotic fluid. Then how to have an idea how much is present inside? It is done by ultrasound. How we assess it? It is done by ultrasound. In ultrasound, we have two parameters, single deepest pocket and amniotic fluid index. Let me show you because then only you will be able to understand it. So we do an ultrasound and we divide abdomen in 4 quadrants. How many quadrants, beta? We divide abdomen in 4 quadrants like this. We are doing ultrasound and we divide abdomen in 4 quadrants. Quadrant 1, quadrant 2, quadrant 3, quadrant 4. And then we measure length of pockets of amniotic fluid here. How do we do it by ultrasound? Look here, 4 quadrants. So this is done by ultrasound, 4 quadrants. This is first quadrant, this is second quadrant, this is third quadrant, this is fourth quadrant. And what we are doing, you can see here like this. We are measuring pockets of amniotic fluid like this, like this, like this, like this. The third one and the fourth one. So now I will erase, you can see that once again. So this is how we are measuring pockets of amniotic fluid. Longest pocket out of 4 is called longest vertical pocket. or single deepest pocket, longest vertical pocket or single deepest pocket. And if we add up, if we sum up these four, this is called amniotic fluid index or AFI. What is this called? Amniotic fluid index or AFI. So how do we categorize whether this is normal or less or more? How do we categorize this? So if SDP is less than 2 centimeter, AFI is less than 5, amount is less than 200 ml, oligohydramnios. If SDP is more than 8 centimeter, AFI is more than 5 centimeter, 25 centimeter, and amount is more than 2 liter, this is polyhydramnios. So assessment is done by ultrasound. How many parameters? Two. Single deepest pocket and amniotic fluid index. Then if less oligo, if more than these, this is poly. The most common cause of oligohydramnios is maternal diastolic hypertension, but that is for severe. Most common cause of mild oligo or mild poly, most common cause of mild oligohydramnios or mild polyhydramnios, both, is idiopathic. Most common cause of severe oligohydramnios is maternal diastolic hypertension. Why and how we have discussed in great detail. Other causes: premature rupture of membrane, post-term pregnancy, use of indomethacin, amnion nodosum, and fetal renal problem, bilateral fetal renal agenesis mainly, otherwise polycystic kidney also causes it, and triploidy. Triploidy are associated with oligohydramnios. The most common for mild oligo, idiopathic. For severe oligo, maternal diastolic hypertension. Then complications. What can happen if it is less? Fetus will be compressed. So overall most common complication of oligohydramnios, very important question beta, very important MCQ. Overall most common complication of oligohydramnios is pulmonary hypoplasia. Now examiner will dissect this question. Most common complication of early oligohydramnios. Early oligohydramnios beta before 30 weeks. So most common complication of early oligohydramnios is pulmonary hypoplasia. Then another complication of early oligo is amniotic bend sequence, which may cause amputation of limbs. We have written in notes. Most common complication of late oligohydramnios, meconium aspiration syndrome. So read the question very carefully. Very important MCQ zone. If the question is most common complication of oligohydramnios, answer is pulmonary hypoplasia. Most common complication of early oligohydramnios, pulmonary hypoplasia. Most common complication of late oligohydramnios, meconium aspiration syndrome. Fine. Then how to manage? According to the cause. Search for the cause in question and treat it. But if examiner writes that fetus is compressed by uterine wall, then we need to instill some fluid inside. That is called amnio infusion. And don't be trapped here. If you are taking out fluid, that is called amniocentesis. Centesis is done to treat polyhydramnios, while amnio infusion is done to treat oligohydramnios. What is instilled? Normal saline. One thing you have to remember. At what temperature? Room temperature or body temperature? Body temperature. How much is instilled? 500 cc per hour is instilled. Then polyhydramnios, most common cause of mild poly, idiopathic. Most common cause of severe poly, there are two causes: open neural tube defects and gastrointestinal defect. There's a tug of war. I will go for open neural tube defect, although some literature write gastrointestinal defects more common, but they keep on changing. For 12th December exam, I am telling you open neural tube defect. Open neural tube defects like anencephaly and spina bifida apata. Then gastrointestinal defects, cleft lip and palate, esophageal atresia, duodenal atresia, annular pancreas. How and why they cause, we have discussed in great detail in our classes. Then multifetal pregnancy. Then trisomies cause polyhydramnios. Triploidy cause oligohydramnios. Why and how, we have discussed in great detail in our classes. Means Down syndrome, that will be associated with polyhydramnios. Torch infections, diabetes mellitus. Chorioangioma of placenta, RH incompatibility, and trisomies. Triploidy cause oligo. Then complications of poly: breathlessness, respiratory discomfort, malpresentation, cord prolapse, abruptio placentae, preterm labor, premature rupture of membrane, postpartum hemorrhage. How and why, we have discussed. They're just in front of you. Everything is in front of you. Then, how to treat polyhydramnios? Treatment of polyhydramnios according to the cause. But if she is having severe breathlessness, then amniocentesis. amniocentesis. And which drug can be used to treat polyhydramnios? Indomethacin. Indomethacin, one important question, indomethacin should not be used beyond 32 weeks. Otherwise, it will cause premature closure of ductus arteriosus. Important pharma question also. Then, as far as color of amniotic fluid is concerned, simple chocolate question. Color of amniotic fluid is colorless. Color of amniotic fluid at term pregnancy is light. Why and how? We know. RH incompatibility, golden yellow. Post-term pregnancy, saffron colored or greenish yellow. Intrauterine fetal demise, blackish brown or tobacco colored. Abruptio placentae, dark colored. Listeria infection, breach, transverse or fetal distress, green colored. How and why? We know very well. Maximum amount of amniotic fluid is seen at how much time? 32 weeks of pregnancy. So it will float between 32 and 34. If 32 is not given, you can choose 34. Otherwise, between 32 and 34, best answer would be 32 weeks of pregnancy. Maximum amount of amniotic fluid is seen at 32 weeks of pregnancy. So after amniotic fluid, pregnancy. Pregnancy, how much is the normal duration of pregnancy? 280 days or 9 months plus 7 days or 40 weeks. Fine. In pregnancy, there are two terms. One is period of amenorrhea or gestational age. Other one is fetal age or true conceptional age. So period of amenorrhea or gestational age is calculated from first day of last menstrual period, while fetal age or true conceptional period is calculated from day of fertilization. So true conceptional period will be how much less than period of amenorrhea? It will be 14 days less than period of amenorrhea. Fine. Now, few statistics. First trimester, second trimester, third trimester. I told you according to Williams, first trimester is up to 14 weeks. Second, after 14 till completion of 28. Third, from 29 to 42. DC Datta says, first trimester up to 12, second from 13 to 28, and third from 29 to 40. But we will go with Williams. Then there are few terminology regarding term, early term. Early term is from 37 weeks to 38 weeks, 6 days. Term is 39 weeks to 40 weeks, 6 days. Post term, late term is 41 weeks, 6 days. Early term is 37 weeks to 38 weeks, 6 days. Term is 39 weeks to 40 weeks, 6 days. Late term is 41 weeks to 41 weeks, 6 days. And post term is beyond 42 weeks. Beyond 42 weeks. And preterm is before 37 weeks. Then what is gravida? Number of times she got pregnant. Parity, number of times she delivered beyond the age of viability. Nulli gravida, never became pregnant. Primigravida, pregnant for first time. Multigravida, pregnant for 2 or more than 2 times. Nullipera, never delivered beyond age of viability. Primipara, delivered once beyond age of viability. Grand multipara, delivered 2 or more than 2 times beyond age of viability. Grand multipara, delivered 4 or more than 4 times beyond age of viability and now pregnant for 5th time. Great grand multipara, delivered 9 or more than 9 times beyond age of viability and now pregnant for 10th time. Fine. Then what is the most accepted scoring system for gravida and parity? GTPAL. Gravida, number of times she got pregnant. T, number of term pregnancy. P, number of preterm labor. A, number of abortion. L, number of living children. What you have to remember in gravida and parity word. Gravida, number of times she got pregnant. Suppose she is pregnant for second time and in first pregnancy she delivered triplets, 3, and now she is pregnant for second time. So her gravida score is G4 or G2, G2. Number of children will not be counted. Similarly with parity, similarly with gravida. Now how to calculate expected date of delivery? It is done by which formula? Nigle's formula. We just have to add 9 months or 7 days, or what we have to do, you can add 7 days and count back 3 months. If month is changed, count back how many months? 2 months. We have written clearly in our notes. Then after this calculation of EDD, terminology and everything, symptoms. First trimester symptom, earliest symptom is amenorrhea. Cause of amenorrhea, we know very well. Other symptoms in first trimester of pregnancy, increased frequency of micturition, Then what else? Morning sickness, nausea and vomiting, breast discomfort because breasts are enlarging, and lethargy, tiredness. Fine. These are first trimester symptoms. So out of these symptoms, which one is the earliest? Amenorrhea. Amenorrhea is the earliest symptom. Then second trimester symptom, quickening, perception of fetal movement. It is experienced earlier by multi, 16 weeks onwards, primi 18 weeks onwards. Third trimester symptom, lightening and reappearance of increased frequency of micturition. Lightening in primi around 38 weeks, multi recognized lightening almost at the time of labor. And lightning is also called welcome sign. Baby is coming down, we are ready to welcome it. Signs in first trimester. Earliest sign is Goodell sign. It is softening of cervix. How and why we discussed in detail. It is appreciated as early as 6 weeks onwards. Other signs, Jacquemer or Chadwick, bluish violet discoloration of cervix vagina, 8 weeks onward. Rest of the first trimester signs, 8 weeks onward. Goodell is 6 weeks onward. So Jacquemer or Chadwick, bluish violet discoloration of cervix and vagina. Then Osiander sign, if we are doing PV, palpation of pulsations of uterine vessel. Piscasex sign, asymmetrical enlargement of uterus. Palmer sign, if you put your palm, you can sense some tone, which are due to uterine contraction, which are of how much intensity throughout pregnancy? Less than 8 millimeter of mercury intensity throughout pregnancy. Then there is a bimanual sign, which is called Hagar sign. What is this Hagar sign? Hagar sign is bimanual. Your abdominal and vaginal fingers seem to approximate each other. Seem to approximate each other. I will show you Hagar sign and Jacquemer. Okay. They are first trimester signs. Second trimester sign, palpation of fetal parts and auscultation of fetal heart sound by stethoscope 18 weeks onward. Third trimester sign, lightning is a third trimester sign. So out of all these, best clinical sign is auscultation of fetal heart sound by stethoscope. Then investigation. Investigation, first investigation, earliest investigation, urine pregnancy test. Best sample, early morning sample. It is positive only when she is at least 1 day overdue. So earliest answer is urine pregnancy test. Best and to diagnose early before she is overdue, blood test. Which one is best? Fluoroimmunoassay. 0.001 MIU per ml, radioimmunoassay 0.002 MIU per ml. By ultrasound, first structure seen is gestational sac, second is yolk sac, third is embryo. And as soon as you see embryo, you should be able to see cardiac activity. By transvaginal sonography, things are visualized early. Gestational sac by TVS, 4 weeks, 3 days. Yolk sac, 5 weeks. Cardiac activity, 5 to 6 weeks. Transabdominal sonography, gestational sac 5 weeks, yolk sac 6 weeks, cardiac activity 7 weeks. So your questions will be, first structure visualized by ultrasound in pregnancy is gestational sac. Gestational sac can be visualized earliest by what time? If nothing is written, we will choose a transvaginal ultrasound, that is 4 weeks, 3 days. Cardiac activity can be visualized earliest by what time? 5 weeks. Cardiac activity can be visualized earliest by transabdominal ultrasound by what time? 7 weeks. So this is how we will solve these questions. So there are two questions. Best sign of pregnancy, visualization of cardiac activity by ultrasound. Best clinical sign of pregnancy, auscultation of fetal heart sound by stethoscope. Then there is the word pseudocysis, pseudo pregnancy. She thinks she is pregnant, but she is not pregnant. This is called pseudocysis. So all these signs, absolute signs of pregnancy will be absent. Absolute signs of pregnancy are visualization of cardiac activity, visualization of fetus by ultrasound. If you do a X-ray, you can see fetal skeleton. That's of no use, only two questions. Best clinical sign of pregnancy, auscultation of fetal heart sound. Best sign of pregnancy, visualization of cardiac activity by ultrasound. So this is how things are done. And symptom, sign and investigation. Let me show you few images here. So this is by ultrasound. First structure visualized by ultrasound, that will be gestational sac. This is the gestational sac. This is visualized first. And later on, second structure which is visualized by ultrasound, this is the yolk sac. Third structure which is visualized by ultrasound, this is the embryo. And when you are visualizing embryo, we should be able to see cardiac pulsations. Look here, first structure. Nothing else is seen. The first structure visualized by ultrasound is gestational sac. This is the first structure. Fine. Then let me show you signs. This is Jacquemer or Chadwick sign. This is bluish violet discoloration of cervix and vagina. Then I will show you Hagar sign. This is the bimanual sign, as you can see here. This is Hagar sign. Abdominal and vaginal fingers seem to approximate each other. Fine. And this is the urine pregnancy test kit. This is the positive urine pregnancy test. This is the negative one. It is based on antigen antibody reaction. Answer to the question: earliest investigation to diagnose pregnancy is urine pregnancy test. Then, changes in pregnancy. What are the changes in pregnancy? Changes in pregnancy on face, pregnancy mask, which is called melasma or called chloisma gravidarum. I saw my face, put on some weight because eating parathas, aloo paratha, gobi paratha, methi paratha. Got it? Should control now. Okay, pregnancy mask. Okay, this is due to increased melanin. So it is brownish black pigmentation over cheek, nose, and forehead. Fine. Then breast, 4 changes. One is enlargement of breast. Enlargement of breast is due to estrogen and progesterone. Estrogen, ductal growth; progesterone, acinar growth. First change, enlargement. Second is formation of secondary areola. I will show you another dark area around primary areola due to increased melanin. Third is Montgomery tubercles, hypertrophied sebaceous glands. Fine. And fourth one is colostrum, can be secreted on squeezing of breast 12 weeks onward. Then changes in abdomen, 2 types of lines in abdomen. One is linear line between xiphisternum and pubic symphysis, linea nigra, due to increased melanin. Then other curvy linear lines is stria gravidarum due to dilatation of capillaries. After delivery, they become white. Earlier in pregnancy, they are pinkish red. After delivery, they become white because capillaries are obliterated, stria albicans. Changes in vagina, one is color change bluish violet. Second is pH becomes most acidic because of increase of number of Doderlein bacilli. Let me show you these. This is pregnancy mask. This is pregnancy mask. Brownish black pigmentation over this. This is brownish black pigmentation. Fine. This is pregnancy mask. Melasma or chloisma gravidarum. Then linea nigra. This is linea nigra. Brownish black line extending between xiphisternum and pubic symphysis due to increased melanin. Then other types of lines in abdomen, they are pinkish red. They are stria gravidarum. After delivery, they will become white and we will call them stria albicans. Then changes in breast. Look here. There is formation of secondary areola. This secondary areola is another dark area around primary areola and enlargement of breast, that is called mammogenesis. And these are Montgomery tubercles. What are these Montgomery tubercles? You can see these are Montgomery tubercles. These are hypertrophied sebaceous glands. Hypertrophied sebaceous glands at areolar margin. They are Montgomery tubercles. Fine. Now, so these are changes in pregnancy. Then change fundal height. Fundal height, I will show you. Fundal height. But let me explain you first. You just look at your notes. Don't look at this diagram. We are doing much better this way. So look at your notes. Fundal height. Fundal height. What we are doing, what is the advantage of fundal height? We want to have an idea about gestational age. How many weeks pregnancy is this by height, fundal height. So uterus is a pelvic organ. When pregnancy is of 12 weeks, it is just palpable at pubic symphysis. So if uterus is just, look at your notes, we have a diagram there. If it is just palpable at pubic symphysis, how many weeks pregnancy is this? 12 weeks. Midway between pubic symphysis and umbilicus, 16 weeks pregnancy. Lower border of umbilicus 20 weeks pregnancy, mid umbilicus 22 weeks pregnancy, upper border of umbilicus 24 weeks pregnancy. And if examiner doesn't specify lower border of umbilicus, mid umbilicus or upper border of umbilicus, answer would be 24 weeks of pregnancy. Then area between umbilicus and xiphisternum has been divided in three equal area, 3 1/3 area. So your MCQs are, if fundal height is at the junction of 1/3 from umbilicus and 2/3 from xiphisternum, 28 weeks. At the junction of 2/3 from umbilicus and 1/3 from xiphisternum, 32 weeks. At xiphisternum, 36 weeks. At 40 weeks, it comes at the level of 32 weeks. So how to differentiate? At 40 weeks, head will not be palpable. It has gone down. At 32 weeks, head is palpable. Now we have two MCQs. What is the best clinical method of assessment of gestational age? Fundal height estimation. What is overall best method of assessment of gestational age? Ultrasound visualization, ultrasound parameters. What are ultrasound parameters? I hope radiology sir has told you. Best ultrasound parameter for assessment of gestational age, crown rump length, CRL. Best ultrasound parameter for assessment of gestational age in first trimester, again CRL. Best ultrasound parameter for assessment of gestational age in second trimester, BPD, biparietal diameter. Best ultrasound parameter for assessment of gestational age in third trimester is femur length. Best ultrasound parameter for assessment of fetal weight or fetal growth is abdominal circumference. Radiology sir told you this. So best method for assessment of gestational age is by ultrasound. Best clinical method for assessment of gestational age is by fundal height estimation. Fine, beta. So this is how we are calculating gestational age, by fundal height estimation. Then what are other changes in pregnancy? How much is the weight gain in pregnancy? Approximately 10 to 14 kg, the bigger range, somewhere around 10 to 12, 11 to 12 kg. That's the weight gain. How much is the total water retained in pregnancy? Approx 6.5 liter. Increase in BMR 10 to 20%. Pregnancy is a diabetogenic condition due to insulin resistance. What is the most common cause of insulin resistance in pregnancy? Human placental lactogen. HPL. Most common cause, most important factor responsible for insulin resistance in pregnancy is HPL. Estrogen, progesterone, and cortisol are also responsible, but mainly by HPL. Pregnancy is a hypercoagulable condition because clotting factors are increasing. So risk of thrombosis in pregnancy. This is why red degeneration in fibroids is common in second half of pregnancy, because second half of pregnancy is most hypercoagulable. So all these things happen in pregnancy. Rest system-wise changes we will just discuss. Fine. System-wise changes in pregnancy. Let's discuss system-wise changes in pregnancy with hematological system. What is happening in hematological system? Plasma volume is increasing. It starts increasing from which week? Fifth week. Maximum between 28 to 32 weeks. Best answer 32 weeks. How much is the increase? 40%. RBCs increase by 20%. So blood volume, which is the average of plasma volume and RBC, increased by 30%. Because plasma increased more, blood became thin. Hemodilution. Because of hemodilution, physiological anemia. In physiological anemia, cutoff hemoglobin is 11 gram per cent. If it is less than that, pathological anemia. All clotting factors increasing in pregnancy except 11 and 13. Serum fibrinogen increasing. Because plasma volume is increasing, GFR increase. So urea, uric acid and creatinine are excreted more. So serum levels of urea, uric acid and creatinine are less. They are decreased. What about ESR? Because RBC increasing, ESR is increasing. All parameters of iron metabolism decrease. Hemodilution, serum ferritin concentration, total iron will decrease, reticulocyte count will decrease. But to compensate this, total iron binding capacity and transporter protein of iron, that is transferrin, is increasing. Fine. So albumin globulin ratio Normally is 1.7 is to 1. In pregnancy, it becomes 1 is to 1. Means albumin is decreasing and globulins are increasing. The factors which remain unaltered are bleeding time, clotting time. They are not changed, they are unchanged. What about WBC? They increase by approx 5%. Platelets are unaffected, but due to hemodilution, their concentration decrease, which is called benign gestational thrombocytopenia. So there are various hematological changes. Now, hematocrit will decrease in pregnancy. Cardiovascular system changes because plasma volume is increasing, cardiac output is increasing. Plasma volume start increasing from fifth week, so cardiac output also start increasing from fifth week. Maximum between 28 to 32 weeks. 32 is the best answer. Cardiac output is further increased at the time of labor by 50% and immediately after delivery by 70%. So, overall, why and how we discussed in detail. Overall, cardiac output is maximum immediately after delivery. Antenatally, between 28 to 32 weeks. Pulse rate, heart rate, they increase by 5 to 10 beats per minute. BP, systolic BP, diastolic BP, mean arterial pressure, everything fall. Maximum fall is in which blood pressure? Diastolic blood pressure. If you do a echocardiography, mild increase in cardiac cilia because cardiac output is increasing, there is mild enlargement of left ventricle. Fine. Mild cardiomegaly or mild increase in cardiac cilia. Moderate or severe will be pathological. Only mild is physiological. As because plasma volume is increasing, S1 becomes loud, S2 is normal, S3 is easily heard. Ejection systolic murmur less than grade 3 is physiological. What is happening? Because of pregnancy, diaphragm is uplifted. So what happens? Heart rotates upwards, leftwards, upwards and outward. So apex beat now is palpable in fourth intercostal space, 2.5 centimeter left lateral to mid clavicular line. Because heart is rotating leftward, in ECG there will be left axis deviation. Very simple to understand. Then because diaphragm is uplifted, there are changes in respiratory system. How much is the upliftment of diaphragm? 4 centimeter. Because diaphragm is uplifted, there is increase in transverse diameter of chest. How much is the increase in transverse diameter of chest? 2 centimeter. Overall increase in chest circumference is 6 centimeter. So upliftment of diaphragm, how much? 4 centimeter. Increase in transverse diameter, 2 centimeter. Overall increase in chest circumference is by 6 centimeter. Fine. When we will be doing OBG chanting, I will take you OBG chanting class with an image session, not only with my stall in one book. That will be a rapid fire round because till the time of chanting, at the time of chanting, you will be revising this Hopskyne in these 3 days perfectly. You will appear for test on 26. Then I will take a clinical case discussion also, image session, and then chanting will be a rapid fire round because you will come out. You will be speaking everything after giving the test. So everything has been planned in a systematic way. Fine. So what is happening? Total lung capacity is decreased. Residual volume is decreased. Physiology. This is not gynae. And tidal volume is increasing. Vital capacity, respiratory rate, they are unaffected. What are the changes in gastrointestinal system? Constipation or diarrhea? Constipation because of markedly increased progesterone in pregnancy, and progesterone is a smooth muscle relaxant. So constipation, tendency towards constipation, formation of gallbladder stones because of increased cholesterol in pregnancy, lipid metabolism, all the parameters of lipid metabolism increase, LDL, VLDL, triglycerides, cholesterol, total lipid. So cholesterol is increasing, and because of progesterone, gallbladder does not contract properly. We have discussed in detail. More formation of gallbladder stone. Which stone? Cholesterol stone. And heartburn, pyrosis, increased GI reflux. Fine. These are gastrointestinal changes. Then what is the change in renal system? Plasma volume is increased, so GFR is increasing. How much is the increase in GFR? By 50%. How much is the increase in renal length? By approximately 1 centimeter due to bilateral hydronephrosis and hydroureter. This hydronephrosis and hydroureter is more marked towards right side because more enlargement of uterus is towards right side. Uterus is dextro-rotated, so right ureter is compressed more. Endocrine system, there is hyperplasia of all endocrine glands because of increased basal metabolic rate. pituitary hyperplasia. So growth hormone, prolactin, ACTH, they are increased. FSHLH normal. Why, FSHLH reduced. Why? Because estrogen and progesterone are elevated. TSH remains normal. What is happening to aldosterone? It is increasing. DHEA and DHEAS are normal. These are changes in endocrine system. Then after these changes, have a look at ectopic pregnancy. What is ectopic pregnancy? Ectopic pregnancy is implantation of fertilized ovum outside uterus. Implantation outside uterus. Now in ectopic pregnancy, most common site of ectopic ampulla. And earliest site of rupture is isthmus. And last site of rupture is interstitium. Why and how? We have discussed in great detail in our classes. Earliest site of rupture, isthmus. It ruptures by 6 weeks. Last site of rupture, interstitium. Rupture occurs by 12 weeks. So most common site of ectopic, ampulla of fallopian tube. Earliest site of rupture, isthmus of fallopian tube. Last site of rupture, interstitium of fallopian tube. In isthmus, it can rupture as early as by 6 weeks. Important question. As early as by 6 weeks. Fine. Interstitium 12 weeks. Ampulla 8 weeks. Okay. Now risk factors for ectopic. Most important risk factor is history of previous ectopic or of previous tubal surgery. Most common cause is PID. So all the causes of PID like early age of intercourse, multiple partners, they will be causes of ectopic. Then sterilization failure. Which sterilization failure carries maximum risk of ectopic? Failure of tubectomy. Then IUCD failure. Which IUCD failure maximum risk? Progesterone containing IUCD. Progestasert maximum progesterone, although not used these days. So progestasert failure maximum risk of ectopic. Followed by Mirena failure. Followed by copper IUCD failure. Then lastly, which contraceptive failure? Progesterone only pill failure. Everything is in front of you in your register and you are having a look at that. Fine. Other causes of ectopic may be cornual fibroid, endometriosis. They are not your MCQ zone. Fine. Then after risk factors, what is the most common symptom in ectopic? Lower abdominal pain. And what is the triad of ectopic? Lower abdominal pain, amenorrhea, and positive pregnancy test. Then sign of ectopic, empty uterus and adnexal mass. Empty uterus and adnexal mass. Most important sign of ectopic is cervical movement tenderness. You will do PV, empty uterus. Then you will do TVS, ultrasound. And when you push and pull your probe towards adnexal mass, she may cry. This is called cervical movement tenderness. So most common symptom of ectopic pregnancy is lower abdominal pain. Most consistent sign of ectopic pregnancy is cervical movement tenderness. Fine. What are other signs in ectopic pregnancy? If you do an ultrasound, you can see a gestational sac. Please keep on looking at your notes. Everything is in front of you in your register, whatever I am speaking. If you see a gestational sac in adnexa, that is called Buggale sign. Even with gestational sac, we call it Buggale sign. If you are able to see yolk sac or embryo, that is also Buggale sign. If you switch on the color mode of your ultrasound machine, that is color Doppler ultrasound, you can see numerous vessels around this gestational sac, which is called ring of fire pattern. What is this called? Ring of fire pattern. So they are all supportive evidence of ectopic pregnancy. Then, investigations in ectopic. Investigation of choice is TVS plus beta HCG correlation. Remember the word correlation. What does it mean? A patient, we will solve 3 MCQ with this. A patient comes to us with a history of amenorrhea. Doctor, I missed my period. My pregnancy test is positive. You will do a PV, uterus is empty. Oh my God. You have done an ultrasound, uterus is empty. Then this is called beta HCG correlation. You will do a beta HCG now and you will repeat beta HCG after 48 hours. You will repeat beta HCG after 48 hours. Because doubling time of HCG is 48 hours. I think these two things doubling time of HCG we wrote, just write down one thing. Just write down one thing. Did we write? Doubling time of HCG is 48 hours. Just write down. doubling time of HCG is 48 hours. 1 MCQ. This is why we repeat HCG after 48 hours. Maximum levels of HCG in pregnancy, they are seen at 10 weeks time. Minimum levels of HCG, they are seen at 16 weeks. 3 chocolate question. Doubling time of HCG is 48 hours. It is 48 hours. Maximum levels of HCG in pregnancy, they are seen at 10 weeks pregnancy. Minimum levels of HCG, they are seen at 16 weeks of pregnancy. So what we are doing here, we are doing beta HCG estimation right now and we repeat it after 48 hours. Normal doubling time of HCG is 48 hours. So what happens if HCG doubles after 48 hours? What does it indicate? Late developing intrauterine pregnancy. If after 48 hours HCG increase but does not double, ectopic pregnancy. If after 48 hours HCG falls, this indicates that abortion has occurred. Fine. So investigation of choice for ectopic pregnancy is transvaginal sonography plus beta HCG correlation. Gold standard is laparoscopy. Then comes management of ectopic. Management of ectopic has been categorized in 3 parts: expectant management, medical management, and surgical management. Expectant management is done. Expectant management is done when beta HCG levels are less than 1000 milli-international units per ml, and best results are if it is less than 200. We are just doing weekly beta HCG estimation till 3 consecutive levels are negative. Our job is done. Medical management, if serum beta HCG more than 1000 but less than 5000 milli-international units per ml, size of ectopic mass less than 3.5 centimeter, cardiac activity, it is absent. Fine. Drug of choice, methotrexate, 50 milligram per meter square by intramuscular injection. How is it given? First day we get done baseline HCG, liver function test, kidney function test, and complete blood count. Second day we give her methotrexate. Then on day 4 and day 7 we check fall of HCG level. If on day 7 fall in HCG level is more than 15% in comparison to day 4, our job is done. Then what we have to do? We have to just weekly monitor HCG till 3 consecutive reports are negative. If fall is less than 15%, we repeat methotrexate. This is how many doses of methotrexate can be repeated? 3 doses of methotrexate can be repeated. After third dose, we don't repeat methotrexate, we do surgery. Fine. Then, what is the surgical indication? If beta HCG levels are more than 5000 milli-international units per minute, size of ectopic more than 3.5 to 4 centimeter, if cardiac activity is present, or if there is no response to medical management, then surgery. Now question arises, which surgery should be done? If nothing is written in your MCQ, that she is hemodynamically unstable or shock or ruptured ectopic, if nothing is written, we have to choose, we will consider she is stable. So laparoscopy. In laparoscopy, which one? Linear salping ghostomy. Ostomy means we will not suture incision site. How and why, we discussed everything in detail. So laparoscopy, linear salpingostomy. If she is hemodynamically unstable, means ectopic has ruptured, or examiner used the word shock, then laparotomy. In laparotomy, which surgery? Salpin. Everything is in your register right in front of your eyes right now. Salpingectomy. What is common to both laparoscopy and laparotomy? In both the surgeries, whether ectopic is ruptured or not ruptured, ovaries are not removed. What are not removed? Ovaries are not removed. If it is unruptured ectopic, linear salpingostomy. Important MCQ zone beta, important. And if it is ruptured ectopic pregnancy, salpingectomy. In either of the things, ovaries are not taken out. Fine beta. This is how we manage ectopic pregnancy. What is Danforth sign? Danforth sign is seen in ruptured ectopic pregnancy. It is referred pain in shoulder. If there is massive hemoperitoneum, ruptured ectopic, massive hemoperitoneum, so diaphragm is, this blood irritates diaphragm and pain is referred to shoulder. That is called Danforth sign. Now there is a word called heterotopic pregnancy. Heterotopic pregnancy, pregnancy inside uterus as well as outside uterus. This is heterotopic pregnancy. Very rare, 1 in 3000 now. What is the management? We have to do salpingectomy here. In heterotopic, we have to do salpingectomy, of course, with curettage. Then, after heterotopic pregnancy, three criteria we have to remember, three names we have to remember. These are Studyford criteria, Spigelberg criteria, Rubin or Pullman criteria. Studyford criteria is for primary abdominal pregnancy. Spigelberg criteria is for primary ovarian pregnancy. Rubin and Pullman criteria for primary cervical pregnancy. Fine. Few things we will remember with chanting round, the last round, the chanting round, when you will remember whole OBJ. This is why I'm advising utilize these 3 days completely to revise whole of gynae. We will be solving all the 50 questions in question paper. So don't waste any time. Everything has been planned systematically. Test on 26. After that, test and discussion, then clinical case discussion, chanting session with image. But my sessions will not be big sessions. I will take a small session in 2 hours, 3 hours. I will try to give a lot, whatever I can try. So, and by that time, actually, you will remember everything. No, you are revising obs gynae. 3 days, revise obs gynae, revise obs gynae, revise obs gynae. We have to solve all the 50 questions in question paper. Today, no talk, no joke, nothing. Tomorrow, 6 p.m. YouTube live session, 25 important questions. Those 25 questions will be absolutely different from test and discussion questions. They will be totally different questions. And tomorrow in that session, I will be telling how to score maximum marks on 12th December exam and how to get the maximum output of whatever we have studied in last few months. That is my today's session or tomorrow's session, 6 p.m. Fine. And those 25 questions will be totally different from that, and try to attempt those questions so that you can see whether you are able to answer that or not. That's different story. Fine. So ectopic, 3 criteria we are done. After ectopic, let's discuss abortion. Abortion, what is the definition of abortion? Definition of abortion, death of fetus before the age of viability. Before the age of viability. After the age of viability, it is called intrauterine fetal demise. Now there are 3 classifications of abortion. One is ultrasound based qualification, other one is according to episodes, third one is clinical classification. Ultrasound classification of abortion is, I will show you because it needs the images. Ultrasound classification, blighted ovum or missed abortion. Blighted ovum means only gestational sac developed. No yolk sac, no fetus developed. So when you call it blighted ovum, this is your MCQ. When how much is the mean sac diameter and there is nothing inside, then you call it blighted ovum, 25 mm. This is your MCQ. If mean sac diameter is either 25 millimeter or more than 25 millimeter and gestational sac is empty, this is called blighted ovum. Missed abortion, embryo developed, but there is no heartbeat in it. Then when you call it missed abortion, when CRL, crown rump length, is 7 mm or more than 7 mm and no cardiac activity is visualized, this is called missed abortion. So what is the difference in blighted ovum and missed abortion? Blighted ovum is empty gestational sac. It is empty gestational sac. Just have a look here. This is blighted ovum, empty sac. Can you see? Empty sac. It's written here also. This is empty sac. Only gestational sac is seen. No yolk sac or embryo is seen inside. So if it is either 25 mm or more than 25 mm and it is still empty, we call it blighted ovum. Now I will show you missed abortion. In missed abortion, embryo appeared, beta. Embryo appeared. But can you see? There's no cardiac activity. I will show you that image where there is no cardiac activity. Can you see here? This is the gestational sac. This is the first structure visualized in ultrasound. Then second structure which is visualized in ultrasound is a yolk sac. Then third structure which is visualized in ultrasound is the embryo. But can you see we are doing a BM mode ultrasound. In this BM mode ultrasound, our cursor is passing through fetal heart. And can you see a flat line here? flat line. I'll show you with color. This is a flat line. Flat line means heartbeat is absent. This is missed abortion. Embryo is present, but CRL is 7 mm or more than 7 mm and heartbeat is absent. This is missed abortion. How to see a normal heartbeat and how a normal heartbeat look like if there is no abortion, if fetus is alive. If fetus is alive and we are doing ultrasound, see how does it look like. Our ultrasound cursor, it is passing through fetal heart. Can you see this is the heart? And you can see this is how it looks like. It is not a flat line. So this is a live fetus. This is a live fetus, beta. And this is abortion has occurred. So our MCQ, beta, our MCQ 17 days before exam, only two line talk 17 days before exam. Blighted ovum, 25 mm or more than 25 mm, still empty, blighted. Missed abortion, embryo present but CRL 7 mm or more than 7 mm, cardiac activity is absent. This is missed abortion. So this was about ultrasound classification. This was about ultrasound classification. Then there is another classification, beta, another classification of abortion, episode based. Isolated or single episode, odd, recurrent or habitual abortion. Recurrent or habitual abortion is if there is history of 3 or more than 3 abortion. If there is history, we will finish our class at 4 o'clock. We'll cover whatever we can cover till 4 o'clock and then utilize these 2 days in revising obs and gynae. I'm telling you repeatedly, there will be very fair number of questions from obs gynae on 12th December. So revise, we will finish our class at 4 o'clock and whatever portion, I'm covering the things in the sequence, whatever I feel important. So intentionally, I have chosen the chapters in such a way. And I have chosen gynae because on 12th December, I'm expecting more from gynae. So whatever is remaining after 4 o'clock, intentionally, we will cover it on the day of test and discussion. I will revise just in 45 minutes to 1 hour on the day of test and discussion. Fine. So we'll finish till 4 o'clock. Fine. So abortion, isolated, single episode, recurrent or habitual if there is history of 3 or more than 3 abortion. Fine. So most common abortion, isolated abortion, single episode. What is the most common cause of these? Chromosomal. Most common chromosomal, aneuploidy. Which aneuploidy? Trisomy. But trisomy 16 is responsible, but there are various types of trisomy. Monosomy X is more common than trisomy 16. If you have to choose between trisomy and monosomy X, trisomy is the correct answer. If type of trisomy is given, that is trisomy 16. Trisomy 16 has 16% incidence. Monosomy X has 20% incidence. So most common cause is chromosomal aneuploidy trisomy. But if examiner gives you trisomy 16 and monosomy X, then monosomy X is more common. So most common cause of abortion is chromosomal. Most common type is isolated or single episode. Most common timing of abortion is first trimester. And in first trimester, maximum abortions occur till 8 weeks of pregnancy. Everything is written in our notes word by word. Fine. Then, recurrent, how to diagnose these? By karyotyping. Recurrent abortion, most common cause of recurrent abortion. Most common cause of recurrent abortion is cervical incompetent cervix. Either congenitally short cervix or acquired causes like we have done conization, we have done some Fothergill's operation or acquired shortening of cervix. Fine. How to diagnose cervical incompetence? In pregnancy, it is done by ultrasound. Cervical length less than 2.5 centimeter, diameter more than 2 centimeter, or funneling of membrane. That's all. Funneling of membranes. Fine. In non-pregnant state, if you introduce the 8-number Hagar dilator, you can introduce it very easily. Then hysterocervicography can also be done, not for your MCQ. Only ultrasound finding will be asked. Then, how to manage cervical incompetence? Answer is one word answer, McDonald stitches. McDonald stitches. This is also called cervical cerclage. Cervical cerclage. I think this is not written in your notes. This cervical cerclage or McDonald stitches, they are usually applied between 14 to 16 weeks. McDonald stitches, they are applied between 14 to 16 weeks but can be applied up to 24 weeks. Ideally, they are applied. McDonald stitches, they are ideally applied between 14 to 16 weeks, but can be applied up to 24 weeks. Fine. This is the management, cervical circulars operation or McDonald stitches. What happens due to cervical incompetence? Painless dilatation will occur, followed by expulsion of fetus. And most common time of abortion due to cervical incompetence is between 16 to 24 weeks. What is the most common time of abortion due to cervical incompetence? 16 to 24. This is why we want to apply these between 14 to 16 weeks of pregnancy. Fine. Then antiphospholipid antibody syndrome we wrote. Diagnosis by modified Sapporo criteria, management by low molecular weight heparin and low dose aspirin. Torch infections cause only single episode of infection. They don't cause recurrent infection. Then few other causes like hyperprolactinemia, luteal phase defect, thyroid disorder. That's not your MCQ zone. Your MCQ will finish most common cause chromosomal, most common time first trimester, then important topic is cervical incompetence. Fine. Then clinical classification of abortion. Clinical classification of abortion: threatened abortion, inevitable, incomplete, missed abortion. There is one more, complete abortion, which we didn't write, I know. So it's nothing actually. What is threatened abortion? There is a threat. So how will you get your question? Threatened abortion. She will come with spotting, history of spotting. Doctor Sahab, I had mild bleeding, mild bleeding. Then you do a abdominal examination, you do a PV examination. PV examination, internal os is closed. Abdominal examination, fundal height will be equal to period of amenorrhea. And if you do an ultrasound, it is a live fetus. So this is threatened abortion. Then inevitable abortion. Inevitable means unavoidable. Inevitable abortion. When you say it, inevitable abortion, fetus is in process of expulsion. Fetus is in process of expulsion. How things are happening then? If you do a PV, she will come with pain and bleeding PV. Pain and bleeding PV. PV, internal os is open. It's written in our notes. You can see in front of your eyes. They are your notes are in front of your eyes. You can see PV, internal os is open. Abdominal examination, fundal height is either equal to or less than period of amenorrhea. Fine. Management is suction evacuation. And if gestational age is more than 12 weeks, we add oxytocin. Incomplete abortion. Abortion has occurred, but some pieces are retained inside. So she will come with pain, bleeding PV, and history of expulsion of products of conception. She will say, Doctor, I have passed pieces. This is incomplete. Abdominal examination, of course, fundal height is less than period of amenorrhea. PV, internal os is open. Management, suction evacuation. What is the difference between inevitable abortion and incomplete abortion? If it is incomplete abortion, she will definitely give history of expulsion of products of conception. Fine, beta. Then, missed abortion. Missed abortion is she has missed it. She is coming to you for routine checkup. 4 months pregnancy, doctor, please write medicine. You do an abdominal examination, fundal height less than period of amenorrhea because fetus died much earlier. PV, internal os is closed. This is why it is missed. Management is dilatation and evacuation. Complete abortion, we didn't write it, nothing to write in it. Complete abortion means abortion has occurred. And uterus is empty. Everything has been expelled out. You will just reassure her. Then MTP. Medical termination of pregnancy. There is the MTP Act. MTP Act. According to old Act was passed in August 1971, became effective in April 1972. According to old Act, MTP could be done up to 20 weeks of pregnancy. Up to 12 weeks of pregnancy, opinion of one doctor was enough. But between 12 to 20 weeks, opinion of 2 doctors required. Procedure can be performed by one doctor. This was old Act. Eligibility, who can do? Gynecologist, MS or DGO, or any MBBS doctor with experience certificate of assisting 25 cases. Out of those 25, 5 cases should have been performed independently. Then, registration, license for MTP is given by CMO of the district chief medical officer. Who should be licensed? Both place and person should be registered or licensed. Consent, if her age is 18 or more, herself can give. Less than 18, consent of guardian. Important catch, consent of husband is not required. Fine. What are the indications? Then amendment of this MTP Act. According to latest amendment, MTP can be done up to 24 weeks. Up to 20 weeks, up to 20 weeks, opinion of one doctor is enough. Between 20 to 24, opinion of two doctors. Procedure can be performed by one. And for gross congenital malformation like anencephaly, there is no age limit for MTP. This is the amendment. Indications of MTP: if fetus has died, abortion has occurred, or if there are gross congenital malformations which are incompatible with continuation of pregnancy. Similarly, maternal diseases which are incompatible with continuation of pregnancy, like malignant hypertension, severe chronic renal disease, schizophrenia, history of rubella infection, or radiation exposure more than 5 rats. Fine. If she says, I am from low socioeconomic class, I can't afford. If she says, I was taking contraceptive, there is a contraceptive failure, or if pregnancy is due to rape. In cases of rape, important MCQ, no FIR is required. All secrecy has to be maintained. So there are indications of MTP. Then methods of MTP in first trimester and in second trimester. In first trimester, two important questions, beta. Most common method of MTP in first trimester is medical abortion. Most common is medical abortion. Let's discuss it. In India or developing countries, it is done up to 7 weeks. Western world up to 9 weeks. Fine. What is the protocol? On day 1, tablet mifepristone 200 mg is given. After 48 hours, it depends, up to 7 weeks, or you are dealing between 7 to 9. If you are dealing up to 7 weeks, 400 microgram misoprostol orally or vaginally. If you are dealing between 7 to 9 weeks, 800 microgram misoprostol only vaginally. And then we review her after 1 week. Abortion usually occur in 1 week. If some products are inside, suction evacuation is done. That is the medical abortion protocol. So most common method of MTP in first trimester is medical abortion. Second MCQ beta. Best method of MTP in first trimester. Best method of MTP in first trimester is suction evacuation. I will show you the images. Suction evacuation images required. It is done with Carmen's cannula. Let's listen, then I will show you. It is done with the help of Carmen's cannula. Carmen's cannula is a plastic cannula. It has opening. Then there are very important MCQs with Carmen cannula. Number of Carmen cannula correspond to diameter of cannula in millimeter. And this also corresponds to gestational age in week. Suppose we are doing MTP for 8 weeks pregnancy. So which number Carmen cannula will be used? 8 number will be used. And how much is the diameter of 8 number Carmen cannula? It is 8 millimeter. So these three MCQs. Number of Carmen cannula correspond to diameter of Carmen cannula in millimeter, which also correspond to gestational age in weeks. Then this Carmen's cannula is put inside uterus and attached to suction machine. Another important MCQ. How much is the suction pressure? 400 to 600 millimeter of mercury. Best answer is 600. Now, the suction is on and we rotate it by 360 degree inside. So products can be sucked from all around. How do you come to know whether uterus has become empty? Indicators of emptying. Gripping of cannula, air bubbles in cannula, and grating noise. Complication. Most common complication of suction evacuation, excessive bleeding. Fine? Bleeding. Rare complication is perforation. Now in perforation, 2 need PG question. If perforation occurs while dilating cervix, management is wait and watch. It will seal, momentum will come and seal it. Second question. If uterine perforation occurs while the suction is on, then what may happen? Immediately stop the procedure and do a laparotomy. Otherwise, maternal intestines will enter uterus. So most common complication of suction evacuation is bleeding. So we are done with 2 MCQs. Most common method of MTP in first trimester is medical abortion. Best method of MTP in first trimester is suction evacuation. Now, three other methods of MTP in first trimester: menstrual regulation, manual vacuum aspiration, and dilatation and curettage. Menstrual regulation, it is done with MR syringe, menstrual regulation syringe. I will show you. It is a 50 cc syringe, and this about here images are required. I will show you. It is done up to 7 weeks of pregnancy. Then manual vacuum aspiration. It is done with manual vacuum aspiration syringe. It is a 60 cc syringe. Pressure generated is 660 millimeter of mercury, and the procedure is done up to 12 weeks of pregnancy. Let me show you these images first. Second trimester MTP, only two lines. Only two lines, then I will show you the image. Second trimester MTP, best drugs used are prostaglandin. What are the best? Prostaglandin. PGE2 dinoproston is the best one. Other things are intraamniotic instillation of urea saline, extraamniotic instillation of ethacridine lactate. That is not your MCQ. Let me show you these images. These are important. This is Carmen's cannula. This is Carmen's cannula. Important image. I will show you in image session also with chanting and CCD. This is Carmen's cannula. And how this procedure is performed. Look here. This is how this suction evacuation procedure is performed. You can see this cannula is right inside and it is rotated and moved in and out so that products can be sucked from all around. This is how we use it. So suction evacuation, only image asked maybe Carmen's cannula, and those three MCQs and suction pressure are very, very important. This is the suction machine. You know very well, this is the suction machine to which our suction cannula, Carmen's cannula is attached. Then now I will show you menstrual regulation syringe. This is the menstrual regulation syringe, MR syringe kit. This is menstrual, these are important. I will show you manual vaccination syringe also. This is MR syringe kit, MR syringe kit, 50 cc syringe. This is a 50 cc syringe. You can see one knob here, one valve knob here. Okay, this is menstrual regulation syringe kit. Now I will show you manual vacuum aspiration syringe. It has two. This is the difference in menstrual regulation syringe and manual vacuum aspiration syringe. This is MVA syringe, manual vacuum aspiration syringe. Any significant image? Yeah, you can see that. This is how we apply McDonald stitches. These are McDonald stitches. These McDonald stitches, this is also called cervical cerclage operation. They are applied between 14 to 16 weeks because maximum abortions due to cervical incompetence, they occur between 16 to 24 weeks. Fine. Another picture. Cerclage correction of the cervix. Cerclage correction of the cervix. This is how we have applied this here. Fine. So after abortion and MTP, we can just cover an important thing, antepartum hemorrhage, and then rest of the things which are remaining. I remember everything. I know everything. That we'll take on test and discussion day. My sincere request and advice would be that you have to revise whole OBS-gynae register till the test. Please utilize these 3 days completely, fully to revise the register. I am not telling you anything. I am not telling you to read anything else. Please, please, please listen to me very carefully. Don't read anything else. Don't read. People are wasting lot of time in many MCQ books from here and there. It is a mere waste of time. Please listen to me carefully. You have to revise in these 3 days only and only our obscini register. Only our obscini register. Notes only our obscini notes in these 3 days. That's all is required. Rest leave on me. Rest leave everything on me. Just revise this obscini register in these 3 days. Fine. And of course, tomorrow, 25 questions, you will all see what I am doing in that session. That's different story. But please, 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 in these 3 days, only obscini notes whatever we have made. That's all. Last topic today, antepartum hemorrhage, placenta previa and abruptio placentae. Antepartum hemorrhage. Definition of antepartum hemorrhage: bleeding per vaginum or into the genital tract after the age of viability. After the age of viability. Fine. Most common cause of antepartum hemorrhage is abruptio placentae. Most common cause of antepartum hemorrhage is abruptio placentae. What are other causes of antepartum hemorrhage? Placenta previa, circumvallate placenta, vasa previa, and local tear, local injuries. Fine. Placenta previa. Placenta previa, low-lying placenta after the age of viability is called placenta previa. Fine. What are the risk factors? Most common risk factor for placenta previa is history of previous placenta previa. Most common cause is history of lower segment cesarean section. Other causes: multifetal pregnancy, history of curettage. Fine. Smoking, multifetal pregnancy. Then, what is the most common symptom in placenta previa? Important MCQ. Nature of bleeding. What is the nature of bleeding? It is recurrent. It is bright red. It is massive, preceded by a small warning hemorrhage. It is painless. It is costless. Very important type of bleeding. How and why this happen, we discussed in great detail in our classes. Then, placenta previa classification was given by Dr. Brown. Type 1 or lateral, low but away from internal os. Type 2 or marginal, reaching up to margin of internal os. Type 3 is incomplete central or partially central. It is covering internal os when internal os is closed. But as soon as os opens, it is not able to cover it. Type 3 or incomplete central or partially central. While type 4 or complete central is, it is covering internal os even when internal os is open. So these are 4 types of placenta previa, and this classification was given by Dr. Brown. Okay. Symptom we have discussed. Then investigation. Best investigation is ultrasound. I will show you images of placenta previa, abruptio. They are important. I will show you. So best diagnosis by ultrasound. What you have to do, you have to just measure the distance. I will show you. Let's discuss this theory, then I will show you. We have to just measure the distance between lower edge of placenta and internal os. So 100% diagnosis is made by ultrasound. Which ultrasound? TVS can be done. It's not harmful. But per vaginal examination in placenta previa is contraindicated. It is contraindicated because of risk of massive bleeding. Then it is done only in double setup operation theatre. How and why we have discussed in great detail in our classes. So PV is contraindicated. If mandatory, it will be done only in double setup operation theatre. Then, how to manage this placenta previa? Management is divided in expectant management and active management. Expectant management regime, important question beta. Expectant management regime was given by whom? McAfee and Johnson. Expectant management means we are continuing pregnancy. So expectant management will be done if pregnancy is less than 37 weeks, one thing. Secondly, if fetus is hemodynamically stable. Third, there are no gross congenital malformations, then only we can continue this pregnancy. Then what has to be done? Bed rest is advised. Steroids are given for pulmonary maturation. If she is Rh negative, anti-D is given. And we are ready with blood grouping and cross matching. If by chance we have to do some active intervention. Then active management is done if gestational age is 37 weeks or more than 37. Or if less than 37, but she is hemodynamically unstable because she may be having massive bleeding. Fine. Or If you have done an ultrasound, she is having gross congenital malformations, then we have to do active intervention. Active intervention, what active intervention? If it is minor degree placenta previa, vaginal delivery can be allowed. If it is major degree placenta previa, only cesarean section has to be done. Minor degree are everything is in front of your eyes in your notes. Type 1 and type 2 anterior. Major degree, type 2 posterior, type 3 and type 4. Fine. What is Stalworthy sign? Stalworthy sign is seen in posterior placenta previa. Type 2 posterior, type 3 and type 4 posterior. What is this? Just everything is in front of you, in front of your eyes, in your notes. If we push the fetal head in pelvis, fetal heart rate drops. As soon as pressure is released, fetal heart rate becomes normal. Fine. Then abruptio placentae. The most common abruptio placentae is premature separation of placenta. Normally, placenta separates after delivery of baby. So, premature separation of placenta, this is abruptio placentae. Now, placenta may be located normally. It's not mandatory that it has to be a low placenta. Premature separation of placenta is abruptio placentae. Most important risk factor for abruptio placentae is history of previous abruption. What is this? History of previous abruption. What are other risk factors? There can be polyhydramnios, which is causing premature rupture of membrane. How and why? We discussed in big details in our classes. Retroplacental uterine fibroid. There can be multifetal pregnancy. Fine. Hypertension. What else? Smoking, deficiency of folic acid, thrombophilia, history of previous abruption. They are all risk factors for abruptio placentae. But most important one is history of previous abruptio placentae. Then, abruption can be of two varieties, concealed and revealed. I will show you the images just after this. Concealed abruption, abruption has occurred, but lower edge of placenta is intact. So retroplacental blood is not coming out. So what is the symptom here? Abdominal pain, no bleeding PV. What can happen if you, what are the signs? If you do abdominal examination, uterus and abdomen is hard and tender. Because of this, fetal parts may not be palpated, and fetal why hard and tender we discussed in big details in classes. And because uterus is hard and tender, fetal parts may not be palpated, fetal heart sound is not auscultated. Fine. So fetal heart sound may be absent. It is not likely that only in fetal death you are not able to hear fetal heart sound. Very, very important MCQ zone. Very, very important. In cases of abruptio placentae also, this is quite possible. Then, this is concealed abruption. What may happen in concealed abruption? If it is a severe concealed abruption, this retroplacental blood in few cases may reach up to serosa of uterus, outer layer of uterus, and uterus will appear bluish red, wine colored uterus, wine colored uterus. This is called covaliar uterus or uteroplacental apoplexy. Second variety, revealed abruption. Third variety, mixed abortion. Revealed abruption, abruption occurs in such a way that lower edge of placenta is also separated, so symptoms are pain and bleeding. Pain and bleeding. Signs will be same, but less in intensity in comparison to concealed. Abdomen, uterus, hard and tender, fetal parts may not be palpated, fetal heart sound may not be auscultated. Third variety is mixed abortion. Overall, most common variety of abruptio placentae is mixed variety. Most common cause of antepartum hemorrhage, abruptio placentae. Most common variety of abruptio placentae is mixed abruption. Fine. Then, investigation, ultrasound is not 100% conclusive. So, it is a combination of clinical assessment and ultrasound. So, this is how investigation is done. Then, management of abruptio placentae. Immediate induction of labor, very important MCQ zone, very important. Management of abruptio placentae, immediate induction of labor, irrespective of gestational age, due to risk of DIC. Second question, beta, here only, read the question very, very carefully. Second question here. If DIC has developed in abruptio placentae, what is the next step? If DIC has already set in, treat DIC first and then induce labor. Treat DIC first by fresh frozen plasma and all, and then induce labor. There's a classification. You have to remember only one word. Which classification is used for abruptio placentae? Page classification. I've tried my best to speak word by word because whatever I have told you for this December exam, and then I'll show you few images. Placenta previa, you can see this is the placenta previa. These are the four types of placenta previa. Type 1 or lateral placenta previa, where you can see placenta is low, but this is far away from internal os. This is reaching up to this place only. Type 1 placenta previa, low but away from internal os. Type 2, it is reaching up to margin of internal os. Type 3 and type 4 we have discussed in much better way from these images. Then ultrasound. This is a normally located placenta. This is not. This placenta is finishing here, and this is the level of internal os. So the distance here is obviously more than 2 centimeters. This is a normal, perfectly normal placenta. So ultrasound is 100% diagnostic for placenta previa because you have to do nothing. You have to just measure the difference. Oh my God, this is a severe placenta previa. You can see this placenta is reaching up to this place, and this is the level of internal os. So ultrasound is 100% conclusive to diagnose placenta previa because you have to do nothing. You have to just measure the distance between lower edge of placenta and internal os. This is anterior placenta previa. That was the posterior one, and this is the anterior placenta previa. As you can see, this placenta is coming up to this place, and this is the level of internal os. So this is anterior placenta previa. This is posterior placenta previa, and this is a normally located placenta. As you can see, the distance between lower edge of placenta and internal os is quite normal. Fine. Then images related to abruptio placentae. Look here. Abruptio placentae, what you have to see. Difference in concealed abruption and revealed abruption. As you can see, this is the concealed abruption. Concealed abruption, you can see nothing is coming out. This is concealed. Everything is collected here only because lower edge of placenta has not been separated. While revealed abruption, you can see this blood is coming out because the passage is open. Passage is open. This is revealed abruption. But the most common variety of abruptio placentae is mixed variety. Mixed abruption. What is this? This is covaliar uterus. And what's the other name of covaliar uterus? Other name of covaliar uterus is uteroplacental apoplexy. What is this covaliar uterus? Wine-colored uterus. It is seen in concealed abruptio placentae. It is seen in which abruptio placentae, beta? It is seen in concealed abruptio placentae. And how to score maximum marks on 12th of December and how to utilize maximum output of whatever we have studied in last few months. I will speak at 6 p.m. tomorrow in YouTube live session with of course 25 important obsgyne questions which are different from test and discussion. Fine. So these were the images which were required for this, and wish you all the very best for test. Wish you all the very best for test. I won't take much of the time today. Whatever I have to speak, I will speak at 6 p.m. tomorrow. Just my sincere advice, मेरे प्यारे बच्चों, my loving student, utilize these 3 days in revising your obsgyne notes from our obsgyne register only. If you are solving questions from here and there, from this book or from this app or from this thing or this thing, I don't want to say anything. I just want to say only one thing. Please stick to our class notes, class notes, class notes. Rest leave on me. MCQs on Telegram group daily I am posting from various subjects also. They are our faculty MCQs only. I'm posting at 9 p.m. and the medicine, surgery, patho, various MCQs, they are our faculty MCQs. What I feel important for our exam. So I'm solve those MCQs and restrict to our test and discussion sessions, restrict to our mock test, and don't waste your energy here and there. Please, please, please. Opskyny only and only our class notes, our Telegram MCQs, our test and discussion MCQs, our mock test MCQs, and our YouTube live 25 questions. That's enough. Wish you all the very best for Opskyny test. Thank you.